Good morning all. Can you hear me loud and clear? Hands up like you just don't care, right? Yep. Full attention, love it. Caffeinated, excellent. Well, welcome everyone to yet another 2025 annual immunisation update. So please welcome Uncle Neil Ingram to deliver our welcome to country.
Welcome and welcome. For those who don't know me, my name is Neil Ingram Senior. I'm a proud senior radiologist. I would also like to thank Alison Sullivan for the kind invitation to perform welcome here today. First of all, I would like to show my respect and acknowledge the traditional owners of the land on which we stand, the Wiradjuri people, for their continual connection to the land, waters and community. I acknowledge our elders, past and present, for their culture, knowledge and wisdom, and I acknowledge the sorrow and pain suffered by members of the stolen generation. I too am a survivor. Wiradjuri country is known as the lands of the mountain plains and the three rivers. These rivers are the Womble, the Dubbo, the Galari, the Forbes, and the Murrumbidgee, the Wagga Wagga. These rivers are important to us, and they are essential to the social and spiritual needs of the Wiradjuri people to sustain all parts of our sacred landscape. The three mountains form the songlines of my three brothers' story, and we need to protect our sacred songline from any further destruction. These mountains are Walu, Mount Panorama, Garnabulla, Mount Canobblas, Goombul Nilyana, Mount Macquarie. Wiradjuri country is one of the largest nations in New South Wales. It begins west of the Great Dividing Range and our southern boundary, the Millewa, or the Great Murray River, the Albury. On behalf of the Wiradjuri people, welcome to country, welcome in language. Yunay Galambu, Gabi Bangbu, Boy Galambu, Guambana Du Nigel Gear, Wiradjuri Gu, Nurabangu. Welcome to Wiradjuri, welcome to country, Mandang Guwu, thank you. I hope you enjoy the rest of the day. It's such a very large gathering here today, obviously from all different sectors. I'll leave you with this little quote. A poet once said, "There are no strangers here, only friends we haven't yet met." Take the time to greet and meet people sitting next to you. Enjoy the rest of your day. Thank you very much.
Thank you so much, Uncle Neil. As always, an extremely warm welcome. So as many of you, I'm sure know, all too well, this annual conference is a result of a long-standing partnership between the Western New South Wales Primary Health Network, Western New South Wales Local Health District Public Health Unit, and the National Centre for Immunisation Research and Surveillance, or as I've become very familiar now, NCIRS. NCIRS? So even I got it wrong for the third time, goodness me. Keep prodding me, it's all right. Okay, so the goal of our partnership is to bring together immunisation providers from a diverse range of health settings across Western New South Wales, to enjoy a day of learning, networking together. So thank you very much for being here again with us today. Now we do welcome, of course, a great lineup of presenters to deliver today's program. So we are pleased to have Victor Carey. Hands up. I might get some hands up if you can. Victor. He was here. Priscilla Stanley. Thank you, Priscilla. Belinda Tracy. There we go, very familiar. Wendy Holmes. Thank you. Alice Gordon. We're there. Kim Rice. Thank you, Kim. Fiona Quinn. And Kendall Ball. All here. Excellent. Thank you for joining us from the Western New South Wales Local Health District, PHU. We are also privileged to welcome back Dr. Archana Coriella from NCS. This year we are also fortunate to add 2 new faces to the presenter lineup, including Dee Brogan. Thank you, Dee. From NCS, and Professor Julie, I've got that Leask? There you go, Julie, on the other side of the room. Thank you very much. Also from the School of Public Health, University of Sydney. So before we get into it, just some housekeeping. Before we begin, so a copy of today's agenda you should have on the table, full presenter bios. Now we do have Slido and evaluation QR codes on each table too for participation throughout the day. A copy of the presentation slides will be shared with participants early next week. Now facilities with bathrooms, so we have the 2 areas for bathrooms just up to my right here in the far corner, turn left. There's one set of bathrooms and there's also another set to my left here. There's emergency exits as well, either side, follow the green signs, and phones if they could be on mute too. Now in the event there isn't a fire alarm, please stay put and we'll have a marshal come and take us through those exits. So breaks will be at 10:15 a.m. for morning tea and 1:10 p.m. for lunch. Now, as mentioned, Slido will be in action today to help us navigate audience questions and to participate in activities. So please visit so there's an audience Q&A tab to enter questions during the day. You can also like other questions, which will elevate their priority in the queue. So questions will be collated and presented during 2 Q&A sessions later this afternoon. And if all questions cannot be answered, we'll take them on notice. Now you can also, during some of the panel sessions, you can also raise your hand and wait for a microphone. We'll have a couple of people roaming with some microphone so you can ask your question. Okay, so moving on with some of the presenters. So first up, I'd like to please welcome to the lectern Katie Pryor, Acting Executive Manager of Primary Healthcare Integration and Reform, to deliver the opening address. Thank you, Katie.
Thank you so much, Brenton. Also, thank you to Uncle Neil, who's just left. It was a wonderful welcome. So thank you, everybody, for taking your time to be here today at the Western New South Wales Primary Health Network's 2025 Annual Immunisation Conference. It's so wonderful to see lots of familiar faces back again. A year always goes by so fast, but it's wonderful to have you all here. On behalf of the Western New South Wales PHN and all presenters with us today, I'd like to pay our respects to the Wiradjuri people on whose lands we meet today. I'd like to acknowledge all Aboriginal and Torres Strait Islanders as the traditional custodians of the land, waters and communities in which we work and live. Western New South Wales Primary Health Network has a strong commitment to building relationships, respect and opportunities with all Aboriginal nations in our region. We pay our respects to Elders past and present and extend that respect to all First Nations people here today. We also want to acknowledge that this gathering is happening during National Reconciliation Week. This week represents an important opportunity for us to listen, learn, connect, and build stronger relationships within our community. In this year's theme artwork, created by Kalkadoon woman Bree Button-Shaw, the native plants, which are known for regenerating after fire and thriving through adversity, symbolise our collective strength and the possibilities of renewal. This is a time for growth, reflection, and commitment to walking together. It is my absolute pleasure to be here with you today. I've been here at many immunisation conferences before, and I'm really proud to lead the team that delivered this. On behalf of the Western New South Wales Primary Health Network, along with the Western New South Wales Local Health District and the National Centre for Immunisation Research and Surveillance, we welcome you today. This is a collaborative effort that we all work on together. Brenton's already introduced all the speakers, so I won't do that again, but it's so wonderful to have you here and to work together on this. We would also like to acknowledge the wonderful support of the Orange X Services Club for their catering and venue here today. We also like to thank Colton, who help us with all the tech support and AV support, and it's wonderful that we don't have to worry about that, so thank you so much, Colton. And we also thank you all for being here as well. We know that immunisation is one of the best ways we can protect ourselves, our families, and our loved ones and future generations from infectious diseases. Even as recently as the 1950s, thousands of children were dying each year from diseases such as tetanus, diphtheria, whooping cough. Immunisation is the most effective medical intervention we have to prevent deaths and reduce disease in our communities. We now have vaccines to prevent many life-threatening diseases, helping people from all ages and all cultures live longer, healthier lives. Immunisation currently prevents 3.5 to 5 million deaths every year from diseases. And I'm probably jumping the gun here because I know the team will talk about this, but our Western region continues to hold high vaccination rates. The most recent coverage rates in December 24 shows the incredible work of each and every one of you here today. Together, we can proudly say that our region has the highest coverage rates for 5-year-olds at 96.25% and for Aboriginal children at 97.8%. Absolutely. But we all know too, within this landscape, there are many challenges. There are concerning trends showing declines in vaccination rates. And this drop reflects a decline in community confidence in vaccines and the health system. Misinformation and disinformation campaigns continue to present challenges for all of us. More specialised information and support for health professionals with diverse views is needed. The re-emergence of vaccine-preventable diseases such as measles and diphtheria can result from changes in vaccine coverage globally. So it's wonderful to see you all here with your passion for vaccination. The Towards a National Immunisation Strategy 2025 to 2030 consultation paper outlines 6 priority areas, including increasing coverage, engaging the community to improve awareness and acceptance, strength and governance, using data to improve outcomes, and attracting a diverse workforce and preparing for emerging infectious diseases and emergency. Our program today, led by a wonderful team of subject matter experts, will include local immunisation coverage rates, Aboriginal childhood immunisation rates, an update on respiratory diseases including COVID, pneumococcal, influenza and RSV, managing immune-compromised patients, anaphylaxis, and doing the basics well, and building trust in the vaccination space and more. Before we start, I would once again like to thank you all for your commitment to your communities and your people, and your dedication to improving health outcomes. Our health is our greatest asset, and it is because of all of us that we are able to continue to improve the health and well-being of our communities and keep them safe and protected. Our team here at the Western PHN are here to support you as together we can continue to break down barriers for our most vulnerable people and lead by example for others in our community. Thank you so much for being here and enjoy your day. Thank you.
Thank you, Katie, for that warm introduction. Now, given we're 5 minutes ahead of schedule, I'll take this opportunity. I didn't officially introduce myself, so for those that don't know me, my name is Brenton Jones. When I'm not emceeing at events such as this for the PHN, my normal day job is Manager of Digital Health at the Western New South Wales PHN. So a very quick shameless plug. If you haven't heard, I also run a podcast for frontline health workers like yourselves on everything digital health literacy. You can tune in via our website or your streaming channels called Let's Get Literal. If you haven't heard enough of my voice, you can certainly get more of it online. So if you wanted to learn more about digital health, but I know you all here are experts when it comes to PRODA and AIR, aren't you? Yeah. Got no questions for me? No? Exactly. So you're experts. So, but if you want to learn something more about what's happening, the future of my health record, etc., please feel free to tune in. Or if you want to be interviewed, don't be shy. It's a very casual chin wag, so feel free to tap me on the shoulder. So before I introduce our first speaker for today, I have been told that this year we need to stick to schedule. So we've extended our budget. We've borrowed my wife's laminating machine. She's a primary school teacher, so she's got plenty of stock. And we produced these little cards. So speakers, if you see me standing over there, flashing one of these cards, it's a reminder you got 5 minutes to go, 1 minute to go, halfway, or 10 minutes to go, right? No pressure. Okay, without further ado, so I'd like to please welcome to the lectern Priscilla Stanley, Director of Public Health, Western Health Local Health District, to present on the local immunisation coverage rates and public health unit update. Thank you, Priscilla.
Thank you very much. I will start by acknowledging the traditional custodians on the land on which we're all gathering here today and pay my respects to Aboriginal people past and present, and those wonderful Aboriginal and Torres Strait Islander staff that we have a privilege to have in our teams. And I also want to thank the PHN for continuing the collaboration with us at the Public Health Unit, or PHU, we'll refer to ourselves as. And it's an absolute privilege that we get. I think I've got 15 minutes, and I'm either going to look straight at you, Brenton, or just look that way and ignore my 15 minutes. Okay. Because anyone who does know me knows that I have a tendency to talk. I've brought my phone up here that has the time, and I think I've got an extra 3 minutes because we are ahead of schedule. But hopefully I don't need my 15 minutes. I tend to go a little bit rogue, so that's probably where I'll look to my team to say, yeah, bring it back in. I missed last year's conference. I meant to go through my calendar to see where I was, but I can't remember what I was doing. No, I didn't come to Orange. It would have been a kid thing, I'm sure. But anyway, I'm so glad I'm back and I can see some familiar faces, which is wonderful, but I think there might be some newbies in the audience. Are the newbies confident enough to pop up your hand? Who's first year? Oh, wow, welcome. Oh, that's great. And I'm not going to go through the 5 years, 10, 20... But is there anyone that's been here for more than, let's go 25 years? Oh, yay, big round of applause. 25 plus years, that is impressive. Wow. Well, we could all probably learn a lot from you. You should be up here speaking. We've got a great lineup today. I have to admit, I feel a little nervous because Julie's in the audience, and Julie, I sort of fangirl quite a lot. Julie, okay, time, okay. I'm going to go through, I didn't want to go through all our Public Health Unit strategic priorities because those of you who know what the Public Health Unit do, which I hope is everyone, is there anyone who's never spoken to someone in the Public Health Unit? Oh, yay. Because we all do like to talk. I think I lead by example. If you haven't met any of the team, please come and say hi, and questions, we're always open to have questions at any time. So what we'll do is go through this presentation. I've actually taken the, I can look down here, our strategic priorities are basically New South Wales strategic priorities when it comes to immunisation. So, and I want to thank whoever took these beautiful photos. It wasn't me. I found the slides, and so acknowledge whoever the wonderful photographer is. If you're in the audience, thank you. They were on some slides I had in my drive, so I just used them. So the New South Wales Immunisation Strategy 2024 to 2028 has outlines six key areas. But as we all know, population-wide immunisation programs are one of the most effective and cost-efficient public health measures to prevent disease. It is estimated that immunisation programs prevent somewhere between 3.5 to 5 million deaths globally each year. I mean, just let that sink in. That's pretty incredible. And then reflecting on what we do in our district and how we're contributing to that. So the New South Wales immunisation program is a population-wide program, and it aims to minimise the incidence and prevalence of vaccine-preventable diseases. So immunisation programs has led to dramatic reductions and almost eliminations of some, and the severity of some or many VPDs. So diphtheria, measles, polio, tetanus, meningitis, Hib. Infants and children, as you're all well aware, have very naive immune systems, so our New South Wales childhood immunisation coverage is incredibly important to have that as high as we possibly can, and we have great coverage rates in Western New South Wales. But what's concerning, and what we'll highlight in a couple of slides, is the geographic variations across our district, across New South Wales, but particularly across our district, where we have a particularly large district, but those geographic variations are quite concerning. We have quite low influenza vaccination uptake in children, and that's a concern. It's a particular concern this year, given that it's predicted to have quite a severe flu season. So we really want to encourage, and I'll use that as a message to vaccinate kids, get that influenza vaccine into our children, particularly our Aboriginal children. Looking at our adolescents and the young adults, so we have our school vaccination program that's used to boost immunity and protect against some vaccine-preventable diseases. So in Year 7, those who aren't familiar with the vaccine program, school program, Year 7 and Year 10, and they're funded vaccines. And there's also adults who are recommended a number of vaccines on the NIP vaccines. So just going through each of these points, so we're aiming to embed immunisation into routine healthcare. So make immunisation just a good clinical care. So the idea of opportunistic vaccination, let's change the rhetoric and make it good clinical care. Enhance community awareness and understanding of immunisation. Sometimes that's really hard when we know, and we do this every day. It's sometimes really hard to appreciate that there's a lot of people out in our community that don't know, have been fed misinformation, and it's our job, with the expertise we all have, to provide the accurate information. Looking at our workforce capacity to support immunisation, which I think we're doing a pretty fine job looking at the size and number of people in this room. But of course, it's always wonderful to welcome new people into the immunisation world and encourage them and all clinicians to be providing immunisations to our cohort, our population. Using data to better drive performance, improve outcomes and address inequalities, which we'll go through some data in a second. Optimise the use of digital systems to support programs. So Brenton's already mentioned Proda and AIR. Don't come to me for questions on Proda and AIR. I have no idea how to access it. Maybe I should go and I'll have a chat. Anyway, I don't need to, because I've got a wonderful team that do it for me. And finally, prepare to adopt and implement new vaccines. So most of you in this room, just looking around the room, would have all been working during the pandemic, and that's where we saw and we rapidly adopted and implemented a new vaccine that we were actually only talking about in the car on the way here, so I've travelled from Dubbo. The vaccine saved lives. There's some coverage targets that we have been set that we need to or want to or must achieve, and there's the stretch targets that accompany that. So this is available online. I won't go through each and every one of them, but let's get into where are we. Now, I did go through my slides this morning and I have a feeling some are a bit out of order, but that's okay, we'll work with it. Time check. Okay. Everyone's familiar with our footprint, that stretch down there, so you can see all the nice colours, yellow through to green. The greener it is, the better it is, just so you know. So you can see up in that northwest neck of the woods, the yellow is, we need to do some more work, and there is that little spot down in the south of our district, which that would be Cowra. I am pretty sure. I probably should have put some names on it, but hopefully your geography. Should I test everyone on their geography? Is that what we're here for? Most of you are coming from this more eastern part of the district, so which is looking good as far as our kids with the Indigenous and non-Indigenous coverage rates. So we exceed both the state and national coverage, which is really pleasing. There's obviously, you can see there the difference between our Indigenous and non-Indigenous kids though. So it'd be great to bring them up in line with each other, if not seeing the Indigenous kids exceed non-Indigenous. So that's our 1-year-olds, here's our 2-year-olds. 2-year-olds is where those who are involved in childhood vaccinations, you do struggle to have coverage, but again we do exceed state and national, but there's a lot more yellow creeping in there, which is where we need to do a little bit more work, again up in that northwest of our district. So it's not looking too bad. I don't want to go through and name all the LGAs where they're below target, but I think it's really obvious from that slide, and hopefully you can recognise which LGA you're from. 5-year-olds, it's looking a little bit better, particularly with our Indigenous kids. And here we do exceed with the Indigenous kids, the non-Indigenous, which is really great. So we've got our young ones heading off to school with pretty good vaccination coverage. Moving on to our kids that receive Men B. Again, there's some work that needs to be done in this space. So, yeah, the yellow tinge to a brownie is all the LGAs where we need to really focus some attention on vaccinating our Indigenous kids for Men B. Moving on to influenza. So this is the kids, 6 months to 5 years. This really poorly labelled, and that's because I did this in a hurry. So this is our data. The graph shows the data for so far this year, and I pulled this only last week. So we've only just gone above the 30% so far this year. Last year, for the entire year, we only vaccinated 31.93% of our 6 months to 5 year cohort. So be great to see that higher. So next year, there's a goal for you all. I'll write myself a note. So this time next year, let's get it above the 31 or 32. Let's say above 32, if not above 50, it'd be, let's stretch ourselves and get our kids vaccinated for flu this year. It does go to school, but I don't quite know what I did here, but anyway, I'll just jump to the adults for the influenza over 65s, and we're not doing too badly with our older people. I actually looked at the data yesterday, and from when I pulled this last week to yesterday, the vaccination rates for our older people we're doing really well. We're obviously only in the beginning months of the the season, despite the fact we've seen quite a bit of flu in the normal off-season. But for 2024, the entire flu season, we only got to 64% of our over 65s vaccinated, and it was quite disproportionate between our Aboriginal and non-Aboriginal adults. Just going back to school program, I think I'm doing well with time. This was our 2024 program, so big round of applause to everyone who's worked in the school program. You did a marvellous job last year. Our Year 7 HPV got to 72%, DTPA 72.1. Year 10s were at 64.2. We did see a decline in our school coverage rates last year, and we've made some changes, and I don't want to steal any of my team's thunder. We've made some changes with the approach to the school program this year to try and increase the vaccination coverage. So we've clearly got some room for improvement, but we hope with these little changes that we've made that we'll be able to improve on last year's data. So a sneak peek at what we've done so far this year, or what I haven't, all you have, and you've done a wonderful job. Sneak peek, Year 7 HPV, we've done more so far this year than what we did at the same time last year, so well done. If you feel like you've been busy in the schools, that's because you have been. Same with DTPA for the Year 7s, and the Year 10s, that's where we've said an amazing increase. So getting those Year 10s early in the school year before they start losing interest in attending school, and as you can see, we want to get them when they're excited about being at school, not later in the year when it's like, I want to get out of here. What else are we monitoring? That all the wonderful work that you're doing, and that's the RSV program. So last year, you'd all be aware they implemented Nasivimab, so it was a vulnerable babies program, and across Western New South Wales, there was a total of 682 doses recorded, and so largely we jumped on that program and our vulnerable babies were vaccinated. Come and talk to me or one of my team for more information about that program and the program this year, which has expanded to include maternal, so mums when they're pregnant, and there's been a bit of a grey area with all the some technical questions that you may have needed to reach out to some of the staff to ensure that you're doing the right thing. So this is the babies for 2025 so far this year. The Nasivimab is, we're doing reasonably well with 360 doses recorded and 38% identifying as Aboriginal. And the maternal vaccine, we're also doing reasonably well there, with 732 doses recorded. Anyone who works in maternity, though, would know that with the number of births we have, we need to increase that. And less than 20% identifies Aboriginal, so there's a bit of work in that space. Another really exciting program the Public Health Unit have been lucky enough to get some funding for the next 3 years is a priority population immunisation program. And essentially this is just going to boost the work that we have been doing over the last few years in trying to reach those that don't or find it difficult to access healthcare providers to receive their vaccination. And what we've done so far this year is we've had pop-up clinics in Dubbo for individuals, non-English speaking backgrounds and Aboriginal individuals in town. There's been the homeless, a pop-up clinic at one of the homeless meeting points where they have 1 minute, really? I think I'll finish on time, which is really good. So this priority population immunisation program we want to work with all of you to increase the vaccination coverage across our district, making immunisation a routine part of just that good clinical care. We know that people often say, why don't they just give vaccines while people are coming through the EDs? We know the EDs are incredibly busy and that may not be the best opportunity to vaccinate. So we're working with all our healthcare providers and community groups and our hospitals and anyone who wants us to work with them. And it will be about building that coordinated system and using our data, so using what we've got, which is becoming more and more accessible, and improving that coverage rates. So you will see more next year about our priority population immunisation program and the benefits and the work that we've done or doing this year with all your help. We're really excited about that. We've got some new staff that will be on board that will help in that space. So there might be some new faces that you'll get to meet next year that can come and present on this program. So have a great day, everyone. Ask lots of questions. Come and talk to us in public health, PHN, NCIS. You've got all the expertise in the room here today, so use it. Thanks, everyone.
Thank you so much, Priscilla. Well played on the timing. Excellent work. Just quickly, before I introduce the next speaker, can you raise your hand if you have a spare seat next to you? One. Hey, look at how many there are. There you go, Michelle. Quite a few. And also, if you didn't sign in as you entered this morning before you started, just in the morning tea break at 10:15, if you can go see the lovely ladies at the back there, Erica, hand up, just to sign in officially, that would be lovely. I think they have a special bag for you and stuff, is that right, or something? Yeah, she's nodding. Good. Okay. So please welcome now to the lectern, Kendall Ball, Clinical Nurse Consultant, Immunisation and Nurse Unit Manager, School Vaccination Program, Public Health Unit, Western New South Wales LHD, to present Vaccine Oopsies. I think that's one of the best titles in a presentation I've heard in a while. Doing the basics well. Thank you.
Hello, everybody. How are you today? So for those of you that don't know me, I'm Kendall Ball. I am doing a multitude of different jobs at the moment, but mainly I am the Nurse Unit Manager of the School Vaccination Program, and I'm acting CNC for immunisation. So you might get me on the end of the phone if you ring up with some issues. I've met, I think, most of you in the room, but if you don't know me, come and introduce yourself later on. Also, if you want to come and work in the school program, please come and tap me on the shoulder. Bathurst people especially. Okay, let's do this. So, oh, hang on, which way do I go?
Big green arrow.
Oh, it didn't work. Oh, it went to, it jumped to. Okay, so when I sat down to do this presentation, so at the end of last year's conference, I got a few things sent into the Public Health Unit for applications for vaccine accounts, cold chain breaches and vaccine reactions, and I went, instead of just sitting here telling you what your data logger should be set at, how you should give a needle, anything like that, I thought, pictures speak 1,000 words. So, why do we need to look after vaccines? Vaccines are very gentle souls. They need to be loved in a dark place between 2 and 8 degrees. They're expensive. They're really expensive. The cost of the vaccines that you're giving people is astronomical. Just because they're given for free to the patients doesn't mean somebody's not paying for them. So always think about it. It's always coming out. If the health system's got no money, this is the way we can make it better. Failure to adequately care for vaccines can cost the health system for wasted vaccines, revaccination costs, and inadequate disease control. Failures in the administration of vaccines can also cost the health system and have inadequate disease control, and can worsen vaccine hesitancy. If you give a vaccine wrong to a child, the parent is more likely to not have that child revaccinated. It's not easy to think about the cost of vaccines when you're doing it. So administration errors, we all know that one family who have all of the questions about vaccines and the need for them, and when they should be given. Should they be given one at a time? Should they be given 2 at a time? That's the family you're going to bugger up on. So just be careful. They're the ones that are going to cost you the money. Righto. Disclaimer, all of the following slides are for educational purposes only, but they have come from facilities in our area that were submitted to the PHU. They're all de-identified. If you recognise any of the photos or they're from your place of employment, no one will know unless you tell them. Act surprised. I don't even know which facilities they're from at this point. I just put them in my little storage folder on my computer, so I have no idea. There is no judgment here. Time to act shocked. All right. We should have a roaming microphone at somewhere. Whoops, hello, everybody's got into action up there. You can just yell it out at me. All right, these pictures are from a cold chain breach. So the little form that you send out to us, the cold chain breach form, these were sent to us in late October and early November. What's wrong with this picture? You're supposed to know. Anybody? So, these are over 65 vaccines. What are you doing with 80 over 65 vaccines in November? Order appropriately. I know flu seasons are really hard and we all get in a bit of a panic. I've done GP land and we go, right, we've got to order heaps of vaccines. Don't. If you need extra vaccines and you've already put your 2 orders in for the month and you need more, call us. We will put in extra orders for you, but don't go ordering hundreds of thousands of vaccines and then getting to the end of the year. You can't give those to pregnant women because they're over 65. Okay, is there anything else I was going to say there? I've gone off track. I've done a Priscilla. Okay. So this data logging, the context of this is the start and the end of the data logging. So the data logging started on the 9th of the 8th and it finished on the 9th of the 9th. There's a problem right there, but that's not the main problem. The temps continued in this range for the whole entirety of the data logging. What is wrong with this picture? Anybody? Scream it at me. It's running hot. So, first mistake is there's not been weekly data logging downloads stored to the computer. They'd have picked that up on the 16th of the 8th if they'd have downloaded it. I don't know what was going on with the min-max monitoring at this point. So, the other thing is it's been over 8 degrees. Our gentle little souls have not been kept in the dark between 2 and 8 degrees for a whole month. So there you go. That's all discarded probably, those vaccines. Okay, this one is a bit different. What's wrong with this data logging? The arrow will give a little bit of a clue. Yeah, good one, Jean. Yes, Jean's got it, everybody. It's a bit over-conscientious, this one. They're doing 5-second live data logging. And when you send me 70 pages, I don't tend to be very happy about that. 5-minute is great. I do appreciate that, there was no mistakes going to be made here. All right. Now, oh my God. All right. These ones are just a couple of administration errors. This is day 1 post Shingrix injection. What is wrong with this picture? Oh, I think everybody got that one. We don't need a roaming microphone for that. It's been given sub-cup. So she's had a big reaction. It's too low. That's the deltoid. That is not the deltoid. All right, this one. Same again. That's a Boostrix. That's day 1 post Boostrix. Way too low. So don't give it too high because you give it into the joint. Don't give it too low where you're giving it subcut. Imagine giving it to the rock. Imagine giving the needle to the rock. Where's his muscle popping out? All right, so you're picturing the arm, you're picturing that triangle of that muscle in the deltoid. Men, it's really easy usually to give them a needle because you can see that muscle. Ladies, not so much. The deltoid, not the deltoid. Okay, this one's a trick one. That is a deltoid. But what's happened? You probably can't tell where on the arm it is. It's a bit rotated in the picture. It has actually been given in the right spot. So the trick with this one is this is actually a normal reaction. It is a documented reaction. So this is day 1 post 2nd Pneumovax dose. So this lady had had a Pneumovax dose years before. She'd come back and she'd had a Pneumovax 23 again 5 years later. It's a normal reaction, so you need to be warning your patients about this one. All right? It's absolutely normal and just needs to be monitored. All right. This one's from a vaccine account application. When we said send a photo of our fridge, this is what they sent. in the application. If you don't know what's wrong with this, please go into your heady cold chain monitoring module again. It's too full, for those wondering. I don't think there's, by the sounds of that, nobody was wondering. This was after it was fixed, before flu season. This van account wasn't approved at this point. All right. This is an anaphylaxis kit we got sent. Anything wrong with it? A box to put it in? Some instructions? Any organisation at all? So when you have your anaphylaxis kit, you've got to have the instructions to give the adrenaline. And you've got to have it nice in a box. We also got sent one the other day that I didn't get a chance, it was only recent, where they'd put the beautiful instructions in the box, they'd put everything else they need to administer the 1 in 1,000 adrenaline ampules in the box, and then they put 2 EpiPens in there. It doesn't work. All right, here's just a couple of useful tips and tricks to finish it off. This is a really useful website. So in GP land, we always know when the pneumococcal people are coming in and they're due for a pneumovax and they're over 65 or 60 or whatever it is. And they've had one before and they've had a pneumovax, but now the rules say Prevnar 13. Go to this website. So the Immunisation Coalition is a really good website for all things immunisation. It's got great information on everything. They also run a conference in January. That's a free conference if you ever want to go. It's amazing. But pin this to your taskbar on your nurse's computer and go in there. So it's like a catch-up calculator. So it's like the AIR catch-up calculator. You go in, you type in the patient's details, chronic diseases, when they've had their last doses, everything like that, and it will spit out exactly what doses of pneumovax that patient needs. So it is so handy, and we use it all the time. If you ring me and ask me about pneumovax, this is where I'm going. All right, that's it from me. So take homes for today, always follow Strive for 5. Strive for 5 is being updated as we speak. We're hoping that it goes online just like the immunisation handbook so that you can just go to online and look at it. But it will include, because it's been such a long time since it's been updated, it's modernising itself, and it's got a lot on there about, new data loggers, each individual data logger, because there's not much in Strive for 5 about that. So keep an eye out for that. Complete your audits in a timely manner when they're sent. So if we send you out an audit, we know that you guys are busy, but try and put it on your priorities so that we can make sure. If you do your audits every year, you shouldn't have any trouble doing your audit the next year. Always follow the Australian Immunisation Handbook for administration tips. Always complete your heady immunisation cold chain management module. Always contact us if you have any questions. We would prefer to prevent a blunder than to be receiving a report about a blunder. We're here to help. Don't ignore concerns, seek clarification and educate new staff, and do as much CPD as you can on immunisation. There are so many free webinars out there, Immunisation Coalition, NCIS, all of the different websites. So just do as many as you can just to keep your foot in, especially if you're not giving vaccines very often. A lot of us aren't giving vaccines very often, and we're not giving vaccines to every age group. So if you want to keep your toes dipped, do that. And get your vaccine management right, or you'll end up in a conference presentation. Thank you.
Awesome stuff, Kendall. Thank you. Very entertaining. Got some alternative titles for next year. How to Love in a Dark Place. Alternatively, Don't Do It, Priscilla. Sorry, Priscilla. I couldn't help myself. I could tell. So please welcome now Kim Rice and Fiona Quinn, clinical nurse consultants, immunisation and child and family health nurses, PHU, Western New South Wales LHD, to lay the groundwork on this afternoon's interactive catch-up cases activity. Thank you, ladies.
Right, I'm Fiona, for those who I haven't met. Can you hear me? Yep. And this is Kim. We job share this role, and we job share at Child and Family Health, so we get it. We're on the ground and we're on the end of the phone or the emails when you send us. Kim's in charge of the slides because I muffed it up last year. So we're doing immunisation catch-ups today. I feel very pressured because we've only got 5 minutes, so I'm expecting Brenton to hold up his little 5-minute sign already, but we'll get there. So we're going to introduce it, and then this afternoon we've got half an hour to run through some catch-ups. So why do we need to organise catch-ups? Hand up anyone who organises catch-ups themselves. Yep, good. Hand up who rings the PHU. Yep, good. That is fine. All right. Sorry.
And how do we organise immunisation catch-ups? Okay, so as everyone knows, I love a catch-up, and I think I've spoken to lots of you on the phone and have received emails, and I'm always happy to receive more. We need to organise catch-ups because we get the people at the desk with their vaccine cards that were given overseas, and we're like, wow, cool. I need to take a photocopy of them and I need your address because we need to get them on the Australian Immunisation Register, and then we have to work out what they need. Sometimes we've got to organise catch-ups because there'll be a cold chain breach, which Kendall has touched on before, or vaccines accidentally given before it was recognised that there was a cold chain breach. So that's why it's very important to do your weekly downloads, because in the public health unit we've had instances where fridges have not been checked and lots of people have been given immunisations, and because the immunisations weren't loved and in a dark space, we had to actually organise catch-ups to revaccinate a lot of people, and that is a nightmare. Sometimes people miss scheduled vaccines. Sometimes, we have that person that was previously a vaccine objector and then all of a sudden has said, you know what, I think I'm going to believe the science and I'm happy now to have some vaccines, and we love those people too. And then sometimes people have a change in medical circumstances as, they become immunocompromised, and so they need a whole lot of new vaccines. I hope that all makes sense.
So, how are we going to do it? So there's 4 options you're allowed to pick from. You can panic and crawl into the corner and hide. Definitely decide this is not happening, and I think when we're all new clinicians, we've all definitely felt that panic of, oh my God, I've got to do a catch-up, what do I do?
And it's always on a Friday afternoon. Yeah.
And don't think we don't feel that sometimes too, to be honest, because you get those overseas ones and you look at them and you think, breathe. Option 2, refer to the catch-up section in the handbook, and there's a resource section at the back for immunocompromised people. It's a really good resource if you're thinking, I just don't know where to go. It's a really good starting place. If you've got access, you can go to AIR and have a look at the AIR records. Be mindful that sometimes what is shown on AIR is not everything that they require, and we're going to go through that this afternoon. There'll be some scenarios that'll show you that just because AIR doesn't say it's not due doesn't mean it isn't due or that you can't give it, but it's a good starting place. And then obviously you can always ring the PHU. Kim and I are often there, and if not, there's Kendall, there's plenty of people around to help answer the questions, bearing in mind that sometimes catch-ups can take a good few days, not just for us to do, but for AIR to upload so that we can send it through. So if people come to you, don't promise a magic wand just because you're ringing us. We definitely need a few days to run through particularly the overseas ones. Yep.
About 5 minutes is probably up. So we've got scenarios on the table, and we want you to do what your scenario is. Not now, but throughout the day. But we're just going to give you some I have these useful tips that are just in my brain all the time. So children under 5 years of age, always check they've had at least 1 pneumococcal and a Hib vaccine at or after 12 months of age. Because sometimes AIR will say that they don't need a Hib or they don't need a Prevnar, but if they haven't had a shot at 12 months or after, we do recommend they do.
And it's funded.
Measles, mumps, rubella, chickenpox vaccine should not be given as the first dose until 4 years of age. So always have that in your head. That's the combined vaccine. And it should not be used in people over 14 years of age, that combined measles, mumps, rubella, chickenpox vaccine. Rotarix, it's always that tricky one. There's an age limit for the first dose of Rotarix. It should be given between 6 and 14 weeks. So before turning 15 weeks of age, you can give the first dose. Age limit for the second dose of Rotarix is 10 to 24 weeks. So before turning 25 weeks of age, because we've all had that 24 plus 4 days babies. So, and then those childhood vaccines, so anything that has Inforex in front of it and the Vaxelis, Quadricel, Tripicel, those vaccines should not be used in people over 10 years of age. And I know sometimes people get that wrong. And I think, so you got your little scenarios.
So there's some catch-up tables on your desk so you can get into groups sometime during the day because we're the last presentation to wake you up this afternoon. And do the one that's highlighted. So from the very back, you'll all be you'll do scenario 1, 2, 3, 4, 5.
And then a couple at the front might be a bit different. Yeah.
Feel free to attempt more than one scenario by all means.
Yes, and I think our time is up. We're going to get...
We will come back and see how you've gone this afternoon.
We'll be back after lunch. Okay, thank you.
Thank you, Kim and Fiona. Very friendly. Microphone hogs, but friendly. Okay, moving on. Please now welcome Wendy Holmes and Alice Gordon, Aboriginal Immunisation, PHU, Western New South Wales, LHD, to talk to us about Aboriginal immunisation, childhood immunisation. Thanks, ladies.
Hi, I'm Wendy, as you all know. I do the Aboriginal immunisation with Alice. First of all, I'd like to acknowledge the traditional owners of the land we are meeting on today and remind people that we live and work on Aboriginal land and acknowledge the Aboriginal elders of the community that have passed and the Aboriginal people attending today.
Our footprint. So there are two of us that sit in Orange and Brewarrina that cover Western and Far West New South Wales. And today we're just going to give you a bit of oversight on what we do in the background with childhood immunisation.
Did we say it's not moving? Did it move? No? There. Okay, so air data and Medicare. As you know, immunisation records are not being, or some immunisation records are not being recorded on air in a timely manner. Some children don't have Medicare cards. We've got Medicare details that are not up to date, or they have duplicate records, which mean that they're vaccinated partly on one Medicare detail and partly on the other. So we follow up with clinicians and have their records updated to try and reflect what they're meant to have had. Most cases, families have not yet received their birth certificate, so they can enrol them in Medicare. Children are in out-of-home care. These children's and parents have joint custody and they tend to move from one active Medicare number, and if they're under DCJ or out-of-home care, they usually get provided with their own Medicare number. So and they're not linked together. There are a lot of children born off-country and in rural, remote areas that have different addresses for birth because of their different addresses. Their Medicare numbers are not merging and resulting in a duplicate. That's also a delay in these records being updated. And also details not being updated on our hospital database. Okay, so now I'm not sure, you all should be aware of this anyway, but if not, just give a yell out and happy to come and have a look and show you where you can order your reports at. So we've got us as a public health unit can order the second one, the Air 11A, and other medical practices can order the Air 10AB. So and then you've also got the pharmacist and vaccination providers. So if anyone isn't aware out there of how to order their own reports so that they know which kiddies are overdue, just give us a call. So these are what, you can actually download these on the immunisation, on Proda. It shows you step by step how you actually go about ordering them. So if you just want to have a look at that.
Access. So in the background, Wendy and I pull reports for the communities that we cover, and we come across lots of barriers and such for parents accessing vaccines for their children. Some of the biggest ones are changes to drop-in clinics, and this might be that, you know, in this day and age, both parents are working. The mum's usually the one who brings the kids in for the clinic. Those times are strictly when the mum's at work, or even when the dad's at work. And the work commitments are changing and the competing priorities for vaccines. And some services do offer transport, but it's a little bit hard sometimes if you've got 3 kids that need car seats. So it's just those little things that, yeah, there's an easy fix, but it's also a barrier that's, you know, competing for immunisations. Changes in GP services over the last 18 months to 2 years. Some GP clinics are at capacity and they just can't accept new clients, or they're no longer bulk billing. So just these little things that they are barriers, they are fixable, but they are barriers that are changing the statistics of the access. Where am I up to? Vaccine hesitancy. So, more barriers. Vaccine hesitancy. COVID done us dirty in this space. We are rebuilding trust, and in a lot of ways. You know, we're educating parents. We're also finding that we're having to educate bigger groups of families if the mum or the dad or whoever's looking after the children are being influenced by an elder or someone that they really respect in their community or their cultural environment, and they have misinformation. So we're educating lots of people to start ingraining, yes, you know, these are childhood vaccines, they're really good, they work, and this is a trustworthy experience. And the stigma around Bexero. I myself has experienced a conversation of a mother walking in and go, "You're not trialling that on my baby." And it was just how we're wording the education back to the parents. No, it's not a trial. It's just funding differences for the baby's Aboriginal. Yes, they're eligible to have this vaccine. And it is that the stigma also around the health service. Are they having this vaccine in an environment where they've had a bad experience, where there's been a significant death? And it's just those emotions that come back, and you see a piece of paper that says Aboriginal only. And it's the history of that that's behind, is this a racist vaccine? Yeah.
So education. Parents and carers questioning why the childhood vaccines are important. So if you've got someone well known in the community, is seen as a role model, they're respectful, and they're a trusted resource. So it's word of mouth through social media, wildfire, community grapevines, and much further. Community questioning why all of a sudden we're needing so many vaccinations, thinking that there's an ulterior motive around vaccinating. Parents choosing not to vaccinate after friends' child was diagnosed with autism shortly after being vaccinated. So it's just all their myths. Okay, so other reasons, religious, cultural reasons. As I said before, DCJ, when a child's in care, and DCJ, both DCJ and parents have Medicare numbers that are not linked. Sometimes the child isn't living in the district anymore due to placements, etc. Some children in care have an order that parents are not to receive any information regarding the child, so it makes it hard if we want to update both Medicare cards to reflect what the detail that the child is up to date with both, because if a child's been put in kinship and they're in another location, they might be updated on one but not the other, and through, we can contact PRODA, but we're not allowed to, for specific reasons, have them update it together because parents are not to have any information. Situation where child is cared for by family members was declined by an AMS to vaccinate the child due to legal reasons, as there was no formal evidence having custody of the child. Also, we're finding mums have complications during birth and they're airlifted to larger facilities in other districts. And if the child or children pass away, that information's not always sent and updated to the appropriate services. So therefore, we're still getting the information with, therefore, the bub or child is showing up overdue. We also, and I think it'd be great, but I'm not sure whether this is something that'll happen, if we have access to major hospital databases where we can actually access that. I mean, we're lucky we've got one of us in each district where we can contact the bigger facilities, say Nepean or Royal Prince Alfred, to find out information for that child.
Because who doesn't love stats, right? So these are some stats on Aboriginal children in the LGAs that we cover. And these are the age groups that we report to the ministry. And I just want to pop them up there because in some of our communities, the numbers are so small. So it can be just between 1 or 2 kids that make a difference in those communities. And while there are a number on this page, everyone in this room, we don't look at a number, we look at a child. We look at the individual, the family, and the community commitments to why this child isn't vaccinated. And we all know, we follow them up and we do that. But they're quite significant in, say, on Brewarrina. If there's 4 4-year-olds in Brewarrina and 1 isn't vaccinated, it's quite a significant drop in the stats that come through. And that's what we do in the background, is we explain what this is and how it is. And yes, we've chased and we've followed and we've tried everything that we possibly could to get these children vaccinated.
Okay, and this is a better slide, just giving you what our percentage rates are. If you look at what we are with Australia, so if you look at the 1-year-old, 94.7, 2-year-old, 88.6, and 5-year-olds, 95.4.
And this wraps up our presentation. So we just wanted to say thank you for everyone who works with us. We do cover a lot of ground, and we would like to come in and help provide, the cultural expertise and knowledge and the different conversations that we have with our patients, with our care providers, with anyone who provides immunisations to children or otherwise. So thank you.
Thank you.
Thank you so much, Alice and Wendy. Love that sunrise photo of Brewarrina. Yes. Yes, lovely. So please take them up on that, actually. Cultural awareness is very important. Okay, morning tea. Welcome back, everyone. Tommy's full, caffeinated. I'll get you to take your seats, please. Show of hands, who sat outside in the sun? All right, you get the Koala Stamp Award for having a very smart move, I reckon. Well played. Okay, we're going to make a start. I'm going to introduce the next speaker now, just to keep the schedule. So please welcome now Professor Julie Leask, Professor of Public Health, Faculty of Medicine and Health, the University of Sydney, to present a session on building trust in the vaccination space. Thank you, Julie.
It's not a mic, it's a light. Thank you very much, Brenton. And I'd also like to acknowledge Uncle Neil for his welcome to this beautiful Wiradjuri country and pay my respects to elders past, present and future, and the Aboriginal people in the room, particular acknowledgement to Aboriginal health workers and practitioners. It was wonderful also to hear earlier from Wendy and Alice. So yes, my name's Julie Leask, and Brenton actually said to me, how do you pronounce your surname? And I said, don't worry, I had to ask that same question years ago because I married Sandy Leask. I identify with that challenge. So you've got the outline there. It's just a bit about me and what we're covering. We're covering building trust in the vaccination space. And I will be focusing on some of the challenges we have with vaccine communication. I'm hearing from some of you and Dee last night on our way over that there is more hesitancy out there and that you are having to deal with more questions about vaccination, some of you. and that's a challenge, that people need more time, and yet primary health care is still very pressured for time. So total acknowledgement of the amazing work you all do in this space. And I say that also as a former nurse and a midwife who found her way into public health, that it's wonderful to be with a group of nurses and other health professionals, Aboriginal health practitioners and others. And I always really enjoy these sessions. So we'll cover some tips on vaccine communication. We'll look at sharing knowledge about immunisation, which is a package of support to address those conversations with people about vaccination, including people who are hesitant. We'll focus on childhood vaccination, but some of this will be relevant to all of you. We'll have some discussion and we will have fun. So I'm focused on that learning outcome, which is the importance of active listening. So therefore, I'm going to focus mostly on the one-to-one, the vaccination encounter, or any kind of conversation you might have with another person about vaccination. So I'm focusing on vaccine conversations, noting that that's not the only way to build trust. And I also want to acknowledge so many people whose knowledge I'm sharing with you today from my own team, Social and Behavioural Insights in Immunisation Research Group at the University of Sydney, from the team that developed sharing knowledge about immunisation, NCIRS, the Hunter New England Health Protection Team, you'll see why I'm acknowledging them later, and of course the organisers, the PHU and the local health district and NCIS. So, the challenges with vaccine communication. Number one, this is Sandy, my husband Sandy Leask's vaccination schedule from 1974, I think. 4 ticks. I heard someone say that's what mine looks like too. I remember getting polio in a spoon from a community health nurse. That's what it looks like in 2025. It is much busier. And of course, parents are going to be concerned about how many vaccines their young children are getting. So, there are people in the US in particular who capitalise on these concerns, and they develop selective schedules. This is the Dr. Paul schedule. He's a paediatrician in the US. Some of you might have heard of him because this schedule includes no vaccines in pregnancy, no Hep B at birth, rotavirus vaccine, no. So this is where you select out certain vaccines. It's the pick and mix schedule. And it's harmful for children, but he makes it look compelling. So parents are wanting this individualised schedule. Some people have had negative experiences with healthcare. This is not just since the pandemic, although that contributes to it. It's people in this room would have had negative experiences with healthcare, and for some people, that causes them distress and a loss of trust, and it flows over into their trust in vaccination. They may be exposed to other people's stories about an adverse event following immunisation and become scared of immunisation. And credit to the work of Maria Christou-Ergos in our team, whose PhD was on this whole area. This is a dad from New South Wales. I've got multifocals and I can't really see this screen easily. I don't know, maybe I'll look over there. At 1 year, vaccinations, my daughter had a very overt reaction to the vaccine. She was despondent and floppy and she couldn't make eye contact, and it was scary as a parent. That made me look into them. And then he says, and I went down this rabbit hole of information. And that's what, sometimes it's that negative experience, a person goes and looks further at it, and online, of course, you can see all sorts of stuff that's scary. Then there's the high-profile vaccine safety scares. This is from a long time ago. This is Andrew Wakefield, now deregistered gastroenterologist from London, who popularised the idea that vaccines could cause autism, and MMR in particular. His infamous article in The Lancet was shared liberally. The UK media were captivated by the idea, and there were parents, there were already movements of parents who believed that vaccines caused their children's autism because they wanted to make sense of what was happening. And this theory is still being circulated. So his article was 1998, and it caused a decline in coverage in the UK, not in Australia, although of course all of you would have heard of this issue. But now it's being reignited, and I'll show you in a moment by whom. Alternative parenting. Okay, so the lady in the middle with the red cardigan is my grandmother, and she turned to natural health in 1941. And she is with her 2 daughters and their husbands, and this is sometime in the 60s. And a couple of my brothers are in this picture. My grandmother raised her children to be against medical intervention because it would introduce toxins into the body. She always had a filter on her tap to get rid of the fluoride. I don't know if it worked. And she was very against vaccination. My mum didn't vaccinate her 3 sons. This is before I was born. And was also raising her children naturally. Now, I'll come back to her story later. But this natural parenting thing has been a thing for a long time. And there's many good aspects of it. My grandmother was very devoted to feeding her children a good diet. She cared deeply about her children and her grandchildren. So did my mum. So this is actually a lady from South Australia just a few years ago in one of our interviews in work led by Paul Ward. I grow vegetables, I have chickens, I feed my children organic food, I cook everything from scratch. I don't give them processed food, we have no chemicals in the house, we don't drink fluoridated water, we drink rainwater which has been filtered. So why would I then go and put those chemicals in my child? So alternative parenting or natural preferences is a thing. Misinformation, half-truths and activism. So not everything's misinformation. Sometimes it's just carefully framed in a nuanced way to scare people off vaccination. And the whole idea that something's either misinformation or information is a little bit naive because we know that there's uncertainty in science. So that's one of the things that makes it hard to counter. This is the Forest of the Fallen. Who has heard of this? It's kind of good in a way. So this is a collection of notices on sticks that are put periodically in parks around the state, and in this state in Victoria at least, by an activist who wants to share the stories of people who believe their problem was caused by the COVID vaccine. So you get, on each of these, you'll get a story like Stuart, who died suddenly at 42, and it is claimed here that he died from a COVID vaccine. Just reading his story, it's extremely unlikely that was the case. But that's the story, and there's many of these on these sticks in the parks, and it doesn't get a lot of media attention, interestingly, but it's out there. Now, this is someone's story. It may be misinformation, but it affects people. Stories affect people. And of course, there's the politicisation of vaccination that's happening more and more now. This is Robert F. Kennedy Jr. on the left, now essentially the health minister of the US, and Joe Rogan, the world's second most popular podcaster, on the right. After 3 hours of RFK Jr. giving his beliefs about all sorts of things, including a lot of time on vaccination. RFK Jr., as the Health and Human Services Secretary, said to Donald Trump at a cabinet meeting recently, and this is where the MMR autism thing resurrects itself, "We've launched a massive testing and research effort that's going to involve hundreds of scientists from around the world. By September, we will know what has caused the autism epidemic and will be able to eliminate those exposures. All the research on autism, all that's been known that vaccines do not cause autism, all the good science on that, ignored. And you are not going to know what causes autism by September. The pandemic. This is a local karaoke bar. I live in Western Sydney and Darug country, and we were very locked down. So COVID lockdown closed until July 9, July 16, August. So people had tough experiences during the pandemic, some more than others. And all of you will know of people who have, since the pandemic, less trust in the health system and less trust in public health, and for some less trust in vaccination, or it's ignited some more questioning about vaccination. And because, as we heard earlier, people in the networks, there might be elders, there might be school principals, there might be people who are now vaccine hesitant who weren't before, who are influencing their networks. So it doesn't just take a parent to be spooked about vaccination to have an impact on everybody. People in positions of leadership can have a big impact. Now, if you look at trust in government in Australia, it actually hasn't declined that much since COVID. In fact, in the last 10 years, it hasn't declined that much. But if you look at rating of the state government's response to the COVID outbreak, and this is surveys of people from April 2020 to March 2025. So you can see that decline in the rating of the response. So it's like the retrospectoscope is becoming increasingly critical. So that's a thing as well. And there has been a significant decline in the general population's confidence in childhood vaccines' importance, safety and effectiveness. Now, this is not a massive decline. Most people support vaccination, and we have to remember that strength that we have in the program. But the group, so you look in the middle at vaccine safety perceptions, the orange and the red bars have increased slightly. And those orange and red bars are the people who disagree or strongly disagree or tend to disagree that vaccines are safe. And that's parents. I think, oh no, it's the general population. So I'm going to ask you at your desks, I'm not using Slido, I want you to have a chat with others at your table. Just take a few minutes, let's say 4 minutes, to talk about what concerns you're hearing in your practice. And I'm curious to know what's changed since the pandemic as well. And then I'll get a few people to shout out afterwards. So take 4 minutes, have a quick chat, go. Yes, please. Yeah, that'd be great. Thank you. Yeah, is my mouth dry? Hello. 15 minutes. 1 more minute. Okay. So, as you're winding up your conversations, I'm going to ask for the question: what concerns are you hearing? Is it any sector that you're working in? It doesn't have to be childhood vaccination. What concerns are you hearing? We've got 2 roving mics. Put your hand up if you're feeling brave. Is a hand up over here and over here. Thank you. So, here first.
Too many vaccines, so people are worried that they're always getting jabbed.
And do people feel like there's more vaccines given now than there were
Absolutely.
a few years ago? Are there more vaccines being given now, Dee?
Yes and no. It depends on whether you want to break them up and do your own pick and mix.
Okay.
But you know, if you add in, you know, RSV and flu and Men-B, potentially there are more. But we don't have polio in Australia, so why does my child need polio?
Is that what you're hearing? Why polio?
And Hep B, you know, so...
Yes.
Yep.
Others?
That the vaccines are new and they haven't been tested over a really long period of time, so how can we say they're safe?
What vaccines in particular?
RSV.
Yeah.
Just a couple of comments like that.
Yeah. And that was that was quite a dominant sort of rhetoric with the COVID vaccine, wasn't it? And we were trying to address that concern in lots of different ways, but it resonates obviously for people. This is new, it hasn't been tested. And it's understandable, I think, as humans, we want to think that something's well tested and know that it's safe for us. And so sometimes that's a matter of addressing that with a bit of education about the testing that's done. Others?
School vaccination.
Where are you? There.
I just help sometimes with Kendall, and I also team lead for a couple of little towns, and I'm a child and family health nurse. And I've heard from a few families that they didn't sign up to get the school vaccinations done because they heard that we were going to give the kids COVID vaccines at school.
Yep.
And so then just been educating them, and when they say, so we can't give anything without your permission, and we never give COVID at school. So
Yeah. Are others hearing that with school-based vaccination? You might be giving our child the COVID vaccine as well, and we don't want that? We've heard that in other forums about school-based vaccination. I see a couple of nods there. Anyone want to comment on what's changed? What are you noticing? I'm really burning to know this, because in the overall sort of trends, you know, things aren't changing that much in terms of confidence, but we are hearing from the ground, so over here then here, that things have changed a bit in the kinds of conversations, so it's more of a qualitative change. So over to you.
social media, like Joe Rogan is a classic. I listen to Joe Rogan because I like to hear what he has to say.
Yeah.
And he can be so convincing with his speakers. But I think there's a lot of social influences, a lot of this well-being, healthy lifestyle stuff. And I think our youth, younger generation, younger than ours, are really perhaps influenced by that.
So the younger people are more influenced by social media, and their news feed is very different to that for many of us as when we were younger. Over here.
Sorry, I work in Bloomfield Mental Health, and I've actually seen the opposite, where people are wanting more information. They want to know why they keep seeing on the news that there's another COVID booster shot. Why can't my kid have it? I work predominantly with teenagers. Does my child need it? When can I give the flu shot? How do we get more vaccines to prevent what happened? Or how can I find out more information? Because I never understood it. I just signed the paperwork so they could get it at school.
Yeah.
But now I want to know what's in every vaccine so that I can protect grandparents, great-grandparents, toddlers.
So there's more engagement, which means more questions, but some of it comes out of a motivation to be more engaged with vaccination and potentially to vaccinate others or protect others around them. So there's more perhaps vaccine literacy in a way.
I'm also finding teenagers never understood why they were getting vaccinated, but now they're the ones driving, wanting to know what the vaccines are and why we have to have COVID shots. What does it do? I've heard that it's a live virus, but are you putting something alive into me? And I'm just having to explain through to them that the process of vaccination.
And of course, the COVID recommendations, which change frequently, but the latest recommendations probably are on that schedule sheet on your table. So it's always worth checking up who's recommended for COVID vaccines because it has changed. But it's great that people are asking questions, I think, and part of your job is to help answer them as people who specialise in different ways in vaccination. Okay, now unless there are any other burning... Oh, yes, sorry, yes.
Maybe just that sort of loss of control as well.
Just hold your mic a bit clear.
That loss of control, being told what to do, you know.
Yes.
And no one likes being told what to do. And we were talking about that here. There's also just, like, clearly with all of that, the fear that we all were told that we had to get the COVID vaccine to get our freedom back. So, and I know I was in Sydney when we had COVID, and so obviously there was a lot of fear, and I worked at RPA during that time, so there was a lot of fear. Whereas other areas weren't affected as much.
Yes.
So it was that thing of like, well, if you don't get vaccinated, you can't go back outside, you can't go back to work, you're going to lose your job, you're going to lose everything. So there's definitely that sort of loss of identity and loss of control.
Yes,
So,
absolutely. Well said. Okay. All right, so with all of that, that's our communication environment. I wanted to share with you something that sort of depicts the different positions people can have on vaccination. And this is overly simplified, but it's kind of helpful to think beyond just pro and anti-vaccine. So on the left, you've got people who are activists, who are very against vaccination and will be activists in that space. So Robert F. Kennedy Jr. is one of the leading anti-vaccination activists in the world. So the US have a real problem on their hands. Then you've got, I'll just change that. Then you've got people who are rejecting vaccination, who are just hesitant, who are accepting, who are demanding, I want this vaccine now, and who are advocating. So they're the kind of opposite of the anti-vax, they're the pro-vax activists, if you like. And with my colleagues in the Hunter New England Health Protection and Immunisation teams, we ran these workshops called Yarning About Vaccination. So Christy Crooks, Kylie Taylor, Liz Harwood and Katrina Clark led these workshops, all Aboriginal women. And we had this diagram, but they wanted to, in their words, indigenise the information. So they suggested these fabulous labels. Activist, hell no, and you shouldn't either. Rejecting, yeah, nah. Hesitant, maybe. Accepting, yeah. Demanding, hell yeah. And advocating, hell yeah, and you should too. So just a lovely way of depicting those different positions. So I want to focus on vaccine hesitancy in this particular scenario. You're going to see a recording of an acted vaccination interaction between a primary healthcare nurse and a hesitant mum. This has been done by a registered nurse and the health promotion officer in WA Country Health. And we wrote the script together and they have acted it out. So I'm very grateful to Verity and Lance for agreeing to share this. They're not playing themselves, they're playing roles. But I just want you to look at this interaction which isn't so great, and notice some things about it. I might just ask the AV guy to press play. Thank you.
Hi, Angelique. So Josh is due for vaccinations, I see.
Yeah, he is. But I just wanted to talk to you about it because I'm feeling a bit unsure, particularly about him getting the MMR.
Oh, why not?
Well, I just don't feel right about him getting all the vaccines at once. He is really small, and I just feel like it might be too much for his body.
Oh, look, there's no evidence it'll be a problem for him. His immune system could certainly handle it. Vaccines actually strengthen the immune system to fight against diseases. I just wouldn't be worried.
Yeah, okay. Well, I mean, I did read this thing. It's by a doctor. His name's Dr. Paul, and he's a pediatrician in the US. And he does recommend keeping them separate.
Well, there's a lot of misinformation there online. I would actually be more concerned about him not having his vaccines on time. I mean, you'd have to wonder how you'd feel if he actually got measles, and there's some cases around the community at the moment. Personally, I've seen a child with measles when I worked in Mozambique, and it's a terrible disease.
Yeah, right. Yeah, look, I'm just not too sure.
Look, ultimately, it's your choice, yeah?
Okay. Well, in that case, I think I'm going to leave it for today and think about it a bit more.
Okay.
It's so hard to watch. Okay, so it's a bit artificial, but it actually takes in what people have said to hesitant parents in the past from research we've done. So it's a bit of a collection of that. And it demonstrates some of the less helpful communication strategies, which include not taking the time to listen and engage and elicit the person's concerns, in that case, to acknowledge Angelique, to set a bit of an agenda, disparaging her sources of information, and also at the end, what we put in there was abandonment. So, well, this is impossible, I'm in a rush, I'm frustrated, I worked in Mozambique and saw kids with measles, that's hard for me, and it is, and therefore it's up to you. And those sort of things can happen, particularly in those formative early experiences with someone who's very hesitant, that clinicians, health workers can find it so discouraging that they just want to move on and they develop a bit of a script around this situation. So we won't pause here because I want you to have time to play the bingo game. You've got little bingo cards in your that you picked up at the front, and you may have wondered what they are. Later in a while, you're going to see a more positive interaction, and you're going to mark off the positive communication practices as you hear them, and then get to yell bingo when you've heard them all. So, vaccine refusal and hesitancy can be challenging, but you are influential. Parents look to their family doctor or nurse immuniser when they are concerned. There can be these ritualised practices or scripts, if you like, that can be ineffective, and some can be incredibly effective, which Sky is based on some of the wonderful communication strategies that we've heard from GPs and nurses and Aboriginal health workers over the years. Some communication can be overly directive. Now, that's appropriate sometimes. As RNs, you'll need to, and other healthcare workers, you will need to be quite directive at times, and sometimes it's culturally appropriate as well, depending on your relationship with the person. But sometimes that can go very badly, particularly when a parent wants to make their own choices, and choice is important to people. Dismissive communication is associated with non-vaccination. So if people have bad experiences, they can be put off even more, like Angelique in that video. And some health professionals have knowledge limitations. They don't want to have to answer this question because they don't know the answer and they feel embarrassed at that. You don't have to know all the answers, although I know this group will have a lot of good information. Sometimes it's about saying, I'm not sure of the answer to this, let's look this up together, and showing the parent where to find good information sources. And some health workers are vaccine hesitant, as you all know. So sharing knowledge about immunisation, we developed this some years ago because of these issues. It's an integrated package of resources and structured communication for primary healthcare providers. It aims to move parents towards vaccination and to build trust among non-vaccinators, among the hesitant, and to facilitate valid consent in everyday vaccine conversations. It's evidence-informed. It's informed by communication science, motivational interviewing, and particular communication paradigms. And there's a whole evidence base to this in our development of it. So it basically says, rather than that complex normal bell curve you saw, there are 3 positions that people might have on vaccination. People are either ready, they're hesitant, they have questions and concerns, or they're planning to not vaccinate. And they're often quite different positions. So with people who are ready, they're confident, they want the chance to ask questions. With those who are ambivalent, who are hesitant, they're ambivalent, they're not sure. They might have a lot of questions about safety, about reactions, about too many vaccines, someone mentioned earlier, about autism, about new vaccines, you name it. A strong sense of responsibility to make the right decision for their child. And they want their child treated individually. For parents who are planning to decline vaccination, or anybody for that matter, they may not want to discuss it. They might have had some pretty negative interactions with the health system about their decision to not vaccinate. They may talk about I've done my research. That's often a key phrase people will use. They may have had bad experiences. They see vaccines as unsafe very often. And some have alternative parenting practices like my grandmother and my mum, and some don't. So these are the pathways that Sky sort of takes you through the website. For those who are ready, the goal is for vaccination and for valid consent to occur. Now, not everyone needs a heap of information, but at least they have an opportunity to get the information that they need through this system. For the people who are hesitant, you want to see them vaccinated if you can, or to at least reduce their hesitancy and make a plan for another visit. And for those who are declining, the goal is to maintain trust and engagement. You can't always get them to often can't get them to vaccinate at that visit, and may never, but maintaining that trust and engagement, they might come back to you if they feel safe to. So how do you initiate these conversations? All of you will have your own communication practices which are effective. These are just some suggestions that might enhance your existing practices. He's due for his whatever vaccinations today. Do you have some questions? And some questions tends to open up people's actual questions more than do you have any questions, interestingly. For those who are ready, who are hesitant to vaccinate, he's due for his XYZ vaccines today. I noticed you had a few questions here on the Sky Sheet. The Sky Sheet is one of the resources in the on the Sky website that is for parents who are ready to vaccinate. You can print it out and put it in the waiting room. And it has information about the vaccines at different time points. And it has a section at the end, what questions would you like answered before getting your child's vaccines today? But if you don't have this available to you, you can simply ask the person, do you have some questions? Have you had time to read the information? And for people who are declining vaccination, it might be, I noticed she has no vaccines on her record. Do you mind if we discuss that? And this comes from motivational interviewing, where it's a behaviour change counselling technique where you're working with people who are resistant to change, and you want to figure out how ready they might be for change. Asking permission to discuss is a good practice when someone's resistant to change, because if they don't want to discuss it, then you know that right at the beginning. It can get pear-shaped if someone doesn't want to talk about it and you try and keep prodding them. I'd like to understand your decision, if that's okay. So it's very open. So just to delve into the tips for talking with people who are hesitant, they have questions, or they're planning to decline vaccination. Use questions, elicit questions and concerns. And by the way, this is on your bingo card as well, in slightly altered format. But just take note, because when you hear it in the next role play, you'll want to be attuned to it. Simply eliciting questions and concerns. What questions do you have? Tell me about that. Active listening. Body language is important. Turning away from the computer. Resisting the urge to correct wrong thinking at this stage. So you might hear someone say, we're going to do homeopathic vaccines. Don't say at this point they don't work. Elicit their questions and concerns or their experiences a bit more first. Acknowledge the person, validate them. It sounds like he had a strong reaction to that vaccine, or you had a strong reaction. I can see you've done a lot of thinking about this. I can see you care about him and you're trying to do the right thing by him. Validation of the person. You don't have to validate their misinformation, but you can validate them, and it makes such a difference to your later recommendation that they vaccinate. When you're acknowledging people, it's important to sort of adopt an air of curiosity. Because even though in yourself you might be wanting to right the wrong thinking, you might be frustrated, you might be in a hurry, stressed out, feeling like you've got to perform, but just notice your feelings and be curious. Recognise the root causes of people's vaccination decisions. Sometimes it's not about the vaccine. I'll show you a slide in a moment that depicts that. And know when to let go. Some people are fixed. Be attuned to that. And if you think they're not going to change, keep that in mind. I want you to just briefly at your tables chat together about how you notice, how you can tell if someone's totally against vaccination versus just hesitant, because it can sometimes be a bit tricky. So for those of you with a bit of experience in this, can you just share with your table how you've been able to tell that? So just take a couple of minutes for this. Okay, just wind up your conversations. Okay, can we have the roving mics again, please? Because this is a burning question for me, so I want to hear your answers. Who would like to share some of their reflections on this question? How you tell if someone is totally against vaccination versus just hesitant?
I think if they're totally against it, they just shut you down to start with. If
Yeah.
you mention immunisation, they'll just, a statement maybe like, we don't vaccinate our children, or it's just a statement to, that's the end of the conversation.
Yeah.
Yeah. If they're hesitant, they're more willing to listen to what you say or ask some, some questions and things.
Just curious to know, when someone just makes that statement, what do you say?
I'll often ask why.
Yeah.
What's led you to that, or
How do they respond
experience
to that
you
that
had?
why question?
Oh, very differently, like
Yeah.
bad experiences or done some reading or social media or,
Yeah, and it's a big decision for parents because, as Archana was just saying, it's quite a bit of stigmatisation if you don't vaccinate your kids. Some people are fairly quiet about it, some are not. But there is stigma for them and their kids as well that we've seen in our research interviewing parents who don't vaccinate. Others?
Hi, I'm Nadine. I work in general practice. I agree with the straight up no. Usually, if they're hesitant, they say to me, "Well, what do you think about it?" Which opens up the conversation. Yeah.
What do you say?
I say, well, if it's recommended for your age group and what the benefits are for it, and I point them in some direction of the resources. Yeah.
Yeah, good.
So it's not a personal recommendation. It's an overall health recommendation.
Yeah, that's a very professional response. Are there people who say, I vaccinate my own kids? Yeah. So people feel differently about that. I don't think anyone should feel obliged to share that if they have children. But some people will do that, and that can make a difference. But it's a very personal decision what you share about your own life and experiences. Others? It's a tricky one, I think, this one. But they're helpful answers. Thank you. Okay. Oh, we've got someone over here. Sorry.
This isn't an adult, but working in a school vaccine program, when the child won't even come into the room, mum's consented or whoever.
Just hold the mic a bit closer.
Mum's consented or whatever, but the child won't even come into the room.
Yeah.
They're already crying. They won't take a jack. They won't let go of the top of their arms. Year 7 usually. Very tricky.
Yeah.
So you really can't
do
anything really. Just let mum know and they can go to the GP maybe.
And that, I guess, is such a different situation to the one that we saw earlier, because it's the parents not declining, the child for various reasons is, and that's a real issue now. We've done some work on the barriers to HPV vaccination or school-based vaccination, but particularly looking at the literature on HPV vaccination. And this is a big issue. Young people are sometimes very anxious about having a needle in a school-based setting, and how that's managed is very important. Any other burning answers to how you tell the difference? Okay, great answers, thank you. So, I mentioned earlier that sometimes it's about what's under the surface. So on the surface, you might see a set of behaviours or statements around vaccination, but under the surface, there are things like this. If someone vaccinates or they don't, they're almost always going to be thinking about protection of their child, either from vaccine preventable diseases or not. And that's a fundamental aspect of parenting. Choice. You mentioned earlier that people are have been upset that they had to have a COVID vaccine. Those mandates are having what we call a big reactance effect now. There are people who, in retrospect, are not happy that they had to have a COVID vaccine. The mandates were very challenging in many ways, and finding the right balance in mandates, the right policy balance, is extremely challenging. And there has been some overreach of mandates. And so there are people who are still upset about that. They had their choice taken away. Purity, the desire to keep the body pure, like my grandmother. Now, I'm going to tell you about my mum at this point. So she felt the same way. But then my brother was in the playground. He hit his head on a bit of playground equipment. It bled a lot. She went to the GP. The GP said, has he had a tetanus vaccine? Mum said, no, not vaccinated at all. The GP was aghast. This is the 60s. And Mum went home. She'd already been prevaricating a bit. She thought, so she was hesitant. She'd started off rejecting vaccination completely. Now she was a bit hesitant. And this particular communication staff from the GP worked for her. And she thought about it, she talked to my dad, she dreamt about it, and she ended up going back to the GP the next day with the 3 boys, my older brothers, and had them all put on a vaccine catch-up schedule, had them all vaccinated. And when she admitted that to her mother, who was a decliner, her mother, my grandmother, said, "This is the worst day of my life." So you can see that sometimes people will start in a particular position and they can change. These are not fixed positions necessarily. Traumatic experiences, distressing experiences, birth trauma, vaccination experiences that traumatise people can all affect this as well. Racism and traumatic experiences from racism in healthcare services affects people. And belonging. I want to be like my social group. So if you live in some towns in New South Wales or some, suburb, I can see you laughing up there. I don't want to sort of label particular areas because there are many different issues with vaccination. In Byron Bay, there are different issues with vaccination. It's not just about active refusal. But that sense of wanting to be like your group of peers is powerful. And social influences are powerful when it comes to vaccination. Okay, so that's sort of understanding the person. Now, what about the conversation itself? Because you still have to answer their questions and then vaccinate them, hopefully, if they're hesitant. So set agenda, and that's just simple. It's, now I've heard your concerns. This is from an actual conversation. Let's check her over and discuss the rash she got last time, then we can talk about some of your concerns and hopefully try and answer some of those questions. Would that be okay? Simple agenda setting. And then the parent gets a chance to say, oh, I also want to address this or whatever. Share your knowledge. So share what's in your head, share the recommendations, or written information if you have it available, or online information. Open up the computer if you have access to one. I have a fact sheet here that explains it. Would you like me to work through it with you now? And Sky has a whole lot of fact sheets. Chunk and check. So don't give them a huge amount of information and just go on and on and on and on and on. Give a bit of information, pause, check in with them for understanding and what their responses are, and then proceed. Because you might be barking up the wrong tree and you'll waste your time with a big screed of information that's not relevant. By the way, I'm not very good at this. I'm not great at some of this stuff, but it's partly why I love studying it, because it sort of gives you some great tips for good communication. Help the person find their own reasons to vaccinate. And that's the reinforcing motivation piece. Now, you're going to hear it in the next role play, but it's going to be a bit subtle. So we'll see if you find it. But one example of this could be, So I hear you saying you're not ready to vaccinate today. Can I just ask, are there any particular diseases you're concerned about him getting? And if the parent says, well, we are a bit worried about tetanus, which can be something that people who don't vaccinate are concerned about for some reason, or meningococcal disease, then I hear you. I'm, that is a concern. If you would be willing to consider the vaccines for this, that might be a way forward. Would you like to consider that today, or can we have another chat about it? Recommend vaccination. Every parent, every individual who is recommended vaccination should hear that recommendation from you. There is evidence that it makes a difference for people who are hesitant. Now, your timing and tone will differ depending on the person and where you understand them to be at, but a recommendation is powerful, and some people are really torn about their decision, and sometimes you just saying, look, I think you should vaccinate, is enough for them and helps them move on. Vaccinate, refer or defer. Make an appointment for another chat if you can, and plan and close. There's just a one-stop shop. You can take a screenshot of that. I think it's going to come in your materials. So it's just a single piece of information, but the Sky website also has this as well. It has something similar. So elicit, acknowledge, set agenda, elicit motivation, share knowledge, recommend vaccination, close. Okay, let's play bingo. So you're going to hear that conversation. It's a different conversation between our two fabulous actors from WA Country Health. And as you hear each communication practice, mark it off, cross it on your bingo card, and shout bingo when you've crossed everything off. Is that clear? Do you have some questions? Okay. No? Okay. Go to the next slide. It'll just take a while to play, but if you could press play, please, that would be great.
Yeah. Oh, hi, Danielle. And this is little Harper?
Yeah.
She's due a 2-month vaccines today. And you received the basic information sheet in the waiting room, is that right?
Yeah, I got that.
So what we normally do is go through some of the questions with you, and then we give the vaccines.
Right.
Today she's due the Inforex Hexa, the pneumococcal, and rotavirus vaccine. Before we go ahead, do you have some questions?
Yeah, I'm glad you asked, actually. We've been reading this stuff about, we saw this information from a doctor in the US. It's called the Dr. Paul schedule, and it talks about how to avoid overloading their system, and he does recommend spacing and leaving out some vaccines.
Okay.
Yeah, because, can her immune system handle so many all at once? And yeah.
Sure. It's an important question, and one that other parents have asked. They worry about the impact of having a few vaccines at once on their baby. I'm happy to talk with you about that. Can I just ask you? You mentioned we. You mean your partner?
Yeah, David.
How does David feel about the vaccinations?
Yeah, he's actually more worried than me. His sister had a bad reaction when she was young, so he's quite worried.
Oh, okay, of course. And you both want to do the best for her. That's totally understandable. And I want to try and address your concerns. Is there anything else you wanted to cover today?
No, that's it really.
Okay, sure. We can go through it. So just to summarise, so I'm clear on your concerns, it's the multiple vaccines that she's due to have today and whether it's better to delay some. And Dave is concerned too because of his sister's experience. Does that sound right?
Yeah, that's right.
Today, I probably won't have time to go over David's sister's situation because I don't know her particular the details of her situation. If it's okay, we can focus on the too many vaccines worry today.
Yeah, that sounds good.
All right. So the vaccines we're talking about are the combined Infarex Hexa pneumonia vaccine and the rotavirus vaccine. That sheet in the waiting room, I have it here. So the Hexa means that there are 6 diseases prevented in one injection. The second needle is for the pneumonia vaccine called pneumococcal. And then there's the rotavirus vaccine that prevents severe diarrhea, and that one's given as a drop in the mouth.
Yeah, that's the one that Dr. Paul says to delay, the rota one.
Oh, yeah, so I saw that. I think he felt that babies don't need it when the family has good access to good medical care. So if they get diarrhea, they can just be treated. My concern is that even with the access to good care, rotavirus can make babies quite unwell, and it can be pretty disruptive for the whole family. And also having the vaccine now gives her immunity for when she's older and she might travel.
Yeah, okay. I didn't think of that.
It's safe for her to get these vaccines all together today. Sure, it's a bit stressful, and seeing her have 2 needles today, the Hexa and the pneumonia. The rotavirus is just a drop, so it's not the same. It's pretty easy. But if she gets the protection on board today, she's less likely to get the diseases.
Yeah, I see your point. I guess it feels like it's quite an overload with all those combined vaccines.
Yeah, parents have said that to me. And I think back when I was delivering babies, they're actually pretty tough when you think about the whole birthing process. When they're born and they get suddenly exposed to all these germs in the environment in the everyday life.
Yeah, well, I suppose that's something we need to consider. And there is quite a long drive here too.
Oh, yeah, I see you came in from Lake Kingway, didn't you?
Yeah, that's right.
Yeah, it's a long way. Life does get in the way. I know some parents have really good intentions but don't get back, and their babies end up being late for their vaccines. Tell me, with David, how would he feel about you going ahead? Or would you like to both come back for a conversation?
Yeah, I think he's okay with it. Like I said, he does have concerns because of his sister, but at the same time, he is worried about them being unprotected too. So he said for me to make the call.
Oh, okay, that's good. I mean, it's great that you're both considering all this together. So as I said, getting the vaccines on time means she gets the protection when it's best to have it. Sure, it's a couple of needles, but you don't spread out the discomfort, and it's more convenient for you. You don't have to do that 2-hour trip all over again.
Yeah, that's for sure. And we had to stop halfway through for a feed today.
Yeah, right. Isn't that always the way? Okay, so I'd like to see her vaccinated today. What do you think?
Okay, let's go ahead.
Well done. Okay, who said bingo the first? Just grab yourself a lolly from the table. Okay. I'm going to any sort of, does that resonate first of all? Did anyone get a new tip? I mean, of course you would, but would anyone be willing to share any new tips or things they might change in their existing practices from that role play? Summarising. Yeah, so that agenda setting. Agenda setting is that whole first, third of the conversation. This is what we're here today for. This is what we'll do. Do you have some questions? Right, and do you have other questions? Okay, fair enough. Sounds like, do you have more questions? No, okay. And actually, you can ask, do you have any more questions if you want to start shutting the questions down because you need to move on. Okay, so let's chat about this, and this today. This is what we can cover today in our time available. How does that sound? Right? It doesn't have to take a long time, but little changes in practices, particularly at the front end of the conversation, can make such a difference to how you use your time in the rest of the conversation, because you use your time more efficiently addressing the actual concern of the parents. Any other observations about that encounter? So it's much more respectful to the mother than the other one, and made better eye contact and was listening better. Yep, great. The direct recommendation, you heard it there at the end. Yep. We'll grab the mic for you. Yeah, thanks.
Sorry, what I was saying is I think what is key too is that the parent feels that they're making their own decision.
Yeah.
So, that they, as adults, we like to be in control. And
Yes.
I think that's the key, is not feeling that someone else is making the decision. And the point was raised earlier. So, yeah.
Yeah. When one of the things I'd done when I was working as after I did midwifery, I ended up working with pregnant and parenting teenagers in an accommodation service, and that's where they need to be, complying with various health behaviours. You want them to stop smoking during their pregnancy, but it's really difficult because their self-determination is so important to a teenager, and to exert that's part of their development. And so for me, that's where I really learnt that form of communication, which is that guiding style, helping someone move towards a positive goal. And that's why motivational interviewing, if you can do training in it, is incredibly helpful and effective. It's got a good evidence base for it. Okay, let's move on. I am keeping an eye on time. 5 minutes we have. Just briefly about the talking with someone who doesn't want to vaccinate. So the tips here are ask permission, ASK, permission to discuss, elicit reasons for decision, acknowledge and validate the person, offer anticipatory guidance, offer opportunity to discuss again. This is the anticipatory guidance. This is from the Sky website, and if you hover over childhood vaccinations, so it's sky.skai.org.au. It's held in the NCIA's website. And it's in the I have questions section under childhood vaccination, and there's a what happens if I choose not to vaccinate. We've actually put the term choice in there. And it has some anticipatory guidance. So the parents go into that decision in an informed way because there are several consequences for them. Okay, a quick role play on declining vaccination. If you could press play.
Hi, Maria. My name is Steve. Nice to see you. And this is little...
Noah.
Noah. Great name. Hello, little Noah. How old is he?
Oh, he's 13 months and going really well.
Oh, wow. Yes, he looking really healthy. And you've come for the well baby check, is that correct?
Yes, well, we can do that too. But my main thing is this little mole on his neck. I just wanted to check that with you. So the GP wait is about 2 weeks at the moment, and we're just a bit concerned about this little one.
Sure, we can have a look at that. What I'll do first is just go through his file, and we'll do his weight and everything. I can see he came in for his 6-month check. Great. And looking at his vaccinations, there's no record of them anywhere.
Yeah, that's right. We're not vaccinating him.
Oh, okay. Is it okay if we chat about that briefly?
Well, briefly, we have been through it a lot before, though, so we've made an informed choice.
Oh, absolutely. Can I ask you what led to your choice?
Sure. Well, our first, Evelyn, just had a very overt reaction to the vaccines. So she was quiet and floppy, and she couldn't make eye contact. And yeah, it's just really scary as a parent. So that made me look into them, and then I fell down a bit of a rabbit hole trying to find the right information. And I learned a lot of things, and also about the alternatives. So we made a choice we made that choice when I was pregnant with Noah.
Yeah, look, I'm really sorry to hear about your experience. It must have been really scary. So where are you at with vaccinations now?
We've been going into town for the homeopathic drops. It's just much gentler on her immune system.
Sure. If I could summarize, it sounds like you've had a bad experience with Evelyn's vaccinations and you've gotten to this point and made a decision.
Yeah, it was truly awful, and we just don't want to go through that again. So we're okay on the current path, and we feel that we've made our choice.
Yeah, I understand. I want you to know that I do recommend she's vaccinated, but you came here today for the baby check and that little mole on his neck. So let's get to that.
Thanks. Yeah, I appreciate your understanding. We often get a hard time about this.
Yeah, I can imagine there are times it must be uncomfortable. But before we move on to the next topic, can I offer you this information sheet? It's about what to look out for. So if she gets any of the infections, you know what to do next. It's particularly designed for parents who've made a choice like yours. Feel free to take it away, read, and please do come back. Ask questions if you have any. I'm always happy to revisit the discussion on your terms. And I can always refer you to a special immunisation service in Perth that does telehealth appointments if you decide to vaccinate and want to consult on what happened with Evelyn's reaction first.
Yeah, thanks so much. I will take that.
Okay, so what I'm going to do is really quickly go through just a few more slides. So Brent and I will finish in about 2 minutes, if that's okay. So we actually did this in the Yarning About Vaccination workshops. We did similar role plays, and this is Christy Crooks and Kylie Taylor, who scripted and acted out different scenarios, but similar sort of in terms of some of the communication practices. And it was wonderful to work with communities and Aboriginal health workers and practitioners in sharing some of these insights. And then they got an Academy Award for their work as actors, as Deirdre and Lance and Verity did as well. So this will be in your slide packs from today. But this is from Maria, whose PhD was on this, as I said, who has thought about how to reduce the risk of further traumatising people who have experienced trauma in vaccination services. Staff training, safe space, avoiding triggers, and so forth. So that will be available to you, and if you're interested, you can check that out. The Sky website is sky.org.au. So many of you will know about it and use it, but it has many different resources, including for pregnancy and newborn vaccination now, adult vaccination, of course childhood as we've focused on today, addressing misinformation and talking with Aboriginal and Torres Strait Islander peoples about the flu vaccine, which was identified as a priority by communities. There's age-based information, as I mentioned. There's Q&A. What about autism is one of the sheets, and you can print off a PDF or just give parents access to the website. And there's a Sky Learning program that some of you might have done. I think you can get CPD points for that. And there's conversation guides. The other thing that promotes trust is community engagement. So one of those yarning workshops is featured at the top left in Gomeroi country in Tamworth. Other forms of community engagement featured here, which I've not gone into today. Take-home messages. Most people are ready to vaccinate. Keep doing your good work. Pay attention to pre- and post-vaccination procedures. Some people are hesitant or planning to decline. Ask, listen and understand before addressing the issues. Validate the person. Give information in small chunks. Use resources. Check for understanding. Recommend vaccination to everybody. And if they're not ready, keep it brief and close with a plan. Use the Sky resources. Just in thanking you, this is my wonderful team. Kerry and I co-lead this team at the University of Sydney, and they are committed to building knowledge around supporting the work that you do and others. And there's a QR code for Sky, and this is the next talk. Thank you.
Well, Julie, very good, very interactive. It all sent our grey matter to the gym, I'm sure. So I'm going to ask you all for another 1-hour gym session of the brain. And now welcome to the lectern, the very popular Dr. Archana Koryala, paediatric diseases specialist and general paediatrician with the National Centre for Immunisation Research and Surveillance, known as NCIS, to present a respiratory update on COVID-19, influenza, RSV and pneumococcal. Thank you, Archana.
While I'm getting ready, do you just want to stand up and stretch? Just because I know that was a fantastic talk by Julie, and I'm just going to give you a lot of data. So have a stretch. Not too long, because I'm going to give this whole chunk and check. I'll probably just give you chunks without the check. All right, let's get back in your seat. And don't worry, you'll all get PDFs of this. So I just wanted to acknowledge Lauren Dalton, who helped me put these slides together, and she's just fantastic. And she's put so much information on the slides where some I'll just skip over because then you can read on your own. But I'd also love to acknowledge that I am on Wiradjuri country, and thank you so much for having me here on Reconciliation Week, and just to acknowledge that the land was never ceded. All right, so I'm going to start with COVID-19. Okay, so the other thing that I just have to acknowledge is that I have reshuffled my slides between my presenter mode and what you see. So apologies if I read something and you can just tell me, hey, that's not on the slide. Okay, so LP 8.1, that's the current COVID Omicron subvariant that's emerging and circulating in Australia. And you might have seen this ABC article, so what is this LP 8.1? Do you remember back, a couple of years ago where we used to name each virus, alpha, and then they started giving Roman names, and then they just gave up, really. So now we just have numbers. So this is something that we see in the Department of Health releases, and you can see I find it like quite a great slide just because it's so colourful. But you can see that we have a lot of XEC circulating still, and then that hot pink LP 8.1 is emerging. And so the main question for you, I guess, is that isn't the vaccine a couple of variants before, and will it work? And I don't have the data, but there's quite good studies where they take the blood of people who've been vaccinated with the booster and they test it to this new subvariant, and it looks like, in that lab test that it works. So, woohoo, the booster will protect you against severe disease from LP 8.1 as well as all the other colours before. Okay, so this is released by New South Wales every fortnight, and I use it almost every time it's released. I have a read, and then I discuss it with my infectious diseases department, and it really gives us an idea of what's happening across New South Wales for COVID-19, flu, and now over the last couple of years, RSV as well. So you can see here that, which is the point, is there a pointer? I don't know, anyway. You can see on the top there's COVID-19 and it's on a slight uptick. You can see flu is also kind of like plateauing. There's still there's a little bit of flu around, and you can see that light blue underneath, which is flu B, and you can see that RSV has gone up and then it is plateauing. So that's where we are at the moment. That was in the last 2 weeks. So I think there'll be another one released very soon, and when we can see what's happened in the last fortnight. Okay, so now I have Slido. So hopefully we can work out the tech for that. And I think there will be a QR code that pops up. Oh, perfect. And just please answer that question. Are current COVID vaccines available in single-dose vials, multi-dose vials, or both single and multi-dose vials? And I'll give you a minute. I think we can see how many people are starting to open the app. So that's the number on the right, and then how many people have answered. So it looks like most of you have opened the app, so yay. All right, I'll give you another 10 seconds, and then if we can showcase, I don't know how that will work. Can we show the answers now, or on Slido? Can you guys see it, like on your device, in terms of who's answered what? Okay, yeah, all right, cool. No, that's questions. Sorry, I tried to be like really fancy and engage everyone, and now. Yay, nay. Oh, yeah, all right, cool. All right, so most of you answered single and multi-dose vials. And, you know, to be honest, when I created this question, I didn't realize that we had moved to single-dose vials, and then I didn't realize that we had both, but we do. So that's great that you guys who are actually immunising knew that both exist. Oh, sorry. Can we get back to my slides? Oh, yeah, sorry. Woo. Okay, all right. So you can see that that it's actually quite tricky. So really kudos to you when we're dealing with a vaccine that comes in both multi-dose and single-dose vials. And so what do you guys do in your practice? Do you order only multi-dose, or do you order single dose, or both? Unsure? No one orders COVID vaccines? Yeah, and so really the color. So you can see that the yellow is a single dose. Oh, sorry, yellow is a multi-dose, and then the blue is a single dose. So really be careful when you have a look at the actual vaccine in terms of whether it's a single or multi-dose vial. Okay. All right, so the most recent booster vaccine that we have contains JN1. We also have XBB 1.5 containing vaccine. There's no preferential use. So if they want a booster, whatever you have in the fridge, please give. And it's funded for all recommended, so for the populations that are recommended, and I'll show you who they are, it's funded, even for people who don't have Medicare. So that's still the same. So really, the take-home message for COVID is that it's a serious disease in older people, okay? So we really want to focus our immunization to those above the age of 65. It's different to the pandemic when we were vaccinating whole populations. Now, really think about the older people. And if you look at the graph, you can see that if you've had a booster in the last 6 months, it has a mortality benefit, right? So it halves your risk of dying if you're above 65 or 75 if you've had a booster in the last 6 months. And I think that's quite compelling. Okay, so who should get it every 6 months? People above 75. And really, we need to think about our aged care residents. I found that's one of the challenges in being able to immunize. It's very difficult to be able to kind of easily immunize our aged care residents for a number of factors, but they should also be getting COVID vaccines, not just the flu. Okay, so every 12 months, if you're above 65 and below 74, then think about it as a yearly. And if you are an adult with severe immunocompromise, you probably benefit from once a year. And people and children who are immunocompromised, they're eligible, but it's not a very strong recommendation. Okay, the other thing is that COVID-19 vaccines can be given with other vaccines. So how are we doing? Well, at the moment, we're really reaching only 26% of people over the age of 75. And only kind of 15% of people with immunocompromise. So it is something where, you know, it'd be a little bit better, especially that older age group, to get that booster in. And then this is just the primary course recommendations. So children who are healthy don't need a COVID vaccine dose. Children who have risk of comorbidities or immunocompromise, they can have a primary dose. And when you turn 18, that's when young people can get their first primary dose. All right, another Slido question. Should pregnant women get COVID-19 vaccine every pregnancy? Sorry, every time I bring up the Slido slide, there's always like stress on the back. Perfect. Oh, yay. Have you been able to see it on your app? Yeah, okay. At some point, just bring it up. The results. Oh, wow. It's not embedded. Brilliant. Okay, so it's a 50-50 split, and that's really great because that's why I'm here, so I can kind of update you. And also, one of our media communications person at NCERS has just sent me an article from our friendly, I've just forgotten his name, Junior, the health minister of the US, and talking about COVID vaccines and pregnancy. But the answer is no. So we don't give COVID vaccines for people who are pregnant for the protection of them during that pregnancy or for the protection of the infant. It's different to pertussis, it's different to flu, and it's different to RSV. Okay, so the reason why we give pregnancy vaccines is because we want to ensure the protection of the infant and in some cases the protection of the mother as well. During the COVID-19, early years of the COVID-19 pandemic, we knew that people who were pregnant might have had severe disease. But now we know that people who are now pregnant, as long as they've had a COVID vaccine at some point in their life, and most likely they've been infected multiple times, so they have immunity against, COVID, that they are well protected. And so severity of disease in pregnancy is on par with other people of that age. So it's not a recommendation to have it every pregnancy. Okay, again, you can give it with other vaccines, and there is no timing of vaccination after you've had COVID infection. So if you remember a couple of years ago, we would say, 6 months after, because the infection will give you immunity. That's all scrapped now. It's just too hard. Most people who have COVID probably don't even know that they had COVID. And so you just give it when they're well. And there's lots of resources on our website. So I have something really lovely for you, and I thought I'd share it.
Hello Orange, it's Nick Wood here, just dialing in to wish you all a fantastic conference today. I know you're in great hands with Arch and Dee. All the best.
Yeah, I thought I couldn't do a presentation without having, lovable Nick Wood say a few words. Okay, so we're going to talk about flu now, and this is what the Department of Health publish annually, the year following the previous year. So you can see 2024, and 2024 is that dashed green line, and compared to the previous years. They've excluded the early years of the pandemic because there's no flu circulation. And you can see that it was a pretty standard year for flu. It occurred, at the time when we think the flu season is, but it was quite prolonged, right? It was quite big. So it was quite a big flu season, for us last year. And then when you look at the ages, you can see that in New South Wales, the ones that were predominated were the children and adolescents. So they were the highest notifications of flu. And when you think about the sublineages, so we had a lot of flu A, and it was the flu A pandemic 2009 strain. And we had a bit of flu B, and then some weren't tested. So when we think about the vaccine, we always recognise that it is a component vaccine. So you have both A and B, and we had a bit of both circulating last year. Okay, so now I really want to give you a case, because there's a lot of policy stuff, recommendation stuff that we all talk about. But when, some of you might work in the hospital, and I sure do, and really thinking about the story or the human impact. So I saw an 11-year-old boy who was referred by the GP for abdominal pain. They did a really good history of the pain, and the GP was a little bit worried, so he sent him to the ED. And in the ED, he looked very well. Initially they thought, oh, could he have appendicitis? But he tolerated food and drink, and he was much improved, and then he was discharged home. Within 12 hours, he presented to ED with intractable seizures. He had to be intubated in the ED, fluid resuscitated, and multiple antibiotics given. And I know you guys don't look at CT scans a lot, but this was his CT. And for those people who have seen a CT, there's usually what we call ventricles. So the brain needs to sit in the CSF or water, and so there's nothing there, and there's a lot of inflammation. So his whole brain is inflamed. And why do I talk about this? It's because he was flu B positive, okay? And his brother was actually flu B positive too, and he was well, and we admitted him and gave the brother of Tamiflu. We gave him an antiviral, but he went into fulminant. He was basically declared brain dead, and he passed away. So this happened, and this happened this year. Okay, and children, it's not just a pneumonia. They don't get just a pneumonia. Children, adults can get severe neurologic disease from influenza, and this is an article, an Australian looking at Australian data, 10 years, 2008 to 2028, and if you get neurological flu, you have a very high chance of dying. And why is this important? Well, last year's season in the US was big, okay? So there's lots of graphs. You can see everything trending upwards. So a huge amount of flu in the US winter, right? So till that, and you can see on the green graph that influenza-associated pediatric deaths also going up, okay? And so the CDC released this, and it's reported that they've noticed a rise in influenza-related encephalopathy, so neurologic disease has gone up last year compared to the previous years. And I know the table's a little bit busy, but in that red box you can see that out of 68, and this wasn't the whole season, this was partial season that they calculated, they had 68 deaths, and then 9 of them were neurological disease, so influenza-associated encephalopathy, and that was 13% of their deaths, right? And if you look at the numbers a bit higher, it's higher than the years before percentage-wise. So we're really worried about neurological disease this season, okay? So that's another reason why we really want to make sure that we protect our children. This boy, he was 11, so he wasn't on a funded schedule, so, but it is something that we are worried, and it's something that we should discuss with our clients and participants. Okay, so now I bring to the flu vaccine. So we know that effectiveness varies year on year. It's not like an MMR vaccine with a 95% effectiveness. We love it when it's above 50%, right? And really, and that depends on the year, the matching population group. But it still consistently shows that it reduces disease severity and absenteeism. I've already shown that one. Okay. So what was it last year? Well, it was actually on the better side. So if you got the flu vaccine last year, it was 62% effective against GP attendance, 56% against hospitalisation. It was similar between the A and the B, and the two different A types. It was really hard to estimate B because there was very few B cases in Australia. And why was it a good match? Well, we think it was because the choice of the antigens that went into the vaccine was good, and it matched what was circulating, and it was a pretty robust season, so earlier than some late ones. So it allowed people who were vaccinated in April, they had good immunity for when the flu was circulating. Okay? All right, so another Slido. The 2025 seasonal vaccine. Oh, this is a double Slido, so I don't know how that's going to work. So let's do the question 3 first. So it's a 2025 seasonal vaccine is trivalent or quadrivalent? Okay, I can give you 5 more seconds because you're like super good at Slido now. Woo! Okay, all right. Yes, it is quadrivalent, and I'll go through that in a couple of slides, and I'll talk about the trivalent. And then the next question is, 2025 seasonal influenza vaccine protects against avian influenza. True or false? Sorry, I put all these questions in because, you've got to make it a little bit more interesting. Oh, that's great, the picture as well. I didn't notice. All right. Okay. Okay, perfect. You guys are so good. All right. So there's no changes to the eligibility cohorts for the NIP funded vaccines. So the people that were funded last year, they're funded again this year. It's recommended for all people aged 6 months and above. And there are a number of different vaccines available, and the adjuvanted high-dose vaccines are recommended for our older Australians, so 65 years and above. It is not protective against avian influenza. However, there is a recommendation for people at, in occupations, so the occupational risk groups, in particular people that work in chicken and egg farms, to get the usual standard flu vaccine. And that's because we don't want them getting the flu, their chickens getting the flu, and then the 2 flu mixing and becoming another flu, right? So that's the rationale. Okay, yeah. All right. And then there is, and the whole discussion about quadrivalent versus trivalent. Well, it's because in our quadrivalent strain, we have 2 A's and 2 B's. And one of the B's, through COVID, just disappeared. So B Yamagata does not exist anymore, but our vaccines still have it. And so there's a move towards making a trivalent vaccine, and I've got a slide on that. Okay, so last year, how did we do? We got to 24% in 6 months to 5 years, and around 58% for those above 65 years. But, I saw the data that was presented earlier, so you guys are like leading the way. So good on you guys, much higher than that. Okay, good. And then where are we at? And this is at 17th of May, so it's slightly different. We're kind of still lowish. It's good that we're getting at least around almost 50% of our 65 years and above, but our younger kids are still a bit low, and we really need to push that up because of this this neurological disease and related influenza as well. Okay, so when do you give it? Ideally before the onset of each influenza season and when the vaccine becomes available. You should also talk about flu and people that are traveling internationally. So if they're going to a Northern Hemisphere flu season, then they can also get the flu vaccine, even if they've had the flu vaccine, to protect them against Southern Hemisphere flu. And yes, you can give it with all the other vaccines, and you can give it in pregnancy with all the pregnancy vaccines as well. So this is just reiterating what I said previously. A second dose for travellers, yes, please give. They'll have a different flu vaccine that will be recommended in the Northern Hemisphere, because the vaccines are slightly different just depending on global circulation of virus. But for a traveller to go to a country, let's say they're travelling to France and then to get access to, GP there to get the flu vaccine, it takes around 10 days to be protected. It's not going to happen. So it is something that we would recommend discussing with patients that are traveling, as well as other vaccines, in particular MMR, right? Okay. And then egg allergy. So yes, please just give it. Don't need to refer to a specialist immunisation clinic. There are egg-free vaccines. So Flucelvax is produced in cell lines, and if the patient would prefer that, you can just give the Flucell vaccine. But we know, and I've shown you guys this before. It's a fact sheet. You can give it to the patient. Even in egg anaphylactic individual, the amount of ovalbumin in an egg-based flu vaccine is so low that they wouldn't even react. Okay. Yep, so egg and cell-based available in Australia. No preference for a standard dose egg or cell-based. The adjuvanted is all egg-based. So that's not grown in cells, it's grown in eggs. And this is our transition from quadrivalent to trivalent. So Yamagata not circulated. In late 2023, WHO and the Australian Influenza Vaccine Committee said, yeah, we don't need it in our vaccine. And then manufacturing takes time. And so from next year, potentially trivalent vaccines will be available. All right, so question 5. The 2025 adjuvanted flu vaccine should be separated, i.e. given on another day, from Shingrix. True or false? That man looks like he's just living a good life. He's probably had all his vaccines and he's cheering. All right, we can show the data. Yay! Oh, you guys are on top of it. Brilliant. So it used to be a recommendation, if you remember, to separate it, and that was because we knew that both vaccines are likely to be reactogenic, so they feel malaise, they feel a bit off, and we were introducing Shingrix to the population, and we wanted to just kind of get a little bit more data on attribution of reactogenicity. But now we can give it with the adjuvant vaccine. And this is just hot off the press. So there's a huge document on NCR's website as well about the co-administration of vaccines, and it's a couple of pages. And you can download it from the website. Oh, okay. Yeah, all right. So there's, okay, so now I just want to talk about, this is not available in Australia, but I know you guys are just so on top of the data and you always ask us really curly questions. So I wanted to talk about the live attenuated flu vaccine. AstraZeneca looks like they're putting in an application and we might have it next year. And I went to ECMID, which is a big European conference in infectious diseases, and I went to a talk where our colleagues at Public Health England and in Spain, they discussed the flu mist. So it's called flu mist, and it's a vaccine where it's a live attenuated, and you just insert it into the nose, and it's been shown to be quite easy to administer in children and highly and protective. So when they rolled it out, they actually rolled it out in certain pilot schools. So that it was a school-based program in primary schools, right? And they went in and they found that in these districts where they did that, it decreased primary school GP presentations by 94%. It decreased, A&E so ED presentations by 74%. It decreased hospital presentations by 93%. This is absolutely ridiculous, yeah. And then it actually had an effect where it decreased other so older people presentation to GPs as well for influenza-like illness. And this is Spain, where they were able to get 60% of their age cohorts flu vaccinated through these programs. And so the effect was seen because of that really huge kind of coverage. And it was well accepted. And these are places where, there are measles outbreaks. So people are, the measles vaccines rates are nowhere as high as what we have in Australia. But it seems to be accepted, because it's not a needle, it's something that's given, and what Julie talked about, belonging, everyone in the school's kind of just doing it, so you kind of did it. So it was a very compelling data. All right, so we also have a whole cohort of information, and you'll get all these slides. And what is this? So avian flu, yeah. I just thought that's, again, a little side note. You probably don't need it in your practice, but I just wanted to show this. This is fascinating. So, we live in a globe and we are not, exempt from diseases that affect animals. And I know Victor's going to talk about some arboviruses later, but, this is high-path avian flu. And you can see the journey that it has taken to become a global kind of pandemic, really. And so it kind of started probably North Africa, and then it crossed the Atlantic, and then across the Pacific, and then down, and then it's gone into Antarctica, and it's kind of infected birds in the subantarctic islands. And it hasn't yet, the only place that it hasn't affected is Oceania. So, but we're very close to that subantarctic island, and a couple of Australian subantarctic islands, they're checking to see, if any of the birds are infected. It doesn't cause disease in humans in general, right? So if so very few humans globally have been infected with avian flu. You can see that one in Australia, and that was a traveller from India who's a child, and they just picked it up because he had flu A, it did fine, went home, and then when we routinely sequenced the viruses, they realised that that was the high-path avian flu. But you can see that if it does cause a disease in humans, it can be quite severe. Okay, so take-home messages is that the current flu vaccine doesn't protect against avian influenza. There are global works to develop vaccines for avian flu, and then two, that it is a huge issue. So even if it doesn't affect humans in general, it's a huge issue in the animal and bird populations. And three, if you have someone who's working with in high occupations, and we've got other avian flus in Australia, with chicken culling, then they should get the standard flu vaccine. Okay. All right, so now I'm going to talk about RSV. So I'm so excited as a pediatrician. RSV has been huge. It's something that we learn day one. Like, you will see bronchiolitis, you will see RSV. It's kind of like, in the 80s or the 70s where they say you will see epiglottitis, you will see Hib meningitis, right? So that was me for RSV. And you can see that so the top graph is age groups, and it's still very much a disease in the very young, right? And it's superb that we have a vaccination program, so we can vaccinate pregnant women to protect their infant, and we can give long-acting immunoglobulin or nirsevimab to the infant to protect the infant themselves. And of course, we have 2 vaccines that we can give our older Australians. Yeah, so let's not forget about the older Australians, because it is a cause of hospital admission in older people. Okay, so the funded vaccine program, as you all know, is to protect the infant, right? So we want to give a Brisvo only. And it's really tricky, isn't it? When you go to AIR, there's like a Brisvo, a Rexv, they're like so close together, and you just need to click the right one. And then if you're an older Australian, then it's recommended, the recommendation is 675 and above, but you can access it if you're now Rexv actually 50 and above. And they need to buy it. It's recommended in Aboriginal and Torres Strait Islander people, but they also need to purchase it, and for people who have medical risk factors. Okay. So it's a dual program, right? How's that going? So it's a dual program, and I find it's a little bit challenging in that you have to look at the maternal AIR record to understand if the baby is eligible or not eligible for nirsevimab, and also you have to look at maternal health, not just vaccination, to see if the baby needs nirsevimab as well. But the uptake seems to be quite good, and it's recommended for women 28 weeks and above. You can give nirsevimab to babies at birth with the Hep B and the vitamin K as well. The funding is separate. So the maternal vaccine is funded by the National Immunisation Program, but all the states and territories came on board to provide nirsevimab to infants. So it's no longer, like last year we talked about postcode equity, right? Like if you lived in New South Wales, then a certain population got it. If you lived in Queensland, everyone got it. If you lived in Victoria, no one got it, right? But now it's a little bit more equitable in that for the patient, no matter where the funding is from, the eligibility criteria is universal across Australia. So there's some beautiful information sheets that New South Wales Health have produced, and it really goes into clear like who is eligible for what. And remember, and this is not a question, I should have put one in, but if a woman has had the vaccine and then delivers a week later, is the baby eligible for nirsevimab? Yes. So what if the baby was born 3 weeks later after the vaccine? What if it was 2 weeks later? Yeah, so it's at 14 days. Yeah, exactly. Yeah, no problems. And what if the mum was on a biologic immunosuppressant? Would you give baby nirsevimab? Yeah, Yeah, and it's all about, you know, just to have a think about, will the mum make the antibodies to protect the baby, right? So if they haven't had time to create the antibodies, then you need to give the antibody to the baby. Or if they have an immunosuppressive condition, whether it's themselves being immunosuppressed or if they're taking a medication to immunosuppress them, then the baby will need to get the antibodies. Okay, so we have had RSV administration errors, you know, because it's a complicated program with vaccines that are very similar in name and a monoclonal antibody as well, and so there have been checks and balances, but we have had errors. So this is now a word cloud. So what are some innovative ways to remember who is eligible for which RSV vaccine? There's no right answer. I'm actually trying to think, like you guys are on the coal face, and how do you remember it? I know, you can even shout it out. It's a... AB, sorry? AB for the pregnant lady. Oh, that's a good one. AB for the pregnant lady, yeah. The flow chart, yes, that's always good. B looks like a pregnant lady. A is for adult. That is true, so don't give anything with an A to a infant. Smart. Lots of flow charts, that's good. A Brisvo embryo, yeah, cool. Bay Fortis for babies. Yeah, that's a good one, I like that one too. Check and double check, that's really important too. Perfect. Nirsevimab, nursing baby, yeah, cool. Can someone take a screenshot of this? I quite like it. It's good. Yeah, so I can show people at NCERS. AB pregnancy. Yeah, that's good. That's good. Oh, perfect. Great. Okay. So we developed one as well. So we kind of similar to you. We said Brisvo sounds like embryo, and then B is like a pregnant lady, and we just remember that needs reconstitution. For the Bay Fortis is B for protecting the baby. It comes in a pre-filled syringe, and you order it for an individual patient. Arexv is X, this is XYV, the end of the alphabet. Yeah. So the older adult greater than 60 years, and that needs reconstitution. So lots of different ways of kind of remembering, but they're all really good tools, hey? The other thing that I forgot to mention is that so Nirsevimab is a newborn program, but also we give it for vulnerable older infants entering their second season, and that has actually caused a lot of questions to us in terms of who is eligible, who's ineligible, what dose you use, and so there is that criteria, and in essence, it's for children who will likely decompensate in the second season. So it's for people with chronic lung disease, congenital heart disease, severe immunocompromise, you know, that population. And if you're unsure, just ask, because it is a little bit confusing. Okay, so this is great news, and I know it's only like a tiny bit, but because of the program, so this is PEDS data, so RSV hospitalization nationally. And the blue curve is 2024, and the red curve is this year, it's the Epi Week. And, you know, we are kind of, you can see that the notifications are lower, and the hospitalizations are lower than what we have in 2024. It's very crude, it needs to be kind of further analyzed because different RSV seasons have different kind of rates through the year, but it is fantastic. And this is something else that's on. This is on our website, and you can see. So on the left-hand side, that was 2024 April, and then you can see 2024, 2025 April, and it's like half. You know, the amount of hospitalization in all age groups. And then if you look at the under 6 months, also it's half the amount of hospitalizations with RSV. So that's fantastic. The other thing that we're doing at NSWIS is that if a vaccine error has occurred, then to an infant, then we like to follow them up. So you can, send anyone that's an infant that's received a maternal or an older Australian vaccine. And then we usually organise a telehealth, so Dee and our fellow does that. And this is just to document any adverse events following immunisation and just get some information locally so that, you know, we can put it out to say these vaccination errors have occurred. And of course, we want to minimise that and understand why that occurred and not to replicate it, but also to provide families when it has occurred that, okay, it's occurred in these number of situations and these were the consequences seen, okay? All right, so we have lots of FAQs. I'm not going to go through every single one of them, but just remember over 28 weeks. Yes, this is something else that has occurred. So if the mother gets a Arexvy instead of a Abrysvo, then at the moment we're saying you don't need to give the Abrysvo. They've had an RSV vaccine. And nirsevimab may be given case by case, okay? So if a mum has been given Arexvy, then you don't need to repeat it. You do need to report it, and you can contact us at NSWIS for advice on the infant, okay? And if Abrysvo is given before 28 weeks, then that's okay because it's actually registered in Australia from 24 weeks onwards. It's recommended from 28 weeks onwards, but it's registered for 24 weeks onwards. So they don't need another vaccine in pregnancy. Okay. If they come to you at 36 weeks and 2 days, right? And you've missed that window because the recommendation is 28 to 36 weeks, that's okay. Give them the vaccine, you know. If they deliver within 2 weeks, the baby will get nirsevimab, but if they deliver within 3 weeks, then the baby's protected, okay? Yeah, and it's fine to be co-administered. And yeah, the other question that comes up is, what about my family member? You know, if they're an older Australian, then yes, they can get the vaccine. But no, your sister who's not pregnant, who is 2 years younger than you, should not get the RSV vaccine, okay? And then for nirsevimab, give it after birth. In neonatal ICUs, they usually do it at discharge. And the protection lasts for at least 5 months, and there's really good data to say that it actually probably lasts for over a year. So it's a fantastic monoclonal antibody. And then there was this is a change to the recommendation. So if the infant has had RSV and hasn't had nirsevimab, then you can still give them nirsevimab once recovered. That was different to last year, because last year we had very few doses, and so we said if someone's had RSV, don't give it because they've already had the infection, they've got antibodies. But now the recommendation is regardless of infection, they should get nirsevimab, okay? And all this will come in your handout. Okay, so what about older Australians? So protection peaks soon after vaccination and lasts multiple seasons. We can see that now. Exact timing is less important, but can be timed pre-RSV, and continue to offer the RSV vaccine throughout the season to people who are eligible. What about booster? So someone said, I got Arexvy last year. What do I do this year? So the booster's not recommended as yet. It might change, and this is depending on the data that we accumulate, but we know that it protects most likely for at least 2 years, so no booster recommendation at the moment. And yes, you can co-administer. So this also is just hot off the press. We've got safety data sheets. So we talked about the Sky, but we also have really good AUSVAC safety data sheets as well. So this is from Abrysvo RSV in pregnant individuals, and it shows that majority of women who get the vaccine are fine. Around 5% do report missing work, study, school, or routine duties. And the majority of adverse events following immunisation, like in the short term, is that local reaction. They can get a bit fatigued, and 10% get a headache. So this is a really good information sheet to give women as well. How are we doing? Well, since it became funded, the uptake has been very good. You know, you can see that going up. And most people who are giving the Abrysvo vaccine to pregnant women are in the general practice, okay? With a number of people getting it through their antenatal care through the hospital, and some even getting it through pharmacies as well. So it's really, we've got a diverse kind of mode of receiving the vaccine, and I think, but it really doesn't negate that general practice giving the bulk of vaccines in pregnancy. And yeah, these are just the number of doses given. Okay, we have loads of RSV immunisation resources, and I think we have heaps in the back as well, right? Yeah, and we've got the Sky resources in the back as well. And there's clinical guidance on RSV product administration errors as well. Okay, I'm not going to go through this because it's stuff that I've said before. And these are the respiratory virus conditions that put you at higher risk for these viruses. And this table's great. So when you get the PDF, just maybe print that one out and put it in your practice, because it looks at all the different flu. So flu, COVID, and RSV, and which conditions are eligible for which vaccines. Okay, so now I'm going to talk about bacteria, you know. So we know that the bulk of winter, it's viruses that cause havoc, but pneumococcus is a bacteria that can cause severe pneumonia, can cause meningitis and ear infections in young children. And the pneumococcal vaccine program is ever-changing, ever-complicated, right? Yeah, and it is due to change as well, so I'll probably have different recommendations next year. Okay, yes, so number one, the optimal pneumococcal vaccine program is currently under review, and the chapter will be updated, so we'll have different recommendations. And the main recommendation changes are because of what we call serotype replacement, right? So we immunize against 7, then 10, 13, and most of the vaccine works really well. For certain serotypes, it doesn't work as well. And then pneumococcus is smart, so they're like, oh, well then we'll just have another serotype cause infection. So it's called serotype replacement. And then vaccine manufacturers have realized that, and so they're making more polyvalent vaccines, so with extended serotypes. So interim recommendations for extended valency vaccines, so 15, 20 should be quite accessible now. It used to be hard to find, you know, in pharmacies. But, you know, if someone is willing to pay for it, then my recommendation would be to get the extended valent conjugate vaccine over just the 13. And then 21 extended valent vaccine has also received TGA approval, but not available yet. And there's also a new resource, recommendations for people who have already received a pneumococcal vaccine. And someone previously also talked about the PneumoSmart, and I use that too from the Immunisation Coalition. Okay, so we've had over 2,000 notifications of IPD in 2024, and that's the highest number in 20 years, right? Notifications were 5% higher in 2023 and 22% higher than in 2022. So pneumococcal disease is on the rise. Okay, most cases were in adults aged 65 and above, and in children 0 to 4 years. And most frequent reported serotypes were serotype 3, 33F, 22F. And serotype 3 is included in the current immunisation schedule, and the other ones are not in the 13th valent conjugate vaccine, but are in the 23 valent polysaccharide vaccine. Okay, I only have a few more slides left. So I will definitely stick to time. Okay, so you can see that coverage is increasing, so great, but it's not kind of universal. So we're still only reaching around less than 50% of people eligible for free pneumococcal vaccine. You can see that the recommendation in the NIP, well, what is it for Aboriginal and Torres Strait Islander? At what age? Someone? 50. Yeah, so we're capturing them later. And that's always really hard, I think, when it's
difference in the immunisation program between non-Aboriginal and Aboriginal people. We saw with Men B, Men B coverage is lower, and so when it's a targeted population, it's always very hard. But we are getting almost 50% in Aboriginal and Torres Strait Islander over the age of 70, which is great. Okay. So a question that comes to us, and you guys are like all over it, is PCV and PPV interchangeable? No. They're very different vaccines, right? One is conjugated, one is non-conjugated, and so you can't give a PPV in replace, because you just don't have a PCV as a replacement of the PCV. Co-administration, so the underlying thing for co-administration is that anything can be co-administered with anything else, okay? So that's good. And remember that there is that recommended interval between a PCV and a PPV, and that's 12 months. Okay, so this was also from ECMID, so I took a screenshot, and you can see that's 13, 15, PPV 23, PCV 20, and then there's this new one, V116, where they don't have the standard serotypes that are in 13, but they have an extended one. And so it's not something that's available, but it's really exciting, because perhaps you could give 13 and this new vaccine, and then that person might be protected for a lot more serotypes, okay? So that is a in review, maybe coming, we'll see, kind of thing. All right. Well, thank you very much. So that concludes the respiratory viruses and pneumococcal part of the session. And I think we have a QA part.
Well played, Archana. Thank you very much. The data nerd in me was very excited. Well, before we do go to lunch, just a reminder, when it is lunchtime, I've been told there's additional seating. When you go outside, there's a little bridge you can walk over. There's additional seating if you can't find it, but trust me, it's there. But I want to now welcome, we're going to have a quick Q&A session. So if you haven't added some questions to the Slido, please do, because I think that's going to be our central mainframe. But you are welcome. There's going to be some roaming microphones. Hand up, roaming microphones. 1 and 2, the very back there, Erica. So please welcome back to the stage for a Q&A session facilitated by Belinda Tracy, Manager Immunisation and Communicable Disease, PHU, WNSW, LHD. So you can raise your hand if you like, and the team will all submit with Slido, and I'll address them. We have until 1:10, Belinda, so an extra 5 minutes or so. Off you go.
Thank you. Hello, everyone. If you don't know me, I am Belle, so bear with me. I'm going to try and cover a lot of presentations in about 7 minutes. So I do have the Slido in front of me. Roaming mics are out there. So I suppose it's a big recap. We've had some wonderful presentations, and I thank everybody that's participated so far. So let's wind back the clock. We've had Priscilla come up and give us some data. We've had Kendall do our oopsies. We've had the girls introduce what's going to finish this afternoon, so we can skip that. We'll go there. And Julie's wonderful presentation, now Archer. So if there's any burning questions from the floor, pop your hand up, the mic will come to you. But I think they're going to stay in their seats, and we'll hit them with questions as we go along. So I'm looking at the Slido. Archana, you've raised lots of questions for RSV. Does someone want to give a mic to the corner, perhaps? So, will the RSV vaccine be available for young children on private script? We have parents that are very keen to have their under 2-year-olds vaccinated.
So the RSV, there is no infant RSV vaccine, okay? There have been trials looking at giving the vaccine for very young infants, not immunisation in terms of immunoglobulin, but giving a vaccine, and it just hasn't worked. So there is no, so it will not. The answer is no. To protect your infant, mothers need to get the vaccine to protect them for at least 6 months, and then there is that nirsevimab.
Thank you. And while you've got the mic,
yes. Oh, nirsevimab. Oh, okay, so immunisation, yeah. They cannot. No.
Okay, so with RSV, are over 65-year-olds going to be able to get vaccine free potentially in the future? Or can vulnerable adults over 65 potentially receive RSV vaccine as well?
It is not funded at the moment. So for funding, it requires the company to put a submission to the PBAC and then the PBAC to look at cost effectiveness. They did that previously and the government deemed that it wasn't cost effective. So it might be in the future, but for at the moment, it's not funded, regardless of vulnerability in that age group.
Thanks, Arch. Okay, Kendall, one for you, darling. Oh, we've got different questions coming on different phones. Oh my God, the pressure. Okie dokie. So we've had confusion recently with vaccinating a pregnant woman with Boostrix versus Adacel. Are these the same, interchangeable? And is that the same scenario for Year 7 vaccination?
So for pregnant women, absolutely interchangeable. Go to your immunisation schedule and it's there. It says Boostrix or Adacel. For the school program, there's two answers to this question. So if somebody comes to you in a community health centre for a catch-up, give them whatever you've got. But for those of us who are vaccinating in the actual school program, we have to use Boostrix because we cannot record Adacel on the computer system. So it has to be, if you're doing an, say out at Condo or somewhere like that, doing a school clinic, you cannot use Adacel. So if you haven't got any Boostrix in the fridge, you can't do the clinic.
Thank you, Kendall. Okay, wow, they're all coming in now. This is great. I'm not sure who would like to answer this question. So ears peeled panel. If a child has a Hep A vaccine at the age of 4 and has now had an adult dose at the age of 21, considered dose 2, would you recommend another adult dose?
I don't think we talked about Hep A earlier, did we? So that was a bit of a random.
It is a random. I do apologise, but let's hit it.
Okay, so I guess it would depend on what their risk profile is. So what activities are they going to be undertaking? Are they travelling? What's the purpose of vaccination? You know, you might actually err on the side of yes. You know, it's been an extremely long time between doses. So we know that second dose does provide them with more long-term immunity. So at the end of the day, you know, you do your risk-benefit assessment and it'd probably be up to the individual decision of the vaccinee.
Thank you.
I've had that situation, and I know someone that had that situation. They just had serology done, and it said they were immune, so they were happy days. I mean, a third shot wouldn't hurt you.
And that's it. And I think it is. It's that risk assessment, isn't it? Let's just see what's going on and make a decision case by case. It's a bit grey. Sometimes we've got to live in the grey.
Because you know how like the handbook says, you know, because like we get it all the time with Shingrix, you know, someone will give a dose and then it'll be 1-2 years later they'll come back and people go, oh, do we start the schedule again? And I know the handbook always says don't start the schedule again, but then that is a big period of time. So I know that's why that person decided to have serology and they were immune to Hep A.
Thank you. Kendall, I'm going back to you. Hold on to your seat. It's okay. Is there a specific reason why ACWY is given to Year 10 group? Why not do in Year 9 when kids aren't trying to get out like our Year 10s do? I couldn't agree more.
Might be an Archana question. Maybe she knows about that.
Yeah.
I think Year 9, Year 10. I mean, some kids are the Year 10 age is another kid's Year 9 age. So it's you just have to pick a year, right?
Yeah.
And so if the Year 9 wanted a men ACWY through the GP practice in Year 9, that's fine. You know, the reason for Year 10 is because we know that meningococcal disease increases in that late adolescent and university, college, post-school years. And so we want to make sure that we give that 5 year, because we know that that there's good data that suggests that there's a good protection for 5 years, and that's the rationale, is that it extends that protection into that post-school adolescent age group.
Thank you. Now, there's a question here a bit about Guillain-Barré. It's not quite specific about the vaccines, but the question is, if you've had Guillain-Barré, are there any vaccines available?
Yeah, so Guillain-Barré, for people who don't know it, is it's like a neuropathy that occurs, and it's post a certain trigger, right? So there are lots of things that can cause Guillain-Barré. One of the most common things that cause Guillain-Barré is actually Campylobacter gastroenteritis that can cause it. It has been associated very rarely with certain vaccines, in particular, pandemic flu vaccines in the past. There is an alert that the TGA has flagged to say that there have been very rare cases of Guillain-Barré with the RSV vaccine, and this has occurred in older adults. There's been no cases in pregnant women. So the answer to the question is, just because you got Guillain-Barré from a certain trigger doesn't mean anything else will cause Guillain-Barré. So it needs to be an investigation in terms of what was the trigger for Guillain-Barré. So we have a flowchart on our website that shows flu itself is a pretty kind of strong trigger for Guillain-Barré, flu infection. And so these people are actually recommended to get the flu vaccine to protect you from getting flu that could precipitate Guillain-Barré. So it's context specific.
Perfect. Thank you. Okay. How are we going for time? Have I got time for a few more questions? Okay. Why is the flu vaccine not funded for all? This would increase the uptake and reduce the impact flu has on the health system.
I don't know if Priscilla wants to answer that, but I didn't go through the data per state. You can see that the flu vaccine was funded in Queensland and in WA for everyone. And unfortunately, the uptake was exactly the same as New South Wales. And so it's great that, to make it free, but it didn't increase people getting the vaccine. So there are other drivers.
Yeah. Can we just get a mic to Julie behind you?
So this is something I asked Christine McCartney about last week as well. So absolutely the coverage in those two states didn't change. But as I understand it, the reason that it isn't free for all over 6 months on the NIP is that it has not had a sponsor put it to the PBAC for funding on the NIP for all of those age groups. And that some years ago there was a sponsor for all people 50 years and over. And it was actually a university group that sponsored it. Normally it's an industry group. And it's very expensive to sponsor because you have to do all sorts of assessments to present to the PBAC. And that was knocked back for all adults over 50. Now it might change, but currently there hasn't been a sponsor for the all people 6 months and over. So I believe that if it were free, they happened to assess that it was cost effective for all people 6 months and over in Australia in the future, that we would see an increase in coverage, including in the at-risk groups, because you'd have over some years, people would get used to that more generalised recommendation. The systems would get used to it. And it takes a while for the more generalised recommendation to really start to be implemented. This variable state-based funding, it's well intended, but it's not really going to move the dial on coverage unless you have it established in the national systems and processes.
That's amazing, isn't it? But yeah, it would be ideal, wouldn't it, to have a all-of-age access for free vaccines for flu. Just looking at Archer's data, like our our young children really need to be picked up in that space so we can prevent serious illness and hospitalisation.
Yeah, that's right. So I specifically quite concerned about the 5 to 15-year-olds because we know that notifications are very high in that age group, and they're minglers, and you get really severe disease. So, it's just not funded for that age group, even though the notifications are quite high in that age group.
And our vaccination rates are quite low, and yeah, it goes hand in hand. Great question. Okie dokie. Does anyone know the price of the RSV vaccine for over 65s? Oh, hang on.
$320.
There's a barrier.
I had a couple in their 70s that had their injections yesterday, so that was $640 that they had to pay.
Wow. Significant. A big investment in your own health, though, will be positive. Okay. Oh, one more. That's hard. There's so many good questions. Why is the COVID vaccine not listed on the NIP? That's a loaded one. So COVID vaccine still sits in the Commonwealth space, not the state space, is pretty much the quick answer. So watch this space. It will probably move and come to state management, which may be a fabulous thing because it'll change your ordering. Hallelujah, no CVAS. So that's pretty much it. I'm getting wrapped up, but if there's any burning questions, put your hand up really quickly, grab a mic and ask a hot question. Otherwise, I'll take note of what's still on Slido and we'll get to them this afternoon. It's chunk after chunk. One arm is up. This will be the last question, and then you can have some lunch.
It's just a question about ordering the RSV antibody, monoclonal. Why do we have to individualise people in the ordering system? Like, it's really clunky.
Are you going to answer that? Was that nod?
Me? No,
Yes.
I've got another one that I'm just going to really quickly answer.
Arch?
Yeah, I agree. It's very clunky, and I find it really hard. And I think it's based on the fact that it's not a vaccine at the moment. Yeah, because it's an immunoglobulin, but we find it quite tough.
I think they're all trying to collect data at the same time too, because it's a new program.
There also has been an allowance to order up to 5 at a time. So when I first didn't order, I ordered 8 individually. It took me an hour. But now you can at least order up to 5 at a time. And if you need more than that, you can actually contact the PHN and we can see if we can facilitate a bigger order. But your order number shouldn't be huge anymore because they're doing such a good job in the antenatal space too.
Yes. Vaccinate our mums. Kendall, quickly.
Very quickly, just noticed that there was a question on Slido that says, is there a reason why Year 10 students now get Menquadfie and not Nimenrix? Is it a supply issue? That kind of follows on from what I was talking about before. It's a contractual thing. So we now get Menquadfie in the school program. We cannot record Nimenrix. If you've got Nimenrix in your surgeries and a Year 10 child comes in, just give it to them, that's fine. It just has to be given in the school program because we just can't record the other one because the contract is now with a different company.
Thank you, that was speedy. All right, so off to lunch, and I think we are expected to return at 10 to 2.
So we welcome back Archana. She's going to present an update on the Australian Immunisation Handbook, zoster, meningococcal and measles. The next chapter awaits. All yours.
All right. There we go. I might start. So welcome everyone. I'm going to be talking about everything else besides respiratory viruses and pneumococcal in 30 minutes. No, we've just handpicked a couple of things that I think are just some updates that have been kind of over the last year. And just a shout out to Dee, she's going to be talking about the update to the immunocompromised chapter. So it was a huge overhaul, and so there's a beautiful new chapter in there that goes into the immunocompromised host in much more detail. And so Dee will talk about that. Okay, so again, acknowledging Lauren Dalton, who does so much work for us in putting the slides together, helping us put the slides together. Okay, so I don't know how it projects, but it will be in your handout. So there's been a number of updates since I was last here. So August 2024, the pneumococcal page update reflects the availability of 20 PCV in infants and children from 6 weeks of age. Okay, so they are eligible for the extended valent pneumococcal vaccine, not funded, just in the private market. In October, there was the removal of the age restrictions in the Mpox vaccine recommendations. Before it was not for children, but now that's been removed. I don't go into it, but if you've listened to Mpox lectures, you know there's been a global Mpox amongst the MSM population, etc. But really, the bulk of Mpox has been in the African continent and has affected children, and so it's great to have that removal of age restrictions even in Australia. Updates to the zoster pages to reflect recent changes in eligibility under the NIP. So I talked about, I think I mentioned that was coming last year, but now people, and I think I've got a couple slides, who are on immunosuppressants are eligible, so that's great. Removal of true MENBA from the meningococcal pages and addition of clinical guidance for ACWI or MenB and information for Bexsero doses. So that occurred in December. And then the RSV pages were updated in January, and as per usual, the COVID and flu updates come in March and April, and then just a couple of weeks ago, there's this whole new chapter on vaccination of the immunocompromised host. Okay, so let's talk about zoster. So again, I don't know how good this projects, but you can see that there's been additional risk groups in the NIP funding, expansion for Shingrix. So we have people with inborn errors of immunity that are eligible. So and people on immunosuppressants. Where is that? Why can't I see that there? Can you see it, Dee? I don't know, but okay, all right. And the key changes are now there's really no Zostavax recommendation, so that's been removed. There is so there's also removal of serological testing. The reason why we did serological testing in that Zostavax because Zostavax was a live vaccine, and we just wanted to make sure that it was safe to be given, and we knew that you had to have had chickenpox to have been able to get Zostavax, but that's all kind of gone now. And so it says people who have received a varicella vaccine were previously not recommended to receive a zoster vaccine, but can now consider it. So in essence, our population, as the children who or adults who have received varicella vaccine are getting older, now we're going to get into a state where a fair number of adults have had varicella vaccine and most likely not wild type infection. And because Shingrix is quite a safe vaccine, it's something that, they can potentially get Shingrix. And there's a removal of recommendation for household contacts to receive the zoster vaccine, now a practice point for consideration. Okay, so booster. So booster dose is still not recommended. There's really good long-term data out to 10 years to show that the vaccine effectiveness is generally well maintained. And I think I showed this last year as well. And if you look at the vaccine effectiveness at 10 years, it's still like 73% effective. So that's great. So you can, when someone comes in, just tell them you should get the vaccine when you're 70, and there's no booster dose at the moment. This is a slide again. I think I presented this last year. The lifetime risk of shingles is 20 to 30%, 50% if you're an 85-year-old. And so we really, really want to push the protection of our older Australians. What if you've had shingles? You can still get the Shingrix vaccine. We still recommend the 12-month interval for an immunocompetent host. And a 3-month interval for an immunocompromised host. Does anyone know why we mention this interval? No? It's because, so what is shingles? Shingles is your own virus that's been suppressed in the dorsal ganglion, so on the back in your spine, and it's just been kind of left there. And with your immunity, it's been kept at bay. And as you grow older or you become heavily immunocompromised, there is a phenomenon called immunosenescence. So your immunity isn't able to keep it at bay, and then it reactivates, and it reactivates on the nerve, right? And so once it reactivates, that actually boosts your immunity. Your body says, hey, that's there, and then it actually your T cells and T cells in particular, it boosts that, and so you do have good immunity generally for up to a year if you're immunocompetent. So that's the recommendation. If they get it, less than a year from when they last have shingles, there's no problem with that. It's just that shingles reactivation will likely protect them for that period of time. But if you're compromised, then your T cells are just not working anyway, right? And so the length of protection is much reduced, and we don't, and they're much higher, they're much more vulnerable. So that's why we say the 3-month interval. Okay. If you've had Zostavax, yes, please give Shingrix. If you compare the data for Zostavax long-term immunity, it's much less than Shingrix. So Shingrix, all in all, is a much better vaccine. And so it's so I would actually recommend it. That if someone comes in, they've had Zostavax, it's been 12 months since that they're eligible for Shingrix, then to receive Shingrix. We don't need to do serological testing. There might be certain, post-bone marrow transplant, things like that, maybe you'd consider, but it's just a lot of problems when we do serological testing. Why? Well, it's because it's not a great, what we call a correlate of protection. You know how when you work in health, you have to do a Hep B test, right? You have to show immunity, or if you don't know your immunity, then you get a serology testing for Hep B. And we know that, if you're above 10, then there's really good data to suggest that you're protected. With varicella, a lot of people who have been vaccinated or infected a very long time ago won't have IgG, right? So you won't have varicella IgG, but that doesn't mean that they're not immune. Yeah. So if you do have varicella IgG, then easy, you've got immunity. But if you don't, it doesn't mean that they're not immune. Okay, and patients who present greater than 6 months since their first Shingrix dose don't need to restart the schedule. We know Shingrix is a 2-dose schedule. You should give it 6 months apart in an immunocompetent host, 2 months apart if you're immunocompromised. But if someone comes in a year later, just give the second dose. Okay. And you can put any questions on the Slido, because I'm going through very kind of superficially quite quickly, and you might have specific questions that I haven't addressed. Okay, so meningococcal disease. So Trumemba has been removed. So there is clinical guidance for people who didn't complete the Trumemba primary series or need a booster. And the guidance is to restart the primary course and to receive 2 doses of Bexsero 8 weeks apart. For people who require a booster dose, Bexsero can be used and will still provide protection. Okay. So what about adolescents who've previously received ACWY or MenB vaccine? Let's say that they have received it as part of their childhood schedule, or the parents have opted and given it to them at 5 years of age, etc., they should still get the dose after they turn 14. So at the year 10 immunisations, they should receive it. If they haven't received it, I would say in the last 1 to 2 years. And again, why is that? It's because we really want to protect our young adults, and we know that that the meningococcal vaccine is highly effective in that first 5 years of receiving the vaccine. Babies 2 to 5 months. That's fine. Okay, measles. Okay, so measles there's been lots of outbreaks of measles overseas. I did an article because I looked into measles, and the highest outbreak countries are countries where majority of Australians go and visit. So they are India, Indonesia, Philippines, like huge amount of Asian countries, and then there's a smattering in the Middle East. And so any traveller is at risk of measles anywhere you go, and we've had some of the highest rates of measles incursions into Australia, in the past couple of years. So worried about measles. There was an outbreak in WA in their jail where they couldn't find the actual source. So it does pop up. So from a clinical perspective, think about measles if a child comes into your practice. And from a public health and immunisation perspective, we're finding that the measles cases are in people who are eligible for measles vaccine. So the young children, but also young adults, because they likely might have only received 1 dose in immunisation. And, we do so well in Australia in terms of immunisation coverage, but it is slipping. And we know that we need greater than 95% herd immunity to protect our population against measles and to stamp out outbreaks, because we will always have incursions. People can get on a plane and manifest the symptoms a couple of days or hours later. And so we're actually quite worried. And I know the bars look so high and it's absolutely brilliant, but even that 1% drop puts it below the 95%. Measles protection, and that's not where we want to be. And this is all on our website, so it's some great data that you can look up. And this is interim coverage data for 2024, and you can see there's that not beautiful, pretty horrific line that's just slightly. We're all doing a great job, but there's that slight, and just don't want that to slip down. So coverage at 24 months of age dropped below 90% for the first time since 2016. And you can see on-time vaccination of MMR and DTP2. Again, there's this slow decline that we get worried about because we really need that first measles dose in our children to protect against measles. It's a live vaccine. In Australia, we give it at 12 months, as you're all aware. You can give it early, and I'll give you scenarios for when that can occur. Yeah. Okay. So the recommendations are the same. Measles hasn't changed in that. So all individuals born after 1966 should have 2 doses of MMR vaccines. And we know a lot of our population may have only had 1 dose, especially people who have come from overseas, because there were different scheduling periods where some of the global schedules, only had 1 dose. And we know that doesn't confer enough lifetime immunity. But really what I'd love for you guys to take home is that if you have a child that's traveling and they're 6 months of age and they're traveling anywhere, that we do talk about an additional 0-dose measles, okay? So this is additional to the 12 and 18 month, and will protect them for that interim period before they turn 1 and get their routine dose 1 vaccine. And it's really highly important because we know under 1 you can get are the children that get really bad measles, so that they can get a pneumonia, encephalitis, and they can get even this post-measles syndrome as well. So there was a scenario, and it's in the public domain, where we had a CHW staff member who visited Vietnam, and she came back, and her child actually was diagnosed with 9 or 10 months, diagnosed with measles. And this was a healthcare worker that works in a pediatric hospital, and brought the kid to the ED. Unfortunately, because she was staff, she kind of got siphoned in. So what didn't end up as an outbreak in our emergency department, because we see kids who are heavily immunocompromised, and even for our staff that work in health, they weren't aware that they could have given their kid a measles vaccine before flying. So. Yes, it's registered 9 months, but we give it at 6 months onwards. If you're in New Zealand, they sometimes give it from 4 months onwards, right? And I think it's really important to understand why the recommendation. Why did we start recommending 6 months from a couple of years ago? Well, it's because women of childbearing age, we've been very lucky in that we've been vaccinated, and we've lived in an area, a period of time when there's no measles circulation in the community. So we're not getting wild type boost, right? And so the antibodies in pregnant women are not as high as they were in the past. Right? So that means that the infants, it's the same approach of infant protection, right? Maternal antibody. So the infants aren't getting that really high level of antibody, and then attrition. So if you start off here, it takes a bit of time to denature, right? But if you start here, then it denatures faster. So we're finding that kids at 6 months are vulnerable. They're not protected by maternal antibody. So please, anyone that's traveling, I know there are quite a few child and health nurses here. Talk to families about measles, okay? It's a huge outbreaks overseas, and healthcare workers are bringing it back. So yeah. Okay. The handbook is the same. It's the same thing. Use the online version. I think the landing page looks a bit different. And is that me saying 5 minutes? Is that a? Oh well. Okay, all right. I finished early last time, so I could compensate. Yeah, all right. And who gets the weekly jab? Does anyone here get the weekly jab? Yeah. And if you don't, then do sign up. It's great, and it also gives you at the bottom of the weekly jab lots of media articles, so you can see what's happening. And there's just been measles. Yeah. Okay. All right. So the immunisation catch-up calculator, available for infants, children, adolescents under 20, so that's super. And there's an option to select if the person identifies as Aboriginal or Torres Strait Islander, medical at risk, and also includes vaccine received overseas. So has anyone used the new updated calculator? Yeah, do you like it? Yes or no? Boo, yes? Yeah, because the last one was a boo from me, right? Yeah, because I didn't like the last one. So I'm really excited that they've actually done an overhaul. Okay, so travel. I might. Do I have like 3 minutes or so? Yeah. Yeah. This is a little bit like, because I always like to give you a taster of like what's happening overseas, because I remember like we used to talk about research and everyone like was really interested. So I know Victor's going to talk about flaviviruses, but there are vaccines against travel-related diseases for overseas that we don't have here, and it is something that if you work in a GP practice, people go and they get. There's this thing called chikungunya. Most of you might not have heard of it, but it's a virus, and there is a live vaccine that they can get overseas. Maybe it's not available in Australia, but maybe it'll come. There is dengue. Has everyone heard of dengue? Yeah. We sometimes, in the past we've had northern Queensland outbreaks. It's not occurring at the moment, but global warming and there's huge dengue outbreaks. But we've got pretty good vaccines now. There's Kudenga. You can see on that graph, it vaccine efficacy around 80%. It's 2 doses, and we have Butantan, which is a single dose. It's a live attenuated vaccine as well. And then malaria. Everyone knows malaria, yeah? Pretty horrific disease, but there are also 2 vaccines that they're now kind of registered in malaria endemic countries in sub-Saharan Africa, where they can give it to children. It's not something that we give to travellers though. So I just wanted to let you know that there are vaccines that are not available here. They're overseas. They may ask you, but it might be coming to Australia. Perhaps. And then I leave you with our good old friend, Nick. Yeah.
Hello, Orange. I just saw the immunisation coverage rates for Western and Far Western New South Wales. Fantastic result. Keep up the great work.
That's all. Thanks. Cheers.
He can't help himself, Nick. He just likes to get in there, doesn't he? Okay, so I'd like to welcome now Dee Brogan, clinical nurse consultant with the New South Wales Immunisation Specialist Service, or NWIS, NSWIS, NSWIS? No, true. To co-present with Archana a session on the management of the immunocompromised patient. All yours.
Please bear with me. I'm not as energetic as Arch, so it's hard to follow her, nor am I Professor Nick Wood. So, I heard everybody's comments when the first original video came up. Oh, so, yeah, we all love him too. So, all right, and pardon my technical challenges as well in advance. Just following on from Archer's update for the handbook, I just made a couple of little notes there as well. So you might notice the combination Hep A typhoid vaccine, Vivaxin, hasn't been available for probably close to a year now, so which can be a little bit of a problem, but the company stopped making it. So we've yet to update that in the handbook. With the National Immunisation Catch-Up tool, there are some errors in that, and I'm always really keen to receive some emails about that. Some of us love it, some of us hate it, but I feed back any of those errors back to the developers, and they're pretty good at trying to work and solve those out. And one of the current ones that's really a bugbear of mine is meningococcal. So you'll find if anybody's used it recently, it'll say dose 1 and a normal, fit, well, healthy child still needs dose 2 and dose 3. Your calculations are probably more correct. Okay, so thinking about the immunocompromised patient. So I'm just going to gloss over a few things. What's new, some definitions, some principles and recommendations, and determining immunocompromised status, and just a couple of examples there for you. So as Arch said, the immunocompromised chapter has undergone some significant updates. I don't think ever in the history of the immunisation handbook has there ever been such an extensive review. And we know this population group, is huge, and there's so many changes to modern medicine with the expansion of therapies. People are living longer, therapies are becoming more nuanced, more targeted, and there's a lot there that we just don't know. So this is the landing page for the whole new chapter, and I've really just circled that bit there about principles and recommendations, because that's probably the one that you'll use most frequently. And that's just, anyway. So is that going forward? There we go. So what is immunocompromise? So we know that it is a weakened immune system. And so these people that are identified as immunocompromised, they're unable to fight off, normal regular pathogens. They have insufficient white blood cells, like your lymphocytes and neutrophils, which are our, fighting cells in the blood. And these individuals are more susceptible to frequent bacterial and fungal infections. So there's a few different terms that we use when thinking about immunosuppression, immunodeficiency. So immunodeficiency, someone might have primary immunodeficiency, such as SCID, or severe combined immunodeficiency syndrome. Secondary immunodeficiency, and that might be related to an autoimmune condition or disease. Then we have immunosuppression, so, and that's usually secondary to their medication or therapy. And then we think about immunomodulatory. So that's, once again, refers to therapies and treatments, and that's probably the space that's, growing a lot now, particularly for people that have got autoimmune conditions. So this is where their prescribed agents are used to enhance or their immune response, such as, corticosteroids, monoclonal antibodies, immunotherapy. etc. All right, I was going to do a live demonstration of this, but the chapter is huge. I think you really need to sort of sit down in your own time and just play with it and just find where to find the information for the population group that you're primarily seeing in your clinical setting. But essentially this page is, I've kind of divided it up into two sections. So the top section there really refers to the principles about the recommendations for people with immunocompromise. So that's when you've got, the inborn errors. So your primary immunodeficiency syndromes, your secondary immunodeficiency syndromes. So the types of immunocompromise that we see. That bottom section there is referring more to immunosuppressive potential of therapies. And that's a really important section there. So that's where you'll find a lot of the tables. And these tables have got a lot more detail about the conditions and the therapies. And they're sort of structured in a traffic-like system. That's stratified according to severe immunocompromised to moderate to mild. And that hopefully should be something that should really be able to help guide you, in what sort of recommendations you're going to be providing for your patients. So what is primary immunodeficiency? So you may not see this too often because, a lot of these patients are probably already linked in with specialists. So they're inborn errors of immunity, so things such as SCID that I mentioned before. So they're inherited immune system disorders, specific immunodeficiencies, and once again, there's quite a range of those, and we have at Westmead whole family groups, where there's certain immunodeficiencies within that whole family. Syndromes such as DiGeorge syndrome, that's a chromosome microdeletion. IFNA, that's a relatively new one, and Arch knows a lot more about that. So that's a particular anomaly more with our Polynesian groups. And it's really quite important to actually ask that if you're seeing a lot of Polynesian populations because, that might be a red flag there for live vaccines, mainly the MMR vaccine. Congenital neutropenias, so the blood disorders, and then the complement deficiency syndromes. So this population group are more susceptible to repeated infections. So particularly with the kids, you might see the kids come into the practice with recurrent ear infections, recurrent sinus infections, like me from the SA dusts that blew across Sydney yesterday. Skin infections, like recurrent infections. And these infections are taking a lot longer to recover than what, they would in a normal, fit, wealthy child that, might be easily treated in a short course of oral antibiotics. They may also present with failure to thrive, poor weight gain, chronic digestive issues, chronic diarrhoea, things like that. So there's a few other red flags that might make you think, is there something really going on here? So just to summarise with primary immunodeficiency, so these patients must be seen by a specialist. So they've got very unique specific conditions. There's the new table in the handbook, which I mentioned before, like vaccination for people with inborn errors. That's a specific table in the handbook. These groups of people may actually have a suboptimal response to the vaccines. So they may require booster doses of some vaccines. And sometimes some of the immunologists might actually do specific antibody testing. And some of these population groups, so they might be more susceptible to pneumococcal, for example, or Hib, and they might actually benefit by having an extra dose at some point. Live vaccines are contraindicated for this population group for the most part. So then how can we protect them, vaccines aside? Other precautions, hand hygiene, your PPE, vaccinating other household members, healthy lifestyles, healthy habits, but also double checking that all their other vaccines are up to date, including flu, including RSV. It's deathly silence. Is this really boring? Secondary immunodeficiency. So this is, you'd probably see this more so in your adult population group. So they're patients that have got malignancies, your transplant patients, stem cells, the HSCT, CAR T cell therapy, and that's I'm still struggling to get my head around that. That's a really nuanced, targeted cancer therapy. Infectious diseases such as HIV, Arch is an expert in HIV treatment. Patients with asplenia or hyposplenia, so certain conditions where the spleen, they might still have their spleen, but it might not actually be functioning optimally. Autoimmune conditions, your RAs, your lupus, things like that. And then medical therapies, and like I said, the traffic light table will help you with their... So the signs and symptoms, so the way that they present will be fairly similar to the primary immunodeficiency. So there'll be people that will have recurrent infections that are taking a lot longer to recover. So they might have had, you know, a whole lot of courses of antibiotics and still be symptomatic. So key points. So this population group, they can have pretty much most of the inactivated vaccines. But the other thing that we need to think about with these is that for this population group, some of their vaccines may actually need to be temporarily delayed if their exposure risk is low. We want to optimise the timing of vaccination for this population group. So if you know someone who's walked in and, you know, they've just had a cancer diagnosis and their vaccines aren't up to date, but yet they're scheduled for chemo next week, you know, in consultation with their treating oncologist, you might decide to, you know, they're really going to have much of an immune response to that vaccine if they're going to be ablated, you know, in the following week, you know, so... But then again, it might be a benefit versus risk scenario. So if there's a sneaky window to provide all these other vaccines to them before they start their biological therapy or their cancer treatment, then absolutely give them all to them before they receive that treatment. There might be another reason where you might want to delay it, and that might be somebody that's had, you know, a short course of high-dose steroids. You know, so if you know that their high-dose steroids are going to finish in the next week or two, you might sort of think, well, you know, that Boostrix, it is a booster dose. Maybe it's worth waiting, you know, another week or two. They're not really going out anywhere. They're staying at home because they've been sick. You know, those sort of things might be, you know, lead you to think, well, let's just wait until that prednisone is sort of weaned off out of their system. Additional doses, like with the primary immunodeficiency population, so COVID, flu, pneumococcal, that pneumococcal tool, and Arch has talked about that before, so we know they're definitely at risk of these. And also thinking about the people with complement deficiencies that I mentioned earlier, those people that have got specific complement deficiencies also get additional meningococcal vaccines. So, and that's a specific deficiency in their blood. And also HPV. So when you're thinking about, the school program, so some of these kids might have RA or some other underlying issue. We know the school program HPV is 1 dose for fit, well, healthy people. So, you know, if they come in to GP land and you know the background, so these kids are actually recommended to have 3 doses of HPV. Why is that? We know that they're more vulnerable to HPV infection, especially if they're on therapies. Live vaccines, like I said, are generally contraindicated for this patient group. Some patients, there might be a sneaky window period where you might be able to give the live vaccines 2 to 4 weeks before they start their therapies. Once again, that would probably really involve a discussion with their primary treating physician. And some therapies, like for example post-HSCT, stem cell transplant, they may actually need all their live vaccines again post-completion of therapy. And there's that great handbook table in the handbook that gives a good guide as to when to start vaccinating post-completion of cancer therapies. Alrighty. So common questions that we receive is this one. So mums that are prescribed DMARDs during their pregnancy, and it could be anything from methotrexates to infliximabs and things like that. They might have an underlying autoimmune condition. So infants exposed, so this has actually got its own new section in the handbook. So previously that sort of little one-liner was in the rotavirus chapter. So this is in the immunocompromised chapter. So can infants exposed to immunosuppressive therapy in utero or through breast milk can safely receive all non-live vaccines? Hands up for yes. A few. Yep, non-live vaccines, not a contraindication. So that's your Infanrix, Hexa, Vaxelis, Prevnar 13, right? And RSV, Beyfortus. Can infants exposed to TNF-alpha inhibitors and other biological therapies have Rotarix? And this is your TNF-alphas, infliximab, that's commonly used for Crohn's and RA, Cimzia, things like that. New change. So, yeah, pretty exciting. Can infants exposed to anti-CD20, and I mean, I have to read and reread and double check what category these medications come under because I'm not the expert in these. So that's like your rituximab, okay. And these are therapies that are used to treat, CLL, lymphomas, RA, MS, and they're probably in your very vulnerable patients that haven't responded to other therapies. Big red flag, no way. And Ritux is a whole another complicating factor by itself anyway. I haven't begun to talk about that. All right, bit of an example, and Archie's the same photo as me because this baby is just adorable. I just looked at it and I just said, oh, I love babies. All righty, so 6-week-old infant, born at full term, lovely birth weight, 3 kilos, normal vaginal delivery, no medical concerns, but mum was on ocrelizumab for RA during pregnancy. Can the bubby have Rotarix? No. So that's just a little snapshot, of what the table looks like. So you'll see that red traffic light there. So the category or level of immunocompromise. So no. As another example, 26-year-old female. She's got a history of psoriasis, otherwise fit, well, healthy. She's been started on this medication, Cosentyx. All her other immunisations are up to date. She's had all her high school vaccines. She's had the flu every now and again. She's heard about how bad shingles is. Her auntie had shingles and was, bedridden because of the pain. So she's come in to see you and has asked, look, I really want that new shingles vaccine. Can I have it? Is it funded? So you can see there, because this particular drug, it's got mild immunosuppressive factors with it. Can she have it? No. She's not fitting in that immunocompromised section, right? Remember that Arch mentioned earlier, so where we would recommend, those patients that are severely immunocompromised can have Shingrix from 18 years of age. So even if she wanted it, but I really, really want it, can't I get it funded? Can I buy it? No, not really. And the reason for that is that we want to make sure that she actually has a really good response to the vaccine when she's older and when she's, more likely to have the severe complications of shingles, that post-herpetic neuralgia. And at the moment, there's no recommendations for any boosters. So, we've got, we don't have infinite supply of vaccines. What we give to people, we want to make sure that they're actually going to be efficacious and they're going to get the most benefit out of it. Any questions so far? Oh, yes, doctor. Come up.
Superb. This is brilliant, Budgie. So when we talk about rituximab and we talk about anti-CD20, it's complicated, but there are, when you think about cells, right, your immune cells, there are, your immune cells wear clothes, right? They wear clothes, and the clothes have antigens. So the immune cells are detected by what clothes they wear, like 20, 19, 4, things like that, right? And so the 19s and 20s are B cells, and B cells produce antibodies, right? So anything that's B cell suppressing or T cell suppressing is heavily immunosuppressive. Okay, and then there are some immunosuppressants that stop, they don't stop all the cells within wearing that certain clothes, but stop them producing a certain protein, right? And those ones it's different in terms of if you stop that protein being produced, because proteins are way cells talk to each other,
right? So for your immune system, you need cells to talk to each other for that to work. And if you stop one of the means of communication, then your autoimmune disease will probably dampen, but you're at risk of, other diseases. And the things that cells talk with, or the protein that it secretes, if you stop one, it's not the same as stopping another. Some are highly immunosuppressive and some are not as immunosuppressive because it only talks to one line. Okay, so that's the reason for the difference in recommendations, right? So this one, this monoclonal antibody, you can see there, it binds to IL-17A, which is interleukin, which is something that's secreted by a cell, right? But it doesn't. That IL-17A doesn't talk to many other cells, right? So it's not very immunosuppressive. So this person is not getting Shingrix because her likelihood of shingles reactivation is low. That make sense? Okay, yeah.
That's why I love working with you, because she just explains things so much more articulately and creatively than me. And I thought in the interest of time I wasn't going to add any more, so should I just go on to the next exciting topic? Anaphylaxis. Who's ever seen anaphylaxis? Oh, yeah, it's pretty scary, huh? Yeah. Anybody seen anaphylaxis to a vaccine? No. Fantastic. And that's great. All right. And this is probably just rehashing information that everybody already knows as well. Just a broad definition about what is an APHE, adverse event following immunisation. Anaphylaxis, immediate hypersensitivity reaction. Immunisation stress response, recognition and management of anaphylaxis, and a couple of little examples. And I think Belle's going to follow me with some extra really interesting information as well. So what is an APHE? So it's a pretty broad term, and this is the WHO definition. And APHE is an adverse event following immunisation. It's pretty much any untoward medical occurrence which follows immediately after the vaccination. It doesn't necessarily have to have a causal relationship to the vaccine. Okay, so that's really important. If not rapidly and effectively dealt with, it obviously can undermine vaccine confidence. Like when Arch was talking about the RSV administration errors and Julie's talk earlier, we want to make sure that consumers have got a really good confidence in our vaccine program. APHEs can have dramatic consequences for immunisation coverage, disease incidence as well, which is what we've seen in a lot of the data that's been presented already this morning. So what is anaphylaxis? It's a serious systemic hypersensitivity reaction. It has rapid onset, and this is the key phrase, it has progression of symptoms. Okay, so there must be progressive symptoms. It's life-threatening, as we know. And thankfully, as conferred in this room, it's really, really rare post-vaccination, 1 in a million. Cases. It's associated with, vasodilation, a whole cascade of symptoms. So this is just a nice little picture, just a bit of a refresher for those of us that haven't looked at a textbook for a long, long time. So we have the introduction of the antigen to the cell. So that cell is exposed to the antigen. So when it enters the body, it activates that immune system response. So it leads to the production of antigen-specific IgE antibodies, those Y-shaped antibodies. They then bind to the cell, okay, to the mast cell or the basophil, and they sit there, just swimming around in the bloodstream, doing their own thing, minding their own business. Subsequent exposure, same antigen enters the body, and the body goes, oh, hang on a minute, I've seen this before. So then this antigen then binds to those IgE antibodies on the mast cells, okay? And this then creates, a degranulation of that cell, and a flood of chemicals are then released, like histamines, and other chemical mediators that are then, aimed to fight this allergen. So then what this does is that this creates a whole storm in the body where you get, increased mucus secretions, platelet activation, vasodilation, all these mechanisms that the body's trying to repair itself. So with NSWIS, we often review a lot of AFIs are asked by the public health units, when there's been some unusual cases. This is outside of my scope of practice to identify a case definition, but these are what the expert panel reviews do. So I thought you might be interested in looking at this, and I'm sorry, it's probably a bit hard to read on those screens there, but there's major and minor. Essentially. So, and I'll go into a little bit more detail shortly. So we have rapid progression of symptoms, signs which typically affect multiple body systems. So it's more than just a case of hives. So, we've got multi-systems. So skin and conjunctival or mucosal systems, respiratory system, cardiovascular, hypotension, not hypertension. Loss of consciousness, hopefully that's already been dealt with before your patient ends up there. Gastrointestinal symptoms, they can have vomiting, diarrhoea, severe cramping. And if you're lucky, we often get, we would like a mast cell tryptase, and that's usually done in ED. So if you ever see a patient that has had symptoms that you're not sure, think of, it'd be really, really good if they have that mast cell tryptase done, because then that actually helps in the clinical diagnosis of thinking, was this case actually anaphylaxis? Vital signs, really, really important. And I know it's a stressful situation when someone has, a big event in their clinic, but that also gives us a lot of information about the person. So what is angioedema? And I refrain from using, everybody's probably seen it, that picture, that those big luba lips, that's probably someone that's had injectables at some point. But, I'm sure, most people have seen cases similar to this. So this poor little guy, has got these eyes swollen shut, can't open them. You got fluid leaking into the tissues under the skin in those small blood vessels. So usually accompanied by hives, urticaria. Large swollen areas, it can be red, itchy, hot, uncomfortable. The patient's really, really irritable. And I've got there, do not look in the throat, because I had a comment at one point that somebody thought angioedema was actually looking in their throat, looking for swelling in their throat. So, no, you're not going to see angioedema in the throat. You don't want to open the throat. So how do we classify anaphylaxis? So back to that table before, stratified into 5 levels. Level 1, most probably anaphylaxis. They've got 2 major systems, so your cardiovascular system perhaps, and respiratory and or GIT system involvement, and skin and or mucosal. So that's when you would see urticaria, respiratory difficulty, cardiovascular collapse. You go, that's pretty convincing that that's anaphylaxis. Level 2, probably doesn't have skin or mucosal involvement, but it's going to have 2 major systems. So, they might have diarrhoea or vomiting, severe abdominal cramping, and have the respiratory compromise with a wheeze, I might add. So respiratory compromise is usually more than just, hyperventilating or a little bit of shortness of breath. You usually always get a wheeze with anaphylaxis. So level 3, we're getting into that sort of grey area, and this is where we really rely on the information that's provided on by the people that are with the patient at the time, because it's really hard to assess it in hindsight. Level 3, so they might have just one of those major systems there, and a minor system, so maybe a little bit of a rash or a bit itchy. Level 4, insufficient information, and that's where if you had your vital signs there. If they were hypertensive, you go, probably not anaphylaxis. It might be more of a stress response. And level 5, does not meet the case definition of anaphylaxis. So I'm sure everybody's very well versed in the difference between what's a vasovagal and an anaphylaxis. So I don't want to harp on this, but fainting versus anaphylaxis. So fainting usually happens pretty quickly, and it's usually, and I don't want to be judgmental here, but it's, big burly guys come in, and then bigger they are, the harder they fall, even teenage boys, so happens very quickly. Anaphylaxis can happen within that sort of 15 to 20 minutes post-vaccination. So your patients must stay in the clinic for that time. They can't sort of say, great, thanks, sis, I've had my flu vaccine, I'm going to run down the stairs off to work. They fall down the stairs, hit their head on the concrete steps, and then you've got a whole other range of problems to deal with. So they must stay there. Skin symptoms. So, people that faint, they're pale, cold and clammy and, feel very uncomfortable. They often can take big, deep breaths, they're bradycardic. So because they're just about to pass out. They can also have a bit of nausea and vomiting. So you can see like there's sometimes a little bit of overlap of symptoms. So it can be quite difficult to sort of determine what's going on. They too can have loss of consciousness, fall and hit their head. So it's always good to sort of identify these patients early on. Anaphylaxis, tachycardia. So you've got to really know the differences. Tachycardia, hypertension, abdocramps, loss of consciousness. And obviously lie them down and don't get them up, if you're starting to see some symptoms. So an acute stress response, happens very quickly. Like I said, just another little diagram there. Vasovagal with syncope, they can have loss of consciousness and certainly at the bottom there, they can have some, tonic-clonic type movements that almost resemble a seizure, yeah. Okay, management of anaphylaxis. So the only choice of treatment is adrenaline. Okay, so you've got to have adrenaline in the room, preferably in the room, not in the cupboard down the hall behind a locked cupboard. Have it in the room where you're vaccinating. Corticosteroids, antihistamines, bronchodilators, Ventolin, and that. Do they have a place in managing anaphylaxis? No, not really. Positioning, so always think about positioning, laying the person flat. So even if you suspect they're having, a vasovagal, lie them down. This is really important. Their blood pressure can drop really quickly. We want to manage that. We want to get that blood flow back up to the heart. So lay them down. Do not get them to stand. And sometimes these people, when they're starting to, have immediate hypersensitivity reactions, they can get really restless and fearful. And, it might be hard to get them to comply with your, what you want them to do. Standing makes anaphylaxis worse. Their blood pressure plummets and then you've got all sorts of doo-doo. Don't feed them. Don't get them to have anything to eat or drink, because if they are about to have their airway is at risk, then obviously we don't want to make that worse by having, foreign bodies in that airway. Okay, and obviously, what are you going to do? Call 000. Get them out of your practice as soon as possible and off to hospital. All right, so this is just an example of a little boy that we saw in our clinic last year. He's an 11-year-old boy, relevant family medical history. He's fit, well, healthy, gets rashes from time to time. His sister's got multiple anaphylactic food allergies. Multiple, you name it, she's on the whole panel. So this little boy, this family are really vaccine motivated, get the flu vaccine every year. So last year they went and got the flu vaccine in the pharmacy and immediately he developed a widespread urticarial rash all over his body. He described his lips as itchy and like he's 11, so he could articulate it quite well to his mum. No difficulty breathing, no lip or tongue swelling. Treatment, he was given adrenaline in the pharmacy, called by ambulance, taken off to hospital, where he actually got another 2 doses of adrenaline. Once he was in ED, he vomited and he was kept overnight with no progression of symptoms. Any thoughts? Yeah, it's pretty scary, huh? Especially, when the mum's pretty, observant for symptoms of anaphylaxis. So this was like, a bit curious. So we reviewed him in the clinic, and we noted that he's had, a history of increasing localised reactions with each year, and we quite often see a number of kids with this that, each year, they get, more red swollen arm. So we reviewed the vaccine components because, there's a couple of different brands of flu vaccine, right, and the elements or the components of it vary ever so slightly. we didn't vaccinate him. We thought, we need to, spread this out to our wider expert group. So we just presented him in our specialist network meeting, the AFICAN, and thought that he would benefit by following an allergy algorithm pathway. So we actually referred him to the drug allergy testing clinic because he had Vaxigrip Tetra. Vaxigrip Tetra, even though like all the flu vaccines have got negligible amount of egg protein in them, Vaxigrip Tetra's got neomycin in it. So we thought, is this actually a neomycin allergy? Weren't really sure. So sent him off for that, and that was a bit inconclusive. So we did end up, seeing him back again, and we did split dosing. So by that we gave him 10% of the dose, and the poor little guy's, getting, poked and prodded. Watched him, waited for a little bit, and he actually had a few little spots of urticaria pop up on his neck and various parts of his body. And we thought no progression there after an hour, so we gave him the extra 90%, kept him there for at least another an hour to 2 hours. And I think the provisional diagnosis from the allergy team was that he's actually got chronic urticaria. So it wasn't the flu vaccine at all. But it was a good indication, so don't really know what the trigger is for this poor little boy, but he does flare up. So he'd been to the park, come up with hives again another time, so he's just a sensitive little soul. So another little example, 15-year-old Isaac came and saw us in the clinic. So he was born in Syria. Another fit, healthy, strapping lad, because they're all tower over me. No significant illnesses, no allergy history. Went to the GP for some catch-up vaccines. Had his vaccines, had a few, stood up, bang, straight down on the floor. Fainted, blacked out, passed out. Pale, low blood pressure, elevated heart rate, post-syncopal convulsions. He had 2 lots of adrenaline, called the ambulance, shipped off to ED. Any thoughts? It's a bit tricky, isn't it? Because he's got skin, he was pale, but no urticaria. His normal work of breathing. He was tachycardic and hypotensive. No GIT symptoms. And he had temporary, straight away, temporary loss of consciousness. I'm sure there's lots of nods here. Everybody knows what the answer is. Okay, we reviewed him in the clinic. He was pale when he walked in. Felt unwell. During the consult, nothing happening. He had cold hands, felt clammy, started to get a little bit of increased work of breathing. His chest was clear, no wheeze, neurologically intact. We decided there was no contraindications for vaccination because of him being already a little bit tetchy. We thought, we'll vaccinate him lying down on the vaccination bed. Became very, had that colour drain, looked grey, gave him a lollipop, some apple juice, did his obs. Look at his obs. He's quite hypertensive, heart rate was pretty good for a strapping young lad. So, it's good to identify, these patients that might be walking in, and if they're starting to have that colour drain from the face during the chat, before you've even got the vaccine out of the fridge, that's a pretty good indication that they might actually need to lie down. So prevention can sometimes be your management plan. Identify your vulnerable patients early. Think about your communication in your language. So I often do lots of talks on, needle phobia and stuff like that. So, if you know your patient's anxious already, just avoid using those words, those phrases that might sort of, evoke a little bit of fear or anxiety in your patients, like, oh, this isn't going to hurt. Much, yeah. I didn't feel a thing. Distraction. Nurses, we're brilliant at distraction. We just talk and talk and talk. Oh, it's done. Oh, So we're really good at doing that, and appointment planning. So, if you've got a really vulnerable patient, like, that's got a history of fainting, or they've got, multiple medical comorbidities, or a list of allergies a mile long, you're not going to book them on a Friday afternoon, are you? So, they'd be the ones that you want to get in early, on 9 a.m, maybe with them bringing a friend that might sort of keep them nice and calm and relaxed, and make sure, you got your medical staff around just in case. And then if in doubt, always refer to a specialist. All right, that's enough from me. I think Belle's going to have a little chat now too. Thank you.
Oh, leaving? You gotta stay. You haven't got to the good bits yet. Anyway, in the interest of time, goodbye. I'm going to make this really short and sweet, and I think most of you have met the awesome public health team, but basically we just wanted to highlight the fact that, yes, as Dee's just highlighted, APHIs are spooky, but we want to know about them. So as we've covered, an APHI is the adverse event following any untoward medical occurrence that follows immunisation, but it's not necessarily causal with the vaccine. So it might be a medication error. It might be the handling of the vaccine or the administration of the vaccine. So we want to know about those too. But I think everybody just needs to remember that they're notifiable. We need to know about them. So yes, we've just gone through all the events that go on. I'm skipping the 1, 2 and 3 because we've just gone through that. So there's that little section there that says you've got to notify us. So this is as quick as we can make it. So as I've said, they're notifiable under the Public Health Act. So we want to know about all of the incidents that happen when you're doing your immunisation clinics. Doesn't matter how small, if you're in doubt, we want to know. We learn from APHIs, we learn from our mistakes, we share our knowledge, we go to our pros sitting in the NCs and everywhere else. So every single incident that doesn't match up to what you should be expecting after vaccination, we want to know about it. There's lots of information in the New South Wales adverse events following immunisation on the webpage. All these links are going to be in your slides so you can have those. When you ring us in an absolute panic that you've had a vaccine error or you think you've had an APHI, there's always a little piece of paper that we want you to fill out, and that's what it looks like. And I know it sort of says APHI, but it's, it refers to anything that's not right when administering immunisation and vaccine spaces. So if you've made a medication error, you've given the wrong vaccine, just give us a buzz. Sometimes you can't fill out all the sections, but we just want to know what's going on. As Arch let us know this morning, we know we've got vaccine errors going in the RSV space. We need to know about these. We're not there to judge. We're there to just share the knowledge and encourage you just to come forward so we can help identify hot tips on so we can avoid the errors coming forward. So basically, what do we do with a report? Once we get that, we go, oh my goodness, how severe is this? So we basically do a bit of an initial investigation of what the APHI is. So if it's a vaccine, wrong vaccine for the wrong person, we'll work it out. But the more serious ones, we actually have some beautiful control guidelines that we use, and they guide us in that decision-making process. So we take your story that you've sent us, and we apply the guidelines. We then have a look at what has happened post-vaccination and what kind of follow-up might have happened in the clinic or wherever the incident may have happened. So once we've got our information, we actually go back to the treating doctor if that's the situation, or we go back to the nurse that's given the vaccine, and we try and obtain as much medical history as we possibly can of the patient, identify if this is not the first event or if it is the first event. Basically, once we've got that information, then we actually want to talk to the client themselves, providing they're well enough to paint a bit more of a picture. So that way we can draw up a whole big story of what's happened for this person. And sometimes we can sort of come to a solution pretty straightforward, but when we've got something complicated, we go to our friends at the top of the food chain and we seek further advice. And sometimes things are complicated, and it does require a round table of experts to determine what's the right path for that person, to make sure that they're confident in the next vaccine that they receive and the next encounter they have with health. So these are the advantages of reporting any incidents in vaccine administration and any unexpected side effects from any vaccines that people receive. So basically, in a nutshell, if you've got an incident, we want to know about it. We've got a couple of different email addresses, which I've put both up there. We usually promote the PH nurses box, but we do also have a vaccination inbox. We actually don't care which way you send it. Fill out that form, give us a ring, have a quick chat, try and ring the 1300 number, because we've got offices Bathurst, Orange, Dubbo, Broken Hill. So those 1300 numbers go to your nearest public health unit. We've got some amazing admin staff, and they know where we are, because sometimes we're at a conference, we're at a clinic. So sometimes if you're ringing the person's mobile phone number, they might not answer. And if you're in a bit of a pickle, you want to be ringing that 1300 number so they can put you through to someone as quickly as possible if you need some quick advice. So remember the 1300 number, but yes, always remember where you can find your AFI form. All the links will be provided to you after the conference, so you've got that quick, easy access to the electronic form, so you can email that off to us. But if you print it off and scribble on it, please make it kind of legible so we can work out who we're talking about. That's always helpful. And then, just send it through to us, and we'll provide feedback, and we'll get advice from TGA and NCs and everywhere else, and build a picture so you can get that communication back to the individual, build that trust, and give them some guidance on what's going to be the new path. So that's me wrapping it right up very, very quickly so we can get on to Victor and his awesome presentation and what's next. So thank you. So don't forget to call the public health unit anytime. Cheers.
Super efficient and on time. Thank you so much, Dee and Belle. So yes, as mentioned, I'd like to now welcome Dr. Victor Carey, Public Health Physician, Public Health Unit from WNSW LHD, to present local updates on Q fever and arbovirus. Thank you.
Do you ever have one of those moments where someone makes a statement, that it happened earlier this morning for me, and it triggers a memory, and it's something you haven't thought about for a long time, and it's such a strong memory? Archana, you're responsible. You were talking about RSV, and you mentioned Hib. Now, in the late 80s, I was an emergency registrar at Liverpool Hospital. And one day, the ambulance came in with a young boy on a trolley, and he was leaning forward, barely able to breathe. The stridor, and he was drooling. And the look on his face, he was incredibly scared. I was scared, and I was supposed to treat him. So he had epiglottitis caused by Haemophilus influenza type B. Now, we got him to theatre, and we had a surgeon waiting, and we did manage to intubate him. The surgeon was there in case we couldn't, and he needed a tracheostomy. And he did well. We don't see hip disease anymore. We don't see epiglottitis. And it's because of what you do. How's that? And there's many diseases that we could name in that same situation. But anyway, I can still see that boy's face when that memory triggered. And I hadn't thought about it for many years. And it's quite impactful. And here's a disease that we just do not see anymore. You could say the same for meningococcal C, for many diseases. And, that's what you do every day, and it's fantastic. Now, You've had lunch. It's getting towards that time of day when people start to fade a bit. I know if I'm sitting in your place, listening to talks, my mind starts to wander. And, you know, someone like me gets up and I go, I hope he doesn't show a lot of graphs. Let me reassure you, I'm not going to show a lot of graphs, mostly. But I'll give you a warning before I stick one up, okay? We're going to talk about Q fever and arboviruses. And we'll start off with a
zoonotic febrile illness.
little bit of a discussion about
biological name is
Q fever.
Coxiella burnettii.
I hear an echo.
It's mainly found.
Am I imagining things, or
pathogen within.
is this? It's another flashback, I think. What was in that lunch? These two diseases, Q fever and Japanese encephalitis in particular, if you want to talk about two diseases after lunch, these are the two, because they're really interesting. And they're also preventable. Now, in 1935, a person called Macfarlane Burnett was asked to assist in the investigation of an outbreak of infectious disease amongst abattoir workers in Queensland. Macfarlane Burnett, of course, went on to be the Nobel laureate in medicine, and he, along with a US colleague, and they were looking at this at the same time, a similar outbreak, they discovered the causative organism of query at that time, fever, which is Coxiella burnetii. The American was called Cox, and of course Burnett. So the organism is named after the both of them, Coxiella burnetii. Macfarlane Burnett actually went on in 2 years later to get Q fever himself through the laboratory, because they were working on the bacteria. It's highly infectious. That's one of the fascinating things about it. In the Netherlands outbreak, a long outbreak, between 2007 and 2010, there were 4,000 human cases of Q fever. 4,000. Linked to goats, goat farming, in particular at a time when they were giving birth, and associated with what was called an abortion storm. So a lot of abortions from these goats due to the causative organism, Coxiella burnetii. It's estimated that, and they had to cull 50,000 goats and sheep to control this outbreak. It's estimated that there are 1 billion organisms of this bacteria per gram of placenta excreted by goats in particular, but sheep and cattle. 1 billion. Now, these organisms can survive for up to a year in the environment, in the soil. And it's been estimated that what we call the ID50, or the infectious dose to cause disease in 50% of humans, is around 1.2. So, if you take a lungful and one organism, let's say, gets in, you have a 50% chance of getting Q fever. It's highly infectious, highly infectious. What does it present with? It presents with a non-specific flu-like illness, like so many things. So, headache, fatigue, malaise, muscle aches, abdominal pain, nausea, vomiting, high fever, and then chills and sweating, loss of appetite, diarrhea. So any of these sorts of symptoms. It can progress to multi-organ involvement. It's generally self-limiting, so it goes away itself. It can lead to serious sequelae, such as hepatitis and pneumonitis, and stillbirth and miscarriage. But of course, treatment is important because it eliminates the organism and reduces the length of disease. Now, this can go on also to chronic Q fever, and you can have a chronic fatigue-like syndrome, myalgias, so muscle aches, and it can lead to serious sequelae, such as in particular endocarditis. And it's been thought that in an endocarditis where you can't isolate an organism, a Q fever is one of the things you think of. So it's not uncommon. And clearly it has an impact on occupation because it's largely people exposed within these sort of occupation areas. Warning, this is the slide. Okay. It's not about the detail. It's actually more about what this shows. It's a bit confusing, I know, but it's a really interesting bacteria because it comes in two different forms and it switches between those forms. There's a large cell variant and there's a small cell variant, and one can become the other and the other can become one. And the small cell variant is the one you find in the environment. It's really resistant to anything in the environment, so it survives. And it's an intracellular pathogen. So it gets into your lungs because it's generally inhaled, and then it's taken up by alveolar macrophages. And their job is to gobble up foreign things and bacteria and whatever they think is foreign and kill them. But once this gets into the alveolar macrophage, it actually changes its form to this large cell variant. So it's kind of very tricky and it's evading being killed. On top of that, it has two antigenic phases. So it changes the covering that it has, the lipopolysaccharide. And this gives rise on the graph on the right, which is a very confusing graph, but it's our immune response to the disease. You can have antibodies against either phase 2 or phase 1 of these lipopolysaccharides, and it becomes pretty much a headache when you're trying to interpret serology. Does this person have Q fever or not? But it's very clever. It's very clever. It's really interesting because across the world they study these sorts of responses, the human response, and they look at various strains. There are many different strains as well of this bacteria. So it's a complex organism. And interestingly, one of the most commonly used strains for investigations in laboratory is the Priscilla phase 2 strain. What can we say? The main point about this slide is, look, in the first 2 weeks, if you take someone's blood and you think they might have Q fever, you can actually identify it through PCR because the antibody response takes longer. And then thereafter, you need to look at phase 2 first and then phase 1, and it becomes quite complicated. But really, in terms of prevention, there is a vaccine, and that vaccine is based on the phase 1 antigen, and it's for high-risk occupations. It's really highly immunogenic, so it's very effective. It's a very effective vaccine, but it's also highly reactogenic. And so you need to do pre-screening serology and a skin test before you can administer this vaccine. I don't know how many people here have been involved in Q fever vaccine. Hand up. Okay. So it's quite an involved process because you actually have to do a skin test and get the patient to come back a week later, and you take blood at the same time that you do the skin test. And when they come back, you need to look at the blood test. Have they had past exposure to Coxiella burnetii? And that will be looking at humoral immunity, so their humoral response and antibodies. Or have they had a positive skin test, which indicates cell-mediated immunity? And if they have either or both, you can't vaccinate that person with the vaccine because they'll have a very hard reaction, both locally and systemically, to the vaccine. So there are strict criteria for the administration of this vaccine. So in summary, you do a serology and a skin test. if you get a negative result for both, you're good to go. And they've got to be 15 years and older, because that's the licence age indication of the vaccine. Well, how common is it? We see it across Western New South Wales, as you can see there. That's annual rate per 100,000 population. And within the public health unit, we would, many weeks, have a case of Q fever that we're following up. But look at that in 2024 in Far West. So we had an outbreak, and we've been investigating that and trying to find out source. It's very difficult, but big jump in cases in the Far West late last year, and kind of still happening a bit. And if we look at the characteristics, and I think this is from 2000 to current, so 5 years, or 4.5 years of data, 199 cases across Far West and Western New South Wales. Large proportion males, 70%. The major age group, 25 to 64, so kind of that working age group. And if we look at by local government area, we see Warrumbungles, Dubbo, and then also Broken Hill on the left. And here we have a map of annual Q fever notifications, and Warrumbungles highlighted there as a high rate, as well as the Central Darling. And bear in mind, the case numbers are low, so 1 or 2 less cases in a year will decrease the rate, because that's the nature of those rates. There are significant barriers to Q fever vaccination, though: a lack of accredited vaccination providers, the time and the distance required for travel for pre-screening, and then vaccination 7 days later, with the uncertainty for the patient if they go back, and maybe they have to travel quite a long time, quite a distance to come back. And so it's a difficult one. The cost of vaccination, it's not covered. And I've looked at various estimates of the total cost, including the pathology needed. It might be between $300 and $500, depending upon the provider. And that doesn't include time off work and travel, etc. So it's a big imposition. And then awareness. And I think it is a significant problem. It has potential impacts, long-term sequelae. So it's something that if you have people who work particularly in the settings of cattle or sheep or goats, then it's something that should be discussed with those people. It's a worthwhile vaccine. Moving to adenoarboviruses, so amongst the arboviruses, Japanese encephalitis, Murray Valley encephalitis, Ross River virus, and Barmah forest virus. They're the local ones. Of course, there are others around the world. Archana spoke a little bit about dengue. Yellow fever, of course, is the original and nastiest, really nasty. But these are the ones that are problematic for us. I'm going to really talk mostly about Japanese encephalitis because it's something that was not endemic to Australia until a few years ago. It was a disease of travellers going to Asia, and for which vaccination was recommended if people were staying in an endemic area outside of a major city for a few weeks or more. That's no longer the case because it is now endemic in Australia. And if I went back 10 years, I would never have thought this would occur. How did it get here? Well, we think it got here through water birds migrating from endemic areas to Australia, to Queensland, to New South Wales, especially along the Murray River in particular. And then, as you can see from that graph, that chart on the right, there is a natural cycle, and that is the water birds, then the mosquitoes, the Culex species of mosquitoes picking it up and feeding it back to the water birds, so in that cycle. However, if you have amplifying hosts, like pigs in particular, the mosquitoes will bite those pigs. and they get a viremia. And therefore, another mosquito can come along and bite that infected pig, and they will become a carrier. So pigs are amplifying hosts, and probably some native species as well. Humans and horses are dead-end hosts. So if we get infected, we don't have enough of a viremia to pass it on to a mosquito that might come and bite us, but we can become infected. And the sort of symptoms one sees, most people are probably asymptomatic or they don't have a severe disease. However, so when we do notifications of Japanese encephalitis, we know, let's say you had a notification in a particular area of 10 cases in a year, there's probably a lot more that are infected than that. But it's these that we're focused on. Encephalitis is a rare but serious consequence of JE infection, and can be fatal, and it's not treatable, essentially. Symptoms occur within 5 to 15 days of the mosquito bite, and severe cases could have these neurological effects and death. Prevention is key through vaccination and, of course, mosquito avoidance. And you see listed there the sort of symptoms: headache, vomiting, fever, irritability, weakness, movement issues, and then it might progress to those more severe symptoms, which are kind of encephalitis picture. We do have vaccine, 2 very good vaccines. Imagev, which is a live attenuated vaccine, single dose for people greater than 9 months of age, and then Jespect, 2 doses. This is an inactivated vaccine, so 2 doses for infants and children and adults greater than 2 months of age. And it is free for many, many local government areas west of the Dividing Range. Not all. You need to check on the New South Wales Health website. But it is free for people who are potentially exposed. So people who work outside, generally, and anyone who's concerned will get that vaccine for free. And it's something we really advocate. And indeed, we, at the last, the field day, the National Field Day, near here, last year we had our staff from the Public Health Unit running free JE immunisation for any attendees there. We'll do it again this year. But I think it's a really fantastic thing, Japanese encephalitis vaccine. Here we really have the notifications, not for JE, because we haven't had any cases in Western New South Wales at this time period, although there have been isolates from mosquitoes and pigs within Western New South Wales. But in particular, we see here the incidence of Ross River virus, which is another mosquito-borne virus. And here are the rates by month, and you see the summer sort of peak in those rates, and that reflects mosquito biting patterns and mosquito breeding, more in summer months. And here we have the number of Japanese encephalitis vaccine doses delivered by month. Look, in 2022, good amount of doses, but then that's really declined, and even 2025 this year, some uptake. Gee, we can do much better than that. I recommend JE vaccine to anyone. I mean I'll walk out on Summer Street after this, and anyone that passes me, I'll say, get the vaccine, because and they'll look at me like I'm saying something strange. No, and I go bzzz. It's a really good vaccine, and it's worthwhile. Here we have JE vaccine uptake rates by local government area, and quite a good uptake in Central Darling and Wentworth. But you know, the population's small, so it kind of confuses the rates. The other thing, of course, with any mosquito-borne disease is prevention. So avoid peak mosquito biting periods, dawn and dusk, wear appropriate clothing, mosquito repellent, something with DEET in it, and that's critical because we can't prevent all mosquito-borne diseases. Thank you.
Thank you so much, Victor. Please welcome Kim and Fiona now, our last presenters for the day. They're going to guide us on another interactive session on catch-up cases. Should be lots of laughter ahead, I'm sure.
No. Right, you start. Okay. Well, hello everyone. We've got the painful task of being last. I really feel like putting some music on and getting us sort of have a little dance. I might have to do that in Dubbo, I think. So, we've all got your scenarios on your table. First up, I'm just going to go through what is free on the NIP, because like people come into your clinic and your GP surgery and you're like, oh, you know, can they have it? Is it free? Can they not have it? So I'm just going to really quickly go through these slides because it's all on the it's all in the handbook, and then some things will be on the New South Wales Health pages as well. So this just lists what vaccines are free under the NIP for people who didn't receive them as children and what ages we can give that vaccine. One thing I noticed that is very confusing is the meningococcal, when kids miss out on that because, you know, AIR will say they're due for a meningococcal C, and because that's like, if we're following the rules and being really good, and I'm rule follower, you know, between the ages of 10 and 14, they're meant to have a meningococcal C. And then, you know, then we catch them up with the ACWY in year 10. So I hope that makes sense. Is everyone, people are looking at me blankly there, but call me at the PHU if you're ever confused about that. These are some additional New South Wales funded free vaccines. So probably the main ones I wanted to look at is the Hep B. But I know working in GP land, I just want to let you know that the Hep B vaccine is not free to persons outside of these priority populations. So it's definitely not free for healthcare students and for persons travelling overseas. I know we get that a lot. Victor touched on the JE, measles, mumps, rubella. I'm very passionate about anyone travelling over the age of 6 months to, like, travelling overseas to get that extra dose, and it is free. It's New South Wales funded. Just always be careful when that, because often like children, they'll be going overseas, but they'll also maybe be getting their TB vaccine too. So I'm always very mindful. Like the BCG vaccine is a live vaccine, the measles, mumps, rubella vaccine is a live vaccine, so you want to have them both on the same day, which I have done, or you need to have them a month apart. Mpox, I know I've done a day in sexual health, and that's New South Wales funded free. Rabies for post-exposure. We've talked about RSV, and then we sort of touched on that for people, vaccines for bone marrow transplant recipients. That's now New South Wales funded additional free vaccines. Okay, so now we're going to go into the scenarios.
Okay, so the very back row should have scenario 1. I know you're all enthusiastic and it's the end of the day, but we're going to run through this. So all these scenarios are based on things that Kim and I commonly see in the PHU. So hopefully this shouldn't trick a lot of you. It should be stuff you've seen. So a 20-month-old identifies as Aboriginal, born at 38 weeks, 2.7 kilos, no issues, has really only had 6 weeks vaccines and a Hep B dose at birth. Which table would like to volunteer their ideas on what sort of catch-up is required? And I'm really happy to pick a table if you don't volunteer because we all want to go home. I've got to get back to Dubbo, people. Come on. Belle's going to be nice and pick a table otherwise.
There's a bit of thinking going on.
Yeah,
still.
good. It's a really common scenario, I'd imagine, in GP land just as much as child and family health.
Anyone willing
There's no right or wrong answer in the end. Just have a go. We'd love you to have a go before you ring us with your catch-ups. Come on. Got it? Sorry.
No Rodericks. Good answer.
Yep, no Rodericks.
Yep.
So, hold on, there's a microphone right behind you. No, excellent. In the white shirt there.
It's not our table. Okay. Yeah, so no Rodericks, obviously, because of age. Vaccellis, so usually it's ×3 primary, and by now a booster as well, so probably needs 3 more doses.
Yep.
Prevnar 13, another 1 dose of that.
No, Prevnar 13, they'd only need 1 dose.
Okay.
Yeah.
I think I've got that wrong before.
That's
I've
okay.
got that one.
Another dose doesn't hurt them, right? It's
No.
just not needed.
Not needed.
Yep.
Yeah.
Bexero, another dose, because they've only had the 1. And then they need the usual 12 months, so the MMR and I don't know what else.
Lovely.
Is on the 12
Belle's got the
month
table down the back as well. Do you want to add anything into that?
Just needs a chicken pox dose as well, so with the second MMR.
Yep, great. So we need 3 lots of DTPAs, 2 polios, 2 Hep Bs, 1 Hib, 1 pneumococcal, 2 meningococcal Bs, 2 MMRs, and 1 of those will be with the varicella. Okay, so here's what a catch-up would look like if you sent that to us. We would send you back saying this. You need to give now the Hexa or the Vaccellis, Prevnar 13, an MMR, a Nimenrix, and a Bexero. That is 5 needles. That is necessary to do now to consider them to then be on a catch-up, up-to-date schedule. You're going to get them back 4 weeks later for their MMRV, then 8 weeks after visit 1, you're going to get them back for another Hexa or Vaccellis, just depending on what you've got. But you need to remember you've got to allow 8 weeks between dose 2 and 3 of the Hep B. That's why it's 8 weeks later. And you've got to remember you've got the Bexero needs an 8-week timing as well. So sometimes these schedules are a bit tricky to work out with the timings. 6 months after that 3rd visit, you then need to do your Infinrix or your Tripacel, and then they're going to come back at age 4 for their standard 4-year. So the catch-up table that you've all got, like on that pretty yellow sheet, that's the kind of thing we would send you back that outlines when they need to come back, and then you can work out the dates based on when they come back for their first visit.
Does anyone have any questions about that?
Or feel like we missed anything?
Yeah.
Yes. Hold on, microphone. It's late in the Sorry, afternoon. I- I'm probably a bit behind the schedule, but so 5, I always thought 4 was our maximum, or is that old
I did 5 often.
Yep.
Because if you get an Aboriginal at 12 months,
In fact, if you
they
get
need 4, and then we're throwing in a flu, so that's 5.
And if they prem, they need a Hep B, which is 6. And I've done that before on Aboriginal twins at 12 months. Yep. You just then have to look at making sure you have the 2.5 centimetres between your sites.
And you're using arms
and
and
legs. Yep.
But great question.
Yep. Right.
Anyone, will you move on to number 2, or does anyone have any questions?
All right.
Righto, let's
Moving
go.
on.
Okay, scenario 2. I reckon you should talk about this one because you made this one up.
I made this one up. I did not. Right. So I just embellished it. So a 70-year-old turns up at your GP practice. No record of any vaccines documented on air because the last time he had a vaccine, we weren't documenting adults on air. Yep. And, you know, he's lost his paperwork and he's new to the town. You don't have anything on him. So take a medical history. He's got type 2 diabetes, hypertension, which we all know goes well together, seasonal hay fever, and he's recently been diagnosed with arthritis, but he's not on steroid therapy currently. He's come in because he's expecting his new grandchild and he wants to protect the baby and he wants to know what he should have. Isn't he sweet?
He sounds so lovely.
Yes.
He should have Boostrix that will protect him and the baby.
Yep.
Shingrix.
Yep.
Influenza and pneumococcal.
Nice work. COVID, great. Anything else?
Yeah, sorry, we forgot COVID.
That's all right. That's the whole point of this.
Did we say pneumococcal? Sorry. Yep.
Yep. All right. So we'll go over. So we've looked at the halo principle, which we didn't really touch on much today, but we've definitely touched at previous conferences. So we're looking at his health. So he's obviously got diabetes, his age, because that gives us some vaccines that he might be eligible for free.
what his lifestyle is, his occupation. So he's, a volunteer at Meals on Wheels, so he's exposed to people who might be more immunocompromised than him. So we're going to do, he's funded for a flu, for his 2 Shingrix doses and a Prevnar 13. We are going to definitely talk about a DTPA for the new baby, but it's not funded. That's the difference. So we're definitely going to talk it and recommend it, and I would suggest he's probably highly motivated, yes.
Thanks. I was just going to say the DTPA is probably more beneficial for him.
Yes.
For the pertussis and the tetanus.
Yes.
Where not so much the cocooning strategy.
Yes, but that's his motivation. He's come in today motivated, but you're right.
Sweet puppy.
He is. But you're right, it is protective for him too.
When he's doing all that gardening.
Yes. And because he's out in the garden, we would definitely recommend the J, and he needs to look at the COVID vaccine based on his age as well. Yeah. So
Because he was born prior to 1966, we're pretty much guaranteed that he's had it as a child. Yeah.
So, but it's always worth looking at some of these patients because there's stuff we'd recommend, but it's not funded. But it doesn't mean you shouldn't have that discussion with them. Right.
Okay, we're still awake. That's good. Scenario 3, and we get this a lot. A 13-year, 2-month-old recently arrived from India, needs to enrol in school. The following vaccines were given in India. So just have a quick look at that.
I know when you look at it, you go, oh my God.
So we can see measles at 9 months. So I'm immediately going, that's,
We're like, we actually ignore that 9-month measles dose. That's the 0 dose that was talked about before.
Yeah, and then, and another thing to look at, which I haven't actually mentioned in this, but just look at where he's had his Hep B. So it's 6 weeks, 10 weeks, and 14 weeks. So have a little think.
Who wants to volunteer some suggestions? Belle? That lovely Becky Lee would like to have a chat with us. Hi, Becky.
He needs an MMRV. Oh my goodness.
Can't hear.
I don't have a nice speaker voice.
No, it's horrible. It won't echo. Stand up and yell.
He needs, see, it's horrible. It's really great. He needs an MMRV.
And he can have that because he's less than 14. Yeah.
Which is why 13 years and 2 months is important in this scenario.
Yeah.
He could have an influenza. He could have, how old is he? 13. He could have a
HPV down the front, Yep.
And a Boostrix.
Yep.
So here's what our catch-up would look like if you sent this through.
And then I didn't think about the Hep B till afterwards, so I haven't written anything about Hep B there, but his schedule was very quick, 6, 10, 14 weeks. Air would probably say that's okay when we put it on air, but I would seriously think about giving him that 4th booster dose because it was a quick pattern.
And we'll admit we don't have that on this slide.
A meningococcal C, because that's what that thing would tell us, but sometimes we don't have meningococcal C in the fridge. And meningococcal C, it's a vaccine that needs a lot of love. It doesn't coat well.
Don't end up on Kendall's slide with that vaccine.
Yeah, but it doesn't coat well above 8 degrees. So this is what we'd recommend. So definitely you said the Gardasil, which was great. The Boostrix because he's 13, and then he'd be offered the ACWY in year 10.
So you would give all those 4 vaccines in the one visit just to make accessibility.
And definitely
easy
you
for
would
him?
offer the flu, but would he be eligible for the flu? That's the thing. No.
Yeah.
No, he wouldn't be eligible. No, but highly recommend. Yep. Okay. Do you want to do the next one?
Oh, sure. There you go. We'll do a Slopsy. Here we go. Here's one that we do see a bit of. So, almost 4-year-old, 3 years, 8 months. Mum and Dad decide they're ready to enrol in preschool, but they've not done any vaccines before. So, I think the important notes here are that they're hesitant to give too many vaccines at once, so we might recommend a schedule that does 5 in the first visit, but these parents are a bit hesitant to do that. And if you enrol them and you tick they're on a catch-up schedule when you go into air, do you all know how to do that? Yep, right. Then they're actually ready to enrol in school if they're in preschool if they're on a catch-up schedule. But can the parents be trusted to come back and complete that catch-up schedule? They're the kind of things that you're weighing up in this scenario. So if we were to provide you a schedule, it would be based on the assumption that they are doing all the vaccines in one go as best we can, but sometimes you have to tweak them a bit. So thoughts? Sorry? A hexa? Yeah. Yep. You, don't be afraid, speak up.
I used the calculator that they suggested in the last slides.
Yep.
So I popped everything in the calculator and all spat out the results.
Good. Yeah. I must confess I haven't used the new one, but I wasn't a fan of the old one.
You can tell me if the calculator's right.
Yep. So the online calculator, yep, good.
Okay, so first visit was the Inframex Hexa.
Yep.
Nimerix, Priorix, or MR2, and Prevnar 13.
Yep. Mm-hmm. Then what have you got?
And then we got another visit after that, a month later.
Yep.
All right, keep going.
Yep, go for it.
Inframex IPV.
Oh, no.
Energix and Priorix Tetra.
Yeah,
okay.
They like to give a lot of needles.
Yeah.
This is the calculator.
Yeah.
I'm a bit of a rebel.
Yeah.
I like less needles.
Yep. Yeah. What else have you got? And then we'll put up what we've done and...
Then 1 month later, Inframex IPV.
Right.
At 4 years, so 2 months after that, a Hep B and an IPOL.
Right. Yep.
And then at 4 years and 4 months, the Inframex or Tripacell.
Yep. Okay. So, and that's fine.
That would
and
work.
a flu somewhere in there.
Yeah, and that's fine. And this is why we often talk about use the catch-up calculator, but sometimes it's not quite what we would advise, and that's fine. So here's what we've said they're due, which is actually what you've just said, but here's how we would do that catch-up. So we'd be doing, at the first visit, a Hexa or a Vaxelis, Prevnar 13, a Nimenrix, and an MMR, if you can get them to consent to 4 vaccines, right? So let's assume they're going to consent to 4, because you've done all your lovely communication Julie talked about earlier, and they're like, go for it. Then we're getting them back 4 weeks later, and we're doing a Hexa or a Vaxelis. It does, we admit, give them an extra dose of Hib, which does not hurt them, but it reduces the number of vaccines that you're giving at that visit, which might make the parents happier, and an MMRV. Then we've got 4 months after visit 1 and 2 months after visit 2, because this is about the Hep B timing, that you come back for a Hexa or a Vaxelis, again, an extra dose of Hib, but reduces the number of vaccines. And then 6 months after the 3rd visit, Infenrix or Tripacell. So I don't disagree with the calculator, but we've just tried to give less needles because we know we've already got hesitant parents. Does that make sense to everyone? Yep. And there's nothing wrong with doing it that way. It's just more needles and sometimes they're hard to sell. Yep.
So I was saying that if a parent comes in, I like to make sure that they have a vaccine to walk away with. Is it a good place to start to make sure that you've given them something before they walk out the door? And then refer back to you guys to see if we've got it right?
Yeah, you can definitely do that. But we've actually been talking a fair bit about this today. It's okay to say, I don't know, and I'll get back to you. And do the catch-up calculator, give us a call, and do all of that before you speak to the parents. Just say, I mean, we get them at Child and Family Health all the time, and they walk through the door and we're like, okay, give us the paperwork you've got, and we'll call you in the next week and we'll let you know where things are sitting and what you need. It's really okay not to know the answer on the spot, particularly if you're then looking at the calculator like that and you're thinking, well, I could actually tweak that to be less needles, or if the calculator says that, but they won't do that many needles at the one visit, then you need to make sure that you can book them in and schedule it and work out what diseases you're going to vaccinate them for this visit compared to the next visit. So, yeah, it's a good starting place, but I don't know that I personally would necessarily show it to the parents.
The catch-up.
The catch-ups get off the handbook until I've had a chance to really sit down and have a good look at it. Like, I wouldn't do it in the room with them printed off, just in case I want to make some tweaks. Yeah. But I'd definitely be scheduling another appointment to come back and have a discussion or giving them a call. Right down the back there. Who wants to run down there with the microphone? Go, Belle! It's 10 to 4. We're nearly done. We've only got one more to go, guys.
Oh, hi.
Do you have any sort of recommendations when parents bring in their blue books and it's in a different language? I had someone come in with all their vaccines were given in Japan. Yep. So I rang the air and they didn't want to know me, but they said I had to translate it.
There's a free translating service.
Oh, okay.
Yep, which we've actually talked about at past conferences, but we're very naughty and didn't put it up here.
Yeah.
But we'll get it included in your handouts that come at the end of the conference.
Great. That would be wonderful.
Yep.
So you've got to remember, we've been talking about this morning. AIR's just a database.
Yep.
They're not.
They're data entry people. They don't even
not
know the
clinicians.
schedule.
Yeah. So that's fine. Yeah.
Yeah, and we look at the overseas ones and we go, nope, they need to be translated first. So, and it's a free service for anyone. You don't have to do anything but give the parents the website and let them do that. Yep. Yep. Right, last one.
Okay.
Oh, yeah, no.
We've got a 17-year-old. He reports he had all his childhood vaccines except the live vaccines. He's had no adolescent vaccines. And we looked on AIR, and this has all reflected that, but he wants to study nursing.
So the first question is, why would you want to be a nurse?
No. So what does he need? Oh yeah, we've got the staff health nurse here.
As this is my bread and butter. Firstly, I would do a pathology form for MMR and varicella.
No, not at 17.
Well,
in Australia, but
let's assume he's declined having bloods done. Thank you. He's got a needle phobia.
Yeah.
He's really not going to do well in nursing.
No, he's happy to give them. He's just not happy to take them.
Yeah.
We do serology. Anyway, sorry. As per policy with New South Wales Health.
Oh my God.
Yeah. Turn a blind
He
eye,
wants to
lady.
study nursing. Remember, he's not studying nursing. He wants to study nursing. Yeah.
He wants to leave today with some vaccines in his arm.
Yeah.
What are you going to do?
Tell him to reconsider nursing. No.
I'm not the only one. Right.
All right. So if he hasn't had in his adolescent yet, he could have a HPV. He could have a Boostrix. He could have an MYACWGB, whatever it is.
Meningococcal ACWY.
That one. Yep. What else has he got to have?
He hasn't had any live vaccines.
Is he willing to have a live vaccine?
Yeah, he wants to
today?
study nursing.
Then he can have a Priorex
Oh, yeah. Sorry, I thought you were going to say Priorex Tetra, and I was going to go no, because he's over 14.
And he can have a Varilix
Yes.
or a Varavax.
Yes. Yeah.
I'm just going to throw a little spanner in the works and add a little bit to that, in that he likes to go camping and fishing. And he does a bit of social vaping because he's 17 and that's what they do. Does that add anything to what you'd like to do?
Could have a JE.
Very good. Smart.
Thank you.
Yeah.
Have a lolly off the table, lovely.
Thank you. And I can provide that for him.
Yeah. I remember with the JE, you'd have to have it on the same day as his MMR, or you'd have to have it a month apart because they're both live.
And if he's had all his Hep Bs when he was a child, he's good.
Yep.
He's good for that.
Yep. But then he'd have to come back. So he's had one MMR today, and then he'd have to come back.
He has to come back in 1 month.
Yep.
Or 28 days.
Yeah.
All right. So.
Yep. So
or he'd have to have a second varicella as well because he's over the age of 14.
Yeah. So he'd be funded for one because he's 17.
Yep.
But he would need 2 doses for nursing because he's had his first dose after 14 years of age.
Yep.
So, but he'd have to, so that's what you got to think of. And what else you said was
so funded
perfect?
for one, but needs 2.
So we would give now MMR and varicella. You'd have to give it separate because he's over 14 years of age. Meningococcal ACW, HPV, JE, and then 4 weeks after visit 1, we'd give the second MMR. And if he wanted to do nursing, he would need his second varicella, but it would not be funded, the second dose. Yeah. And what would we think about with the vaping and it's flu season?
We would advise to stop vaping.
Yeah.
Do you want this?
And
there's no vaccine for that.
No.
Yeah, unfortunately. Yeah.
If he is going to study nursing, he would need serology testing for hepatitis B.
Yes, correct. Yeah.
If you want bloods done, see Becky.
Yeah.
There she is. Sorry, we'll just.
I thought New South Wales health policy was with Hep B. I know
Yep.
they have them as
Yep, yep,
babies.
yep.
That when they come into nursing
Yes.
and stuff, they've got to have serology
Yep.
to prove if they have
Yep,
been.
and that is correct. So he would need, if
He
he
would-
actually
so if
passed
he's
uni, if he stopped
needle-phobic-
vaping and fishing and passed
Yeah,
uni and got into nursing, yes, he would need
But
serology
that's
for Hep
the
B.
hardest thing to do. Is to get them on the right track for that
Yeah,
and
yeah.
get parents to believe this.
Yeah, yeah.
Because that takes the longest to get them on board
Yeah.
to be able to do their TVETs or whatever.
But if
it
he
is.
has his MMR vaccine ×2 and his varicella
He's still not
×2, he doesn't need serology for MMR or chickenpox. Yeah, yeah.
Just
Yeah.
the Hep B component, which technically can wait until he actually gets into
To
nursing
uni.
and
Yeah.
does it.
Yeah, yeah, that's right.
And there's over this side.
We also had Boostrix on our list as well as.
Sorry, not everyone can hear you.
Oh, yeah, we didn't put Boostrix on it.
As
yeah, good.
We also had meningococcal B, given his lifestyle. and his
Meningococcal B,
age.
he would have had that as childhood.
No,
Because
B.
B.
Oh, meningococcal B.
Bec zero.
Bec zero.
Oh,
You know,
right.
you saw her on
Yeah.
today?
Yeah, I know. I had a meningococcal B on Monday.
Yeah.
It's awful. Sorry, we didn't put.
No, but we figured someone would pick up something we missed, and then we were
Yes.
going to be like, "We meant that to happen. Well done."
Yeah, yeah.
No, you could definitely offer a meningococcal B given his lifestyle. That would be a good.
Yeah,
thing
I
to
knew
offer.
we'd missed something.
Yeah,
Yeah,
guaranteed.
perfect. Well done.
Have a lolly off the table.
Yeah, yeah. So we need to change that
Yeah.
for tomorrow.
Ooh,
Yeah.
That's
yeah.
pressure. Right.
Yeah.
Excellent. Is there anything from any of those that you guys have questions about or want us to go over? Yeah, Kendall.
Can I just say, with the occupational screening stuff, it is really confusing and it is the bane of our existence, the amount of phone calls we get. So, and then, of course, my daughter's just started doing her AINs and has to do placement. And who's not immune to Hep B? My daughter. So you need serology for Hep B. To be onboarded, you need serology and the history of Hep B vaccination.
Mm-hmm.
If you aren't immune and you have commenced your catch-up, you can start.
Yes.
You only need one, then you need serology again, but that gets all confusing. MMR, you just need a documented evidence of 2 doses.
Yes.
Yeah.
Don't do serology if there's.
Don't do serology. Yeah,
if
yeah.
you've got 2 documented doses.
That's right. Because that always.
Yeah, prior to 1966 is good. You don't need anything. You just need to have that date of birth. Yeah. Yeah.
But we do get that a lot. People run serology when they've got 2 doses of MMR documented. Don't do that
Yeah.
because it just adds extra confusion. Yeah.
So, in summary, they can be complicated. Always consider the HALO principle. Refer to the handbook, AIR and US for support. And just remember that vaccines, they can be NIP funded or they may require a prescription. So allow time to do the catch-up and order the vaccines. And I hope that is it. Yeah. Okay.
Yes,
Yeah,
one more
yeah.
question. That's it.
Thank you.
know,
And you're all still awake. That's amazing. We thought
Sorry.
you'd be all awake.
I just want to ask a question about the scenario 3.
Oh.
13 years, and so no pneumococcal, is that we don't worry?
Pneumococcal?
Yeah.
We only worry about catch-up with pneumococcal and Hib until they're 5.
Yep.
Yeah.
And then there's no catch up after 5.
Yeah, yeah.
At
Okay,
all.
cool.
Thank
yeah.
you.
Yeah.
Yeah.
Oh, unless
sorry.
like they've got
Unless
medical
there's,
things,
you know-
yeah. But we said he was a normal,
Unless
healthy,
Steve says
yeah,
unless.
yeah,
and-
yeah, yeah.
But a well
Unless they
healthy
have-
child
yeah.
has no catch up.
Yeah.
If everyone's happy to indulge me for another 3 minutes until 4, Belle, are there any burning questions, very quickly, do you think that are worthwhile debating right now, flagging, before we do the lucky door prize and say farewell?
There are lots and lots of questions, and I think we are going to run out of time to get through them all.
Yeah. Thank you, everyone, by the way, for those questions.
Yes.
You
So
know,
there was a few questions about travelling and MMR vaccine and the extra dose we referred to as 0 dose for the 6 months, and what the funding might be. So Arch, did you want to expand on that a little bit?
you can join me up here, Arch, if you want.
So are community health clinics funded to give the 0 dose of MMR for a child at 6 months?
Yeah, so it's just an additional dose and it's free in New South Wales.
MMR and varicella back before 12 months for travellers. Just wondering the recommendations, and it's funded.
Sorry, what was that?
MMR and varicella back before 12 months for travellers. Oh, that's not making any sense. If the person's in the room, do you feel brave enough?
The varicella vaccine, you give it above 12 months of age. So if you're traveling and they want it and they're above 12 months, then maybe you could give it. But it's not so imperative. They can get it. They can come back and get it with their MMRV.
And the travelling is for outside Australia, isn't it? Not within Australia.
Yeah, it's for outside Australia.
Yeah, thank you. Has anyone got a burning question that they want to grab the mic and ask? Because there are so many here, it's hard to pick.
This isn't a question, but it's just an FYI for all practice nurses and anyone thinking of joining New South Wales Health. As per policy, Shingrix does not, thank you, is not accepted evidence for varicella. So if someone comes, they can't have a Shingrix if they need a varicella vaccine.
If a person had natural wild chicken pox, do you still vaccinate? Do we need to update AIR, so not overdue?
If they've had chicken pox, there's no need to vaccinate with the varicella vaccine. You can do a tick where say you've had natural immunity. Does everyone know how to do that? It's a form that you submit to AIR. Dee does it fabulously. She always helps me out. And then what was the second part to it? Sorry. Oh yeah. And then if they've had chickenpox and they're 18 plus and heavily immunocompromised, or they're above 70, they need Shingrix. Because it's people who've had chickenpox that get shingles.
I think we've got to do the lucky door prize.
All right, cool.
See ya. And while Belinda goes and gets the blue box for me, Belinda, if you could do the honours. First, join me in a round of applause, please, for the speakers today. Thank you all. Okay, so there are going to be 4 prizes, 1 to 4 in order. Prizes are behind me. Ready? Drum roll. Number 1. It's orange or red, depending on how you look at it. A91. A91, front row. Yeah, come on up. Prize number 1. Okay, number 2, left hand. Right.
I've got to mix it up.
Okay, another red. A03. 3. That's 03. Adjudicator.
No, I think that's 0.
Just want to make sure. It's 3. Yes. Yep. Come on up. Number 2. Okay, number 3. Here we go. Number 3. Okay. Red again, 17. A17, yep. Well done. While you're making the very long walk up to the front here, just a reminder, evaluation. Your feedback is highly valued. Please don't forget to evaluate. Information is very valuable to the planning committee and the PHU and the presenters. Okay, lucky last, number 4, red, A6. 06. Anyone with 6? Yes, in the pink? Well done. So thank you all for attending today for yet another year. Thank you, presenters. Hope you all enjoyed each other's company and we look forward to seeing you again next year. Ciao for now.